It was actually more than 62%, only 67%. I think if you actually did this with a greater percentage of imaging, you would have seen a difference, potentially not statistically in the advantage of orbital atherectomy. So even with negative trials, expensive, long negative trials, we learn that imaging is still vital, no matter how many 30 randomized trials we have to say that. And for the most challenging cases, if you think you need atherectomy, do it. You have IVL now, you have laser now, and you've got specialty balloons. The long-term outcome for the patient is what's most important. And however you need to get there and whatever you're most comfortable with is what you should utilize. Thank you very much.
Thank you. Those are some very insightful comments about some of the randomization things that don't show up in the print.
All right, so we're going to move on. So that you've heard now laser, you've heard calcium, you've heard IVL, and then last but not least, John is going to talk to us about calcium management with rotational atherectomy.
I could almost start with my conclusions by saying that all the modalities that you've heard today, you have to be facile with and be able to move seamlessly from one to the other depending upon the situation. I think my case at the end will be illustrative of that. Calcium, no doubt, we've heard from the very first lecture, is the real conundrum. As we get older, more diabetic, there's more calcium. As we have people who have come back with bypass, resurrecting basically the native circulation, that's mostly calcified disease. 30% of the population at least has calcium, and those outcomes are clearly much worse. The clinical outcomes have been summarized in a number of meta-analyses. Here you can see one of them that shows you that the death rate, MI, TBR rates are all significantly worse in the setting of calcium. So in a referral population, like the one that we see in our institution, what I look for is not only the lesions, the sites, et cetera, the need for support, but how much calcium do I have? That's the next thing on my list. Optimal stenting is really not possible in calcium, not without this type of modification that you're hearing about, for all the reasons that have been expressed in terms of delivery, expansion, optimization under guidance. In fact, if you look at the degree of stent expansion, this is at 16 atmospheres, but it's been done with 20 atmospheres. There's a correlation with the arc of calcium in terms of the lack of stent expansion. And the more the arc is, the worse that expansion takes place, as you can see on the right side. So, rotablator, what can you say about it? I was fortunate enough to train very early, but at the first year that rotablator was used in the United States in 1990. Anything that's lasted over 3 decades, basically, is probably a pretty good tool. So you certainly have plenty of information surrounding it. It is one of the major reasons we can apply our type of stenting and practices, optimization, is because we have tools that can now handle calcium to a much greater degree. Its principles haven't changed. It's the orthogonal displacement of friction. It's often been referred to more appropriately in degrees of celebration of popping a wine cork. If you can twist it rather than just pull it, it'll come out a heck of a lot easier. It also has differential cutting. So just like shockwave predominantly affects calcium, actually rotablator goes more generalized than that. It will cut anything that's inelastic. You heard yesterday comments about using it in very severe ISR, like those post-brachytherapy or ISR that's been there for many, many, many years, which is difficult to balloon, and even with a specialty balloon, but it was something that might be amenable to rotablator. So elastic tissue tends to recoil, normal healthy tissue that is, and inelastic tissue does not and will stand up and get cut. This is probably the best demonstration, an eggshell, somebody holding this, so we'll take a rotablator burr to it, and even though they're holding the burr with their finger, the eggshell predominantly will be cut, and hopefully not the thumb. David Auth, who was the inventor of the rotablator, used to love to do this on his tongue. So he would show he could cut calcium on the eggshell, and then he'd put the rotablator to his tongue. I don't recommend this, but basically his tongue was usually elastic, and it reflected the burr without hurting him too badly. Particulate size is related to the diamonds that are electroplated on the surface of the cutting edge, and so therefore, in optimization, optimal therapies, and optimal technique, you should have particles that are fairly similar to those edges. And in this case, The 5-micron beads are basically similar to that of a red blood cell, but obviously doesn't have the same sensibility as a red blood cell. But that's the sort of things you should get. So when you're looking at an optimal technique, you basically want to conservatively burr size this. Back in the early days, we would maximally jack this up to 0.75 of the reference vessel, but you really want to do 0.4 to 0.6, no more than that. And the most likely burr is going to be a 1.5 burr. Advance the burr no more than 3 centimeters back and forth. It is completely different than orbital atherectomy, as we've heard, which is a constant maintenance at the site and getting optimal cutting that way. This is a pecking motion. It's in and it's back. It's in and it's back. People will tell you, don't let it drop more than 10,000 RPMs. Don't wait for it to show up on the tachometer. Listen, you'll hear the decelerations before it shows up on the tachometer. So it is an auditory as well as a tactile procedure in terms of optimal strategies and techniques. The target platform speed is listed as 140 to 150. That's to minimize heat, platelet aggregation, spasm, things like that. But I will tell you that I routinely violate that. Okay, that's what's recommended. And I violate it because what I'm looking at is really dense calcium, high-grade calcium, long calcium, and I'll never get through at those speeds, at least not in a reasonable time. So 180 is usually where I start with on those types of things, and not unusually go up to 200,000, but there are risks with that. Again, I'm very acutely tuned to decelerations. I don't want to pop through all of a sudden, having too much pressure, not paying attention to those decelerations, and suddenly I have a stall, or worse than that, an entrapment as the burr goes through the other side. Limit your runs to 20 seconds. Leave some real periods in between. Stop, take a listen and see what's playing on your playlist. Just cool out for a little while and let everything dissipate downstream, because you don't want to overburden the microcirculation, which is going to lead to slow and no reflow as the particulate matter can get clogged up. Let it clear out, let it work its way through before you go on with your next run. Total procedure time should really not exceed 5 minutes. And I'll show you one where sometimes we have to be violated that way, but that's way we don't just, we think that if we can't get through in that time, there should change your approach. You may downsize your burr, by the way, if you haven't done that, if you haven't gotten through in that long time. Upsizing the burr, an undilatable despite RA, you can go on to the next level at 0.25 centimeter increments, and finishing with a polished run. Again, there should be no resistance whatsoever, no sound of an RPM drop, no resistance whatsoever. So assessing your calcium first. I always like this because it says, oh yeah, just assess it, see what it looks like. You're not seeing calcium. You can see the calcium. You're not going to be able to assess it before you do anything because you can't even cross it for the most of the time. So imaging and assessment of calcium is most likely going to be taking place after you've done something first, like an atherectomy or a predilatation balloon. But when you get more of this arc involved, as we'll see on OCT, the thickness, the lengths, the vessel diameters, you get to a point where you develop a calcium score for each one of these elements of 2 to 3. We know that there's better stent expansion. So if you don't see it already or don't realize it already, you can use these elements to direct you towards calcium modifying techniques. That was for IVUS, OCT, the same thing. The difference, of course, is that OCT can see through the calcium, so you can actually get a thickness and use that as a quantifiable element in determining your calcium score. Again, same thing. If it's 2 or greater, you start thinking about modification for the calcium. Now, this looks pretty overwhelming, but it's pretty simple, actually. Whatever your imaging tech strategy is, OCT or IVUS, check to see if it's deep or superficial. You don't need atherectomy devices for deep calcium, but IVL penetrates both superficial and deep, so that's a good strategy for that type of calcium. If it's superficial, you can go through the scoring process, but what it really comes down to, does it cross or not? We've heard some nice beautiful presentations on specialty balloons and IVL, but they don't help you. They don't cross in dense calcium. So it becomes very simple at that point. That's your bifurcation component in your algorithm where you have to move on to atherectomy. And so that's what this really basically comes down to. Non-crossable or can't cross with your specialty item, whether it's a scoring balloon or IVL. If you can't cross, you got to move on to atherectomy. But always identify that you have fractures. Make sure that you've seen the result of this. And this is where imaging becomes the most important part, because functionally, as I said, you can't cross these lesions to begin with. Clearly differences, as we've seen, between rotational and orbital atherectomy. I'll give you my sort of preferences as to when to use what, but 80% of these, 90% of these, there's overlap between the two. I think, it's what you're comfortable with, really, what your lab comfortable with. Generally, most people don't have the luxury of being really proficient in both of these in the same laboratory, so you use what's best for you, because that's when you're going to get the best outcomes. There, as you've already heard, mentioning the rotablator as a front cutter, I view this as producing a pilot hole, as any carpenter would, producing a pilot hole before they put something else in to expand it, and it cuts very well in that situation. You can see the target lesion openings, most of the time, as I said, a 1.5, rarely a 1.25 because of the problems with entrapment. A real severe disease that might be on an angle, I might use a 1.25 so as not to gutter too much or risk perforation. And the circumferential cutting that we see for orbital, completely different. Not so much cutting in the front, but it's a great sander. So if I have a lumen there that's that's already there, I might as well go ahead and switch to orbital to grind the rest of the calcium down, because that might do a better job than rotablator by being its ability to use a rotational mechanism. There's a very small trial that looked at the comparison between these two. Clearly, it has significant drawbacks because of the minimal size. But looking at rotational atherectomy versus orbital atherectomy, the stent expansion that was seen between the two seemed to favor rotational atherectomy. There's probably some selection bias in how these lesions were chosen, but there is some modest data suggesting that that's the case. And the maximal tissue modification area was also greater for rotablator than orbital atherectomy in this very small trial. That's the summary that significant greater stent expansion was obtained in the RA group and greater tissue modification without sacrificing complications, dissections, perforations, tamponade, etc. So let's have a representative example in the last few minutes here. This sort of brings in multiple elements, and I think it expands on something that we saw Dr. Grantham use yesterday's wonderful CTO case, that you've got to move in accordance with what is being presented for you. What are your hurdles? It's never straightforward. You go in with plan A, you have a plan B, but sometimes, as you said, you got to go to D, C, E, and F. So here's somebody with a 67-year-old CABG in 21. Obviously didn't get a whole lot of use out of their CABG because they've got some grafts that are occluded except for the lima to the LAD. They've got a CTO with a right coronary, who is thought mostly the culprit. And there's an occluded stent in the PDA with collaterals from the LAD. And the occluded stent, of course, brings up the issue that you're going to have a hard time going retrograde on this one. It's going to have to go through a lot. So here's a dual injections. The CTO is right at the ostium. Have trouble with an AL 0.75, really kind of giving us a coaxial alignment, but we can see that everything sort of fills backwards reasonably well. Here's your RAO projection. So trying to penetrate this turned out to be very, very challenging, because there's no way to provide yourself with backup and support when you're really working at the ostium. Had to use a very stiff penetrating wire, like a Judo 6. It gets in there a little bit, but you can see the catheter is backing out. Makes it very difficult to advance it any further. But after about 30 minutes of work, was able to get it down here. So better to be lucky than good. And you say, well, okay, the wire's down, case should be almost over. There's a problem. Can't get anything to go. Microcatheters didn't penetrate. Tried 1 and 1.25 millimeter balloons to kind of soften up the beachhead a little bit, and nothing else is going on. So what can I do in this particular situation? I've got an 0.14 wire down, but I can't get a microcatheter down, and all my balloons won't advance and or rupture at the point of insertion. What's the only device that's going to go over an 0.14 wire? This is where you have to go to a laser. And you've heard that in a beautiful presentation with using contrast, we can get that sort of shockwave type effect and work on it with a laser at that site. But it doesn't work, or seemingly doesn't work. This is after about 8-10 trains on the laser. I don't have any other choices here. I got to keep going. So keep going, and ended up using 38 trains of laser. And somebody said, why 38? What was the magic number about that? Nothing magic. The laser stopped working. We exceeded the device's capabilities. So, but it did fracture things enough to allow for a microcatheter. Swap out, balloons don't pass. So once again, another hurdle, your algorithm you go through, what should I use at this particular point? Well, I've got a wire down, and that's the benefit. Now I can use a specialty wire. And sort of going to my preference that I have dense calcium that's really, really subtotally occluded over a long period of time. This one is, I believe, is a much better opportunity to use a rotablator. So 1.5 millimeter goes through it. Don't use 140 or 150, 160. Go right to 180. You're just going to be wasting your time there. And that allows us to get through, and I'll skip over the details in between, but your Guidezilla, IVL on top of this. I do a lot of atherectomy and IVL. If I can get IVL down there, that's great. I'm fine and happy with that. But most of the time I can't, and I have to do an extensive preparation to get to this point. So that's the overall results. So complication management, if you're going to use these, you got to be able to deal with it. We've talked about small burrs, low speeds, etc., being very meticulous and allowing it to perfuse, dissections that can occur. Most of the points at tortuosity, you get dissection. But if you're cutting into the tissue and you couldn't cross it or dilate it, that's not so bad thing. That's going to clearly change the hoop strength and allow you to get a balloon there and dilate it and hopefully move better from there. Entrapment, as we said, you've got to be careful about allowing it to pop through and get caught on the way back. The next generation rotablator will have cutting edges on the proximal edge, so that should not be less of a problem. And there's no doubt that all atherectomy devices carry some risk of perforation. IVL, when comparison to all these, really had almost no perforation. It wasn't with the IVL balloon. It was the subsequent post-dilations after IVL. So in summary, I'll say that where do I use rotablator preferentially? Well, I take advantage of its assets. It's a front-cutting diamond trip burr. It goes in much faster speed than anything you have out there. So that's a huge amount of power. What attributes, what lesions would benefit from these attributes? Things where balloons are not crossing, they're not expanding, but I can get a wire across one way or the other. You probably don't, if you can cross easily with a balloon, you don't need rotablator, right? Just go ahead and go right up to your specialty balloon, or more likely you're going to end up using something like IVL. I frequently go to high speeds, 200,000 occasionally, but at least 180 because of these extremely difficult resistant lesions. There's no doubt about it that you need something there because nothing else is crossing. This is the only thing you can use that's going to get you there and open up the channel. Caution on tortuous segments, anything more than 45 degrees, extremely cautious, would never use it unless there's absolutely no other recourse. But that's the one that's going to cause problems as far as severe dissections and maybe perforations. So the more difficult it is to get a wire across, and certainly to get any exchange catheters out, the better opportunity it is for rotablator. Thank you very much.
All right, now that we've really gone through all of our plaque modification techniques, we've got a live recorded case, heavily calcified disease from Jazz. Jazz?
Thank you, guys. Excellent session on calcium. So we're going to close this session out with our live case, recorded case. Let's see.
All right, welcome everybody. This is Jazz Singh at Barnes Hospital, WashU in St. Louis, and I have a pretty interesting case today. And I have my team here today. Is Prashant Thakur is the attending physician here. Jeff Tran, he's our interventional fellow, and Jenna and Amanda are our nurses here. Hannah is a nurse tech in the control room. And I'm gonna hand it over to Jeff, and he'll present the case, and then we'll go over stuff.
Thanks very much, Dr. Singh. So, yes, we have an interesting case to present to you all today. If we go to the next slide.
Next slide, Jimmy.
This is an 80-year female. She's actually had a history of 2 AVRs in the past. The first one was some time ago. She had a mechanical valve. Unfortunately, she had valve thrombosis, and so required a second valve, at which time they put in a bioprosthetic aortic valve. She was doing okay, and then she's been developing progressive chest pain and had a much significantly increased degree of that chest pain, and so presented to an outside hospital where she was found to have quite marked triple vessel disease, as well as significant MR and TR. And she was referred here for a surgical CABG and MVR. Unfortunately, due to prohibitive operative risk from frailty and a third lifetime sternotomy, they elected to have us do percutaneous coronary intervention instead. So outside of her past AVRs, she also has a history of a remote stroke and atrial fibrillation. She's got diabetes, on home insulin, and she has factor V Leiden. Her labs look very good. Her hemoglobin is 12. Her creatinine is 0.84. Her platelets are a tad low at 88. And the echo for her, her ejection fraction is normal at 70%, but she does have significant mitral regurgitation, which is secondary to A2 prolapse. She has severe tricuspid regurgitation, possibly due to lead impingement, and the bioprosthetic AVR seems to have either a high flow state versus patient prosthesis mismatch. So let's go ahead to the next slide where we can show some of the diagnostic films done at the outside hospital. So first this is just a illustrated picture of her cardiac function as well as the severity of her MR. We see it's very significant eccentric, and again, that's because of an A2 significant prolapse. So if we go on to the next set of images, this will be the coronary angiogram. So first, let's just focus on the left main. We see that there's distal left main disease involving the bifurcation. So she has true bifurcational disease with Medina 111. Here, it's quite easy to see the extent of the distal left main and the circumflex. If we go to the next slide, we can, we'll see the extent of LAD involvement in a moment, but here we see more of the circumflex involvement. We see that the first OM actually is a series of tight lesions outside of that initial ostial lesion of the left circumflex. It is likely a left dominant system. We go to the next slide. Here we can see the LAD, or I'd like to focus on the LAD here, especially on the image on the left. You can see a severe ostial left LAD lesion, as well as likely a lesion a little bit more into the proximal early mid segment. Go to the next slide, please. And here we see the non-dominant RCA. So we have calcified true Medina 111 left main disease. And we are planning to do an Impella-supported atherectomy of that left main disease.
Okay, so I'm gonna stop here and pass it to the panel. And any comments as to how you would approach this case?
Yeah, it seemed a very tough case. I want to check the intravascular imaging at first at the proximal LAD and check the degree of the calcium and change the strategy.
I assume that for this patient, he has performed 2 times of AVR. How frequent in United States you perform a second AVR? Because in China, we seldom perform a second time AVR or CABG. Or for this patient, if he has 2 times of AVR, is it possible for him to do a CABG?
Yeah, no, he was referred for CABG, but because of the sternotomy and because of these things, and there was reasons we don't know. She was referred from an outside hospital. So you were right. I mean, normally now, we don't do second surgery or third surgery. So we don't really know the history from previously, but she's had sternotomies, and so the surgeon really wanted to look at all the stuff, and he showed me the pictures and said, listen, I don't think I can get her through surgery. So that was the rationale.
Yeah, she had an AVR, which was mechanical first. It fails.
Right.
Bad. And now you're down to a biologic. Everything else after that would have to be TAVR related. And obviously her P2 prolapse is going to end up being percutaneously addressed as well. So everything on this person, you're going to have to be doing percutaneous, starting with the coronaries.
So, approaching the coronary disease, what are you thinking? Hemodynamic support or not? It's a left dominant system, right? Is virtually very, very small. Left dominant, left main, very calcified, subtotal lesion in the mid LAD. Do you guys, ejection fraction is normal, but do you guys, bioprosthetic valve, do you guys think about hemodynamic support here?
Yeah, look, this is a great case. First of all, the coronary anatomy, as you guys discussed, it's very important to understand the nuances, the left main bifurcation, the angles of it. There's proximal mid-LAD, there's proximal circumflex. I think syntax score is a little bit higher than you guys calculated, but this is a perfect patient which is left dominant, and most likely because of the calcification, you will end up doing some calcification therapy. Plus, you have severe MR and severe TR. I think that, to me, probably will increase the risk of PCI in this patient substantially, whichever modality you use. And that would be a great case to use MCS upfront, even though the EF is normal.
Yeah, I'm going to recuse myself because, I know about the case a little bit, but that's an excellent point that you don't necessarily have to have a low ejection fraction as a prerequisite for hemodynamic support. It all depends upon several things, which you've mentioned, and that is the propensity to decompensate. And with bad MR and TR in combination like that, it could be very high if your ischemic time is going to be long. And if you're going to be doing atherectomy, because both of those things, complex PCI, left main, other disease, as well as an atherectomy, will increase your ischemic time, and that's what it comes down to.
Yeah, so that was our rationale is, patient ejection fraction is normal. We talked about it the other day. It's called preconditioning. With this coronary disease that you saw and patient didn't have valvular disease and didn't have good reserve, you're actually okay. Patient will tolerate the procedure pretty well. Problem becomes is when you have either hypertrophic cardiomyopathy, you have this kind of valvular disease, or you have severe aortic stenosis, or you present as acute coronary syndrome, because that hasn't let the heart have time to get preconditioning. And those are the scenarios where patients' blood pressure goes down. Like I play with the fellows all the time. I said, leave the balloon up in the left main, see what happens. So the pressure drops slowly, and then as soon as the balloon is down, pressure comes back very nicely. So the recovery is so quick. These patients with valvular disorders and stuff, they really don't bounce back. And if they stay down, they usually stay down. So you get yourself in trouble. You don't have time. So this is where we thought it was a prime example of hemodynamic support.
Yeah, the questions become the ejection fraction is normal. What shall we do? Is the whole circulation is dependent. So very calcified and then very high grade mid LAD lesion and an obtuse marginal lesion. And the question is, do we need support or no? And that's the question that you always ask. If patient ejection fraction is normal, they're preconditioned, you actually can get away with it.
I'm going to go a little bit further here. We already talked about it.
This should help us.
So
I don't
it
think
shouldn't be a
this is-
contraindication if you
No.
need a, okay, good.
No, I don't think so. I don't think there's a contraindication in this setting.
Nobody has a better right to interrupt Jazz than Jazz.
Yeah, the decision making whether to use support and stuff, we can talk about it in calcified lesions, but we'll discuss that with the panel here and figure out really how people use what is.
So this is a bioprosthetic valve, and you think it's easy to cross? It is so difficult to cross. Boy, we struggled with it quite a bit. I thought, oh, it's just easy. We'll put the impeller through. You see, very, very difficult to cross.
Jazz, do you know the diameter of that valve? Because that's what's making it tight.
Yes.
This is a 20 millimeter valve. It's going to.
Yes. It was really bad.
The rationale for them. So this actually, the prolapse technique with bioprosthetic doesn't work. Just try with a wire.
What?
You have an emerald.
Third
in
floor
this one,
cover.
Trademark J-wire. We get a J-wire, please.
What is this?
Just emerald.
Yeah, that's not gonna work.
Can we get a starter wire, please?
I was hoping it would just go, but
So
We have one.
we took a stock wire, I straightened it out, a straight wire, and then, we were able to then cross it. And then you'll see here, we went in there, and then we put a impeller in there pretty nicely. It went very nicely. And then we took pictures here, you'll see I'll just jump. And now you can see with a guiding shot. So I just want to, we have single access on the right groin. And through the Impella, single access at 2 o'clock, we use micropuncture kit. And then we put the micropuncture sheet and put in stiff wire. And what we do now is a lot of times when there's tortuosities and stuff, and we need a bigger lumen, 7 French guide catheter through the Impella sheath is hard to manipulate a lot of times. So what we do is you use sheathless guide. So sheathless guide is actually made by Asahi, the O guides, and they actually torque beautifully, and you only need a 5 French hole, but it gives you a 7 French guide. So it's pretty neat. So we've actually done so many cases now with that, and that makes your life very, very easy. So when you are doing single access, think about sheathless guides, because those are really amazing, and we've done several of them now, and I think that makes your life very, very easy.
Yeah, we don't know if it's the same or better than having a companion sheath, which is now the dedicated sheath for Impella.
Right, absolutely.
But absolutely, the other sheaths are miserable to work with if you have to torque a great deal.
Yeah, and the sheatless guides are amazing. We use it a lot from radials. When they sit, you use the wire to actually navigate it, and then when they sit in the left main or the right, and they hardly ever move because it's all so much support. So it gives you a lot of support and what makes your life very, very easy. So that's one of the tricks here. So I'm going to show you the angiogram here.
Going through this with the stuff with left main, making it ischemic, even though we have Impella, you're going to fibrillate patient. You don't want to do that. So we're just going to treat the LAD ostium, and then the mid-LAD calcium. We'll probably do CSI. I don't think Shockwave will cross this primarily. And then plan is to try to fix the mid-LAD, stent it, and then work on the bifurcation with Shockwave, maybe from left main into the LAD. So IVUS won't cross here. So our job right now is to wire this thing LAD first, and then try to see if we can do CSI. So let's set up for CSI, guys. What was the ACT?
And then they gave 2,500 after, so we're good.
Okay, and then we're gonna get 2,500 every half. Okay, perfect.
Jazz, as we talk about modalities for atherectomy here, why would you choose CSI over rotational atherectomy?
Well, I think rotational will work. The left main is pretty big. So what I'm thinking about doing here is, we're not worried about pacemaker because she already has a pacemaker. So one thing, it's a big vessel, so that's why I'm choosing CSI, so that we can get a little bit more mileage in the left main also. And then the mid part of the LAD. Mid part of LAD will be difficult to cross.
So Jazz is essentially saying what we just said in our lecture.
But I think
It's not super high grade tight, it's significant, but it's not like you're going to have trouble getting a balloon across it. So CSI is a good one for this.
So the key with these kind of things, Shockwave won't
And
cross.
those left main bifurcation focal calcifications are very typically nodular, and they are very annoying. And I think there may be inherent reason to pick CSI, which may do a little bit better job in theory versus rotation, to consider that.
Yeah, there is theoretical benefit in CSI, also in bigger vessels, and also in deep calcium. And if you do CSI and you look at animal studies with calcium, you actually change the compliance of the vessel. So it actually works very well. So that's my bias in left mains usually. And I feel sometimes, if you don't have hemodynamic support or whatever, that this is the way it orbits. It allows blood flow to continuously do. It's not really occlusive. So it really, patients tolerate it theoretically better. So that's my bias usually when I do big vessels in the left main. But rotational atherectomy, people who are experienced, as like John said, whatever you are comfortable with, learn how to do it and learn how to do it well. It works very, very well. So we are doing CSI here, and I'm just gonna go for the sake of time, and you'll see we engage the lesion. You pull back a little bit, and then you go and you play your music, and you think about it, is 1 millimeter per second erasing motion. And you see, very patient. Every atherectomy is a patient procedure. So you always tell yourself that I'm doing atherectomy, I'm going to listen to the music, and I'm going to be very patient, like John showed his case. You got to be patient because the complications that happen is when you are not patient. So it's very important. So we did CSI here. Then what we do is glide assist into the mid-LAD. And then mid-LAD lesion was difficult to cross. But we were able to cross it.
So I think another good point here, Jazz, is that you're working distal to proximal. You're worried that you got a left main bifurcation lesion, and many people say, I got to fix that because that's where all the ischemia is coming from. But in situations like this, where crossing that lesion is not going to produce ischemia, it's better to go after the higher grade lesions that are distal like this.
When we take it out, we always glide assist it, right? All right, go. Okay, hit it good.
Yeah, so we usually glide assist, not
you see
glide
now,
assist when you
distal
go
part is
in,
good.
but when you come around the guide
Very
curve,
nice.
then you start
We have more
glide assist to go in because the wire moves a lot when you glide assist when you're going in. But when you're coming out, then you use glide assist. It helps you. So you can see here we have pretty good luminal gain.
It's a very patient procedure.
And,
very patient. So
And then we'll show the next thing we do is now is what we do all the time is if initial IVUS catheters, initial things don't cross, but you did some kind of plaque modification, the next thing you do is never do definitive therapy without imaging in this scenario. So the next thing is to image, understand what's happening, understand what kind of calcium it is, where it is, and then what you're going to do. So we can guess every minute. We say, well, I'll fix the mid-LAD. We're going to choose a 3-0 stent, and then we'll do 2-stent technique or 1-stent technique and stuff. So it's really imaging in these scenarios has shown data-wise, we saw today, is really very, very beneficial.
Very patient procedure, very, very patient.
All right, let's see it.
LED, okay? Get a 3.5 shockwave. And then the circ, if you look, this is LED?
This LED. I'll get you.
Okay, let me just measure the LED real quick.
No, to go to the first run then.
Yeah, I'll just measure it here. That's proximal.
3.5. Yeah.
3.4. So I'll go to the first run here, guys. We did 2 runs. So you'll see here. That's the LED calcium that we saw in the mid portion. And then we come back here. That's the bad complex area. So when we start recording, remember that's what we broke here. So if you see here, that's fracture of the calcium that we did with the stuff. So that's all broken. And then you come back proximally. And you see here, that's the calcified area. It's hard to size here. It's 3.9. And then this is a true size. Actually, you go from no plaque to no plaque. That's about 3.2. Then you do here, you can't see where it's probably 3.2 in that area, and the proximal part is 3.5. So we'll shockwave left main into LAD, and then I'll show you the circ. Circ actually doesn't need much at all. Where is it?
3.
This one,
Yep.
yeah. 3. Go ahead and take that shockwave, guys. So you see, you'll come back with the circ. So the circ actually is broken in big vessels, so I'm not really worried about it. We'll shockwave in there. We can actually take the same shockwave into the circ real quick too, and use both in one, and we should be good to go. You know what I mean?
Yeah, no, I agree. And my question was going to be, in if you're looking at calcium angulation, if you're going to use the same shockwave balloon twice, what is your consideration? What vessel do you want to use it in first? What are you thinking through?
Well, the thing was, so I'm gonna go back, and I don't think, yeah, right there. So that's actually distal left main going into the LAD. So most of the calcium is actually in the ostium of the LAD and distal left main. We thought when you looked at the dominant circ on the view, looked like most of the calcium was in the circumflex. It actually wasn't. So it's actually little nodular stuff, and it was broken stuff, calcium, and it wasn't not even thick calcium. So like John showed the algorithm, those things actually expand very, very nicely with balloons. But the area that was distal left main and proximal, the CSI actually went through it very nicely, but actually there was not much fracture at all. And it was such thick calcium. The mid area was all fractured, was very, very nice. So that's the rationale that we looked at that thick calcium from left main into ostial LED. We decided to do the shock wave, and the proximal area was 3.5, so we took a 3.5 shock wave.
I mean, great representation and how important it is to image midway. Just don't wait for the end of it. You've got so much more information and things that you didn't anticipate. You almost always find something that is different than what you were anticipating just based on that angiography.
So yeah, so we did shock wave up to there, and then you will see here, then we stent the mid LED. And we had very good expansion of the stent in the mid LED. Then, looking at bifurcations. So what do you guys think in bifurcation here? How would you approach the left main LED bifurcation and circumflex?
I think that's going to be the key decision to make at this point, the second or the third key decision. Before I get to that, I just want to emphasize that sometimes with all this atherectomy, whether it's IVL or ROTA or CSI, you do not have to don't always have to see macro dissections. There's often micro dissections, which will continue to make your vessel more compliant. And this is a great example of that. I think you got great angles. The calcification, the nodule is mostly very, very focal and not the biggest space occupying where the LED ostium, as you showed. The angulation is more than 70 degrees, which is kind of the rule of 70, where you can probably consider doing either a T or a modified T, whatever you prefer. I think that would be a great option. And the fact that you're going to shockwave IVL both is going to be very important. I always like to leave a large amount of stent, especially an expandable stent in the left main, to do a great parts. I think that's something I've always learned over years, that those large 505, 5NC are not come in very, very short lengths.
Again, we're learning from the Europeans and the Asian populations as well. You've got all the options for this bifurcation, but you can actually do crossover and it becomes a little bit expensive, but do DCB after you've prepped the ostium of the circ, and do DCB and leave that way as well. That's being more and more applicable with a provisional one stent technique. So multiple options here, Jazz.
Yeah, the key is you have to look at this and say, well, listen, there was calcium, but not that thick of a calcium in the ostium of the circumflex. A lot of times in the LED, there's a big mismatch between left main. Left main is close to 5.5 millimeters, and the LED is 3.5 millimeters approximately. So you have to think about stents, you have to think about deformation, and you think about circumflex. Do you need to stent it, or can you just leave it? And the problem with calcium is, and if you look at the definition criteria, really, calcium is your enemy here, and the angle is unfavorable when you sew. So a lot of times when you stent from left main into LED, you can shut the door to the circumflex and get yourself in trouble. So then when you look at bifurcation within itself, this is a high risk bifurcation. So that's the reason why we actually decided to do two stents. And when you do two stents, you think about whether because of the mismatch, because of endothelial shear stress and angles, we actually decided to really stent from left main into circumflex and stent the ostium. And so you'll see here, what we do is a technique that I developed actually, which is very similar to DK crush, but it actually has about 4 steps less than DK crush. And it's called Jail Stent Balloon, and we're just about in the process of publishing it. So what we do is we put a stent here from left main into circumflex. You'll see right there. So we put a stent from left main into circumflex and a stent at the ostium, and you mark the ostium on IVUS. We just want to make sure exactly where the ostium is on IVUS, and then we put a stent. So what we do is you deploy the LED stent, and then you pull back that stent balloon proximal to this stent. Leave the stent balloon behind. And then you deploy the left main into circumflex stent with a balloon behind it. So what happens is, actually we studied this invisible heart, is when you go to 20 atmospheres in the circ, left main into circ, high pressure inflation, you then deforming that LAD stent, and people think that you are crushing it like this. You actually doing a little bit of that. A lot of time you actually longitudinally pushing it where it needs to go, right? So what you do then is you deploy the stent, left main to circ, leave it there, the stent balloon, then you inflate and correct the deformation you just did with that balloon that's behind it. It's like a very quick step of decay crush. So you are correcting the LAD, but you're deforming the left main stent, right? So then take your balloon out and reinflate your left main into circ stent, and it gives you pretty much as beautiful as a bifurcation you'll see, invisible, and there's not much overlap of metal and stuff, in which I'll show you here.
Jazz, quick comment to how did you change your approach because you've got a left dominant circumflex?
Yeah.
Longitudinally.
That's why you're favoring that as the
Yes.
main vessel.
Yeah, so you see the balloon is trapped behind it now, and you can see we use the Sync Vision device detection. It really tells you how you're deforming the stent and how your balloon is inflating. So then you have a balloon trap. Now I'm recorrecting the deformation. Then I'll take it out and I'll reinflate the left main circ stent.
Now that I've corrected the deformation, I'm going to take it out, this balloon out, and then I'm going to leave that wire in there, and then I'm going to correct my deformation from the stent balloon as we did before. So I'm going to do 18 here. So pretty nice. So what are we going to do now? Approximately optimize it to 5.0. Then we'll IVUS it, make sure we have did it. You never want to cross from the left main into the LAD if you don't know that the stent is fully expanded. So IVUS always, then you recross. So what we're going to do now is proximally optimize it, pull the other wire, and then, take the balloon down, then pull the other wire so that we don't trap it. And then we will IVUS, and then we'll recross, and then we'll figure out what is happening in this world. Okay, now record. Okay, so you see this, and then we come back, you'll see there's no disease. Oh, there's stent. Go in. Perfect. In. Come back slowly.
That's the circumflex, left main into
You'll
circumflex.
see it come back. It will come back very slow.
Trying to see the distal stent edge here, make sure there's no distal edge
Perfect.
dissection.
It's beautiful. It's beautiful.
It's well
Yeah, come back.
opposed.
See, that's the ostium looks beautiful. Keep on coming. Let me see the left main real quick. Left main looks perfect. You're good. Okay. All right. Come out, guys. Let's stop. So what we're going to do is recross.
Yeah.
So you guys see, I'm going to show you the IVUS now. If you look here, that's the distal circ, but that's the
Good
stent.
fielder.
Distal edge looks amazing. So you see, we went high pressure on this stent. So we got 4-5 stent to 20 atmospheres. You see here, it's about 4750, which is great. And then you'll see come back, that's the distal, that's the ostium of the circ. See, little ellipse, but you see the lumen is big. And if I want to show you the area, 1, 2, 3, 4, 5, 6. You see, the area is about 18 millimeters squared, so that's perfect. And let's look at the distal reference. So you want to be at least 90% of distal reference. So this is your distal reference. So let's see what the distal reference looks like. And the distal reference is 16. So we got more than 100%. What the hell's going on around here? All right, yeah, so we actually slightly oversized it with 20 atmospheres. So it's about 17 distal reference. We got more than 100% at the area. So it actually looks amazing.
Sure.
So what are we going to do? And when you do kissing balloon inflation, we study the bifurcation dynamics of balloon inflation. If you do high pressure kissing balloon together, you actually deform the proximal stent into an ellipse. you run the risk of number one, dissection. Number two, you make it so much into an ellipse that you cannot really expand it. So it really is not very good. This vessel is big, so may not matter, but in general, the vessels that are not that big, you don't want to actually, then you'll have to report with a bigger balloon and create more problems. What you do is you do sequential high pressure to expand it with a non-compliant balloon, and then you do low pressure KISS. What is low pressure? Probably just nominal.
So you see a 3.5 non-compliant balloon goes like butter because you've already corrected the deformation. No bifurcation that we've done that you cannot cross. So you don't have to worry about it. It actually changes the bifurcation, corrects the deformation. 3.5 non-compliant balloon, 4.5 balloon in the circumflex, sequential high pressure inflation, low pressure KISS, image it. A lot of time you don't even deform it into an ellipse. So you really don't have the need to report it when you do image. So that's what we did here. And then I'm gonna jump here. We're running short of time here, guys. I'm just gonna, we're doing our stuff. And then there was slight under expansion in the mid portion. We looked at it, and this is your final picture.
I mean, you can see this is as good as a bifurcation gets. So
it looks like we put a dedicated bifurcation stent. So it looks amazing. Patient tolerated the procedure well. We pre-closed it. Patient the groin was perfect. Patient went home the following day. So these are the things that complex calcification. All the lectures you had today in this case sort of illustrated everything in action and how we make decisions and the value really of imaging and then bifurcation techniques. So thank you very much. Any comments? Final comments from the panel?
I think the point for your procedure is the precise deployment of the set branch stent. Should precisely deploy the set branch stent.
Yes.
Well, I think it's a great example of employing all the elements that we've talked about this morning. This has been a very illustrative session on calcium modification. I want to thank all the panelists for their contributions and presentations. And we'll take a little break and come back and make a complete pivot 180 degrees, talk about renal denervation.
Good job.
Will we find our way back to the dirt where we came from? Will we find our way to the core, to the roots of who we are? Will we find our way through so lost in these clouds of emotion? Will we find our way home?
What I started doing when I was I would just think. I would every time I would watch somebody else do something, and I try to learn how to do it.
Yeah.
But when it's crazy, you just do the things you know how to do, and that usually helps because that frees them up to do other things.
Yeah. Okay, that's good. So helpful. Yeah, we're good. Oh, yeah, we're good.
Are we going to a hooky loud? A hooky loud. Everybody loves a hooky loud. But the loud is the cow at the luau. We throw our nets out into the sea, and only a mama comes swimming to me. Are we going to a hooky loud. A hooky, 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 hooky loud. What a beautiful day for fishing. Oh, Hawaiian wind. The hooky loud that's swishing down an old Lafayette Bay. Oh, we're going to a hooky loud. A hooky, 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 hooky loud. There's romance beneath Hawaiian skies, with a lovely hula hula maiden roll their eyes, while the silvery moon is shining above. The Johnnies and Mahimi sing a song about love. Paradise now at the hooky loud. A hooky, 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 hooky loud. We throw our nets out into the sea, and only your mama comes swimming to me. Oh, we're going to a hooky loud. A hooky, 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 a hooky, 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 hooky loud.
Oh, hell, Mariana, oh, man. Kalika, Pua, Kua, Kuri. Kuya, oh, Kawana, Matapu, I, Bodine. Iko I Kahimana, oh, Ikapiri, Kouluia. Here, Kalalomiana, Eko, I, Kapali. Oh, here, Mariana, oh, it was a Malame. My home, my all, oh, upon the car. Kulana, come through. Oh, Ikalia, or you can Kalaili, Ikalai, or Kapiti, oh, oh, yeah, Kalila, Kalima, e Kabuki Puka, e Kapiti, oh, Kahiki. Mai oe na oe honi honi aku ai ra mai kapuana e ua hana nei.
E aha ia na o mauna kea, wahi alo me ke hau. Ala wai ho o e a mauna loa, e moa ua ke ai ka mari. Ua kuau mahalo I ka nani, ka halea ka waihu ia ka manu. Mahu iho iau lai ke lihi, ka uahi no e lao I lau e lau. Ke hea mai nei le ma'uma'u, ele nei ke ahi a ka wahine. Wahine kui kua le kua ola, iho oi oi pono ka malanai. Aloha ia noa o hopo e, ka wahine a mi lewa lewa I ke kai. I hona puna I ka hone a ke kai, ke ala o ka inano ka ualoha. A ina ia mai ana ka puana, no huna ke ala I ali ia mai. A ina ia mai ana ka puana, no huna ke ala I ali ia mai.
Yeah, but they had the Australian connection.
Looking out upon the city and the stars above the ocean. Got my ticket for the midnight train, and it's not easy to leave again. Took my clothes and put them in my bag. Try not to think just yet of leaving. Looking out into the city night, it's not easy to leave again. Each time Honolulu City lights stir up memories in me. Each time Honolulu City lights bring me back again. You are my island sunset, and you are my island dream. Put on my shoes and I say, wondering which of my friends will be.
Yeah, I went to sleep.
Standing with their ladies
So,
around. It's not
that's so tragic.
each time Honolulu City stir up memories in me. Each time Honolulu City bring me back again. Bring me back again.
All right. We're already a little bit behind schedule, so I'm going to go ahead and get started, and we'll just let people trickle in. So I'm going to do a little bit of an update on patient selection and data for renal denervation, and then we will show a taped case demonstrating both of the currently available devices. All right, same conflicts. So just, something that we know and we realize, and that is that we're not doing a very good job of controlling people's blood pressure. Only about 24% of people with high blood pressure have it under control, which if you think about a country like the United States being about 337 million, that leaves a lot of people with uncontrolled blood pressure. It obviously leads to a lot of problems: stroke, death, heart attack. And it's also a condition that is disproportionate in that it affects non-white communities, probably at a level that's and a rate that's higher. So in terms of thinking about where this fits, and if you're a payer and you're scared because 50 to 60 million people may end up needing a procedure like this, there's this saying here that has to do with what happens when diplomacy fails. So when everything fails, there's always a last resort. So when diplomacy fails, war is the last resort. What happens when everything fails for blood pressure? So is that the future of renal denervation, or should we be more forward thinking and try to cut off decades of antihypertensive medication costs with an upfront procedure? And so that's kind of where I think payers' heads are at right now, besides saying no to all of us on all of our patients. I think they're mainly just scared of what's coming. So here's just a quick look at what blood pressure reduction means. And we're not talking about massive blood pressure reduction. If you have a 5 millimeter reduction, you get these sorts of reductions in cardiovascular disease, stroke, heart failure, ischemic related events, and death. So as part of the patient selection process, I think it's important to go through the guidelines and just understand what we mean by who, is eligible for this therapy, because the failure of prior trials had a lot to do with people just not taking their medications, not being on the appropriate therapy. So they weren't truly resistant, they just weren't taking anything. So according to the guidelines, you see what normal blood pressure is, you see what high normal, grade 1, grade 2 is, and this is by both office blood pressure and by ambulatory blood pressure monitors. Now, this is a busy slide, but the guidelines break things up into essential and optimal. And so what you really need to do is, over the course of 3 months, try to achieve blood pressure control. So we always used to think and say that blood pressure control is more of a marathon and not a sprint. I would say it's more like a 5K or a 10K at this point. So you need 3 months. It's not tomorrow, it's not next week, but somewhere in the next 3 months, try to get people under control. And then you want to do it in a stepwise fashion. So you want to follow the current hypertension guidelines. So you need to have diuretics on board. You need to use ACE, ARB. You need to use calcium channel blockers. And really, beta blockers have fallen off. And unless you have ischemic heart disease or heart failure, that really shouldn't be the first thing out of your bag, even though we all see people referred in all the time that have beta blockers as kind of frontline therapy. And then at some point, you want to start thinking about spironolactone, and we'll get into that in a little bit, just because when you talk about blood pressure reduction and improvements of end organ damage, LVH is part of end organ damage. And we know that aldactone receptor antagonists prevent fibrosis of the myocardium. If you prevent fibrosis of the myocardium, then it will relax and you'll have better diastolic function. All right, so the other thing is understanding the anatomy in terms of where are the nerves, because when you're talking about these therapies, it's very important to consider where the nerves are. And so what we know from this anatomic study is that they're proximal, middle, and distal, and they're not necessarily circumferential in distribution. So it's really kind of all over the place, and that's why when you treat, you need to cover basically all of the territory that you possibly can, because you just don't know exactly on a person-to-person basis where their renal nerves are. But we do know that there's a depth that you also need to achieve. So most people have their nerve distribution probably around 5-6 millimeters deep. So you need to make sure that when you're treating, that you have a treatment that can actually penetrate deep enough to do the job. Obviously not be so robust that you're blowing up people's kidneys, and then also not so weak that you have no effective treatment. All right, so this is the Paradise system. This is from ReCor, and we'll show an example. But basically, what you'll see here is the emission of a sonic wave, and it penetrates deep enough into the artery, 5-6 millimeters, to do the job. And it gives you a nice circumferential distribution of energy, and that should cover the nerves, even if the nerves aren't distributed in a circumferential pattern. And so we'll get more into that with the live case. So you need a generator. There's a constant cooling that goes on with this system. And basically, you're going to take the system to the bifurcation, and you're probably going to do 2 to 3 sonications as you work from the bifurcation, meaning main renal artery prior to the accessories, right? So you'll start distal and come proximal with this system. Pretty short acting, 7 seconds at a time. So from a pain standpoint, it's pretty well tolerated by the time a patient starts to have the sensation of pain, you're basically done. And so this is another demonstration on a diagram of how it works and what the strategy would be. So looking at the data, we're obviously not going to go through all of these trials for either ReCore or Medtronic, because we all know that there's a bunch of trials, a bunch of people studied, and we know that it works. So I'll just kind of pick and choose what I think is the best to make the point that we need. So if you look at these studies that were done, the Radiance family, so you either had Solo or Radiance 2, where you had a washout period where you stopped taking your medications for 4 weeks, or you had Trio, where you were on a fixed dose 3-drug combination for 4 weeks. So you're settling whatever you need to settle in 4 weeks, reassessing the blood pressure, if appropriate to move forward, meaning blood pressure is not well controlled and you meet these criteria as listed, then you move on to the next step, which is starting to eliminate the other causes. So either CTA, MRA, renal duplex, which we all know is very sort of haphazard and very dependent on techs and body habitus, or what's less often done pre-procedure, which is renal angiography. But we all do renal angiography at the time of the procedure. And then they were split up into treatment versus sham. And then you see here that the daytime blood pressure difference was significant, and the home overall was significant, and the office blood pressure reduction was significant. And then this is an interesting graph, because this is kind of the, if you will, the circadian kind of pattern of blood pressure. And so you see that the treatment arm mimics the rhythm that the body would normally have anyways. So that gives you an idea that the treatment has worked and the body is still functioning in a normal pattern. It also shows that the daytime and nighttime differences are still there, so it seems to be durable around the clock versus the sham procedure. And this is just another look at the pattern distribution of blood pressures over 24 hours between the treatment arm and the sham. So we know that that system works. What I always look at too, that I think is very important, is safety. And so the thing you don't want to do with a procedure like this is cause harm. And so I think that it was demonstrated to be a very safe procedure. When you look at the Spiral program, tons of patients studied through the Spiral program as well. And obviously we're not going to go through all of those. OFF was a washout study. So I'm just going to briefly touch on hypertension on med, just to show that, you know, you have to make sure that the patients are taking their blood pressure medications and appropriate blood pressure medication. So you see in this study that you have a high utilization of renin-angiotensin blockade. You don't have much in the way of beta blockers. So this sort of medication distribution coincides with what we looked at with the guidelines. You see the blood pressures between the treatment arm and the sham. And then you look at the safety features. So again, you want to make sure that you're safe when you're doing these procedures in terms of any damage to the renal artery or any other vascular complications. So 36 months down the road, the first patients that were enrolled, what happened with them? They had sustained blood pressure reduction. And this has been shown over and over in various publications. At 3 years, things continue. When you look at the 24-hour effect of the treatment arm, it seems to be very durable. So that's always a good sign, because I think that's the next set of questions, is if does it work? We would have to say yes. How long does it work for? We don't know, but it looks like it's pretty durable. And then again, safe procedure so that you're not harming anybody. All right, and then anytime that you look at therapies like this, there's always the set of data that you've sort of handpicked because you've gone to centers that you know, and then you have to look at what happens when everybody gets a hold of it. So I like looking at the worldwide registry just to see, you know, if anything's changed. And fortunately for the therapy, it works no matter whose hands it's in, and so that's always encouraging to see. Now, in terms of what it's going to do otherwise, I think you have to, you know, level set expectations. So if you're on 3 or 4 medications and you're treated effectively, you're probably not coming off of all your medications. I think it's realistic to think that you might reduce medications by 1 or 2. In rare instances, you'll come off totally. In sort of lower incidences, you may not be able to get off of any of the medications, but you will be controlled. And I think that's important to go over with patients. So we showed this earlier. You know, we have a very small group of people who have adequate blood pressure control. And so this presents a huge problem. Now this gets into, you know, when in the cascade of things you should, you know, intervene. So some of the most complicated patients, for obvious reasons, were excluded from a lot of these trials. But the idea and the real sort of promise of the therapy is to reduce this global CV risk. So if you look at people that are high risk, so end-stage renal disease, previous MI, heart failure, people that have massive left ventricular hypertrophy and diastolic dysfunction. I mean, these are people that need their blood pressure reduced to avoid all of these horrible things they're at risk for because of their comorbid condition. So you could make a strong argument that in these populations of people, it would be nice to intervene at an earlier stage with this. So who can be considered for renal denervation? Persistent uncontrolled hypertension, despite being adequately treated with medication. And then you have to confirm it, right? You have to make sure that non-compliance doesn't creep its ugly head back into things like it did with previous trials. You have to eliminate all the secondary causes. You need to make sure that these, you know, when you do this procedure, it's in someone who's actually going to get a lot of benefit out of it. And then you have to talk to the patient about expectations. And then I think, you know, the next point is pretty important. In our hospital system, we're really working closely with the nephrologists, even though the nephrologists have hypertension patients who wouldn't qualify for any of these studies because they're very far down the road. But I think working out some kind of synergistic relationship amongst the specialties is going to be important. And then in our institution, if you've never put a catheter in a renal artery, you're not going to start now. Because again, you have to make sure that this is a safe procedure. So we don't need to be experimenting with a renal intervention. So you want an experienced specialist to do this. This again kind of goes over definitions of resistant hypertension and you know, whether that's confirmed by office, blood pressure reading, or ambulatory. But you have to think about all these other causes. And again, it doesn't just stop with renal artery stenosis. You got to make sure they're not hyperaldo. You have to make sure that nothing else is going on. And again, it's very, very, very important to somehow make sure that they actually are adhering to therapy. All right. And then at some point, it may become like left atrial appendage occlusion, where it goes from someone who's at high risk, who's had terrible problems, to now what we see a lot, which is patient preference. You know, either the Eliquis is too expensive, these hypertensive medications may become too expensive. And so it may get to the point where, you know, either through drug intolerance or patient preference, we move forward with this procedure. So the good news is that the hypertension community never really bailed on the therapy and supports it. And so that's encouraging. Now, if we could just get wider adoption from payers, it would be very nice. Thank you very much. All right, so.
That was great, George. Yeah, so can you share your experience now? You know, and how many commercial cases have you done? And then talk about really a little bit reimbursement stuff.
We've been successful with one person going through the process. We have 19 that meet all the criteria that we just have been turned down on, and that ranges from a couple of Medicare Advantage to private payers. The private payers are a real problem here, and I get it, but at the same time, we've been asked to check all these boxes and do all of this stuff, and we're doing it, and it's still being denied. Anyone else have? I mean, obviously, no one's done 1 million of these in the United States, but
I'm curious about the future of this and where it's performed, because I think this is like a perfect procedure for ASCs to be done, because the cath lab space is getting very tight with multiple different procedures. And if can be done in a safe manner in ASC, what are your thoughts on that?
Yeah, I mean, it's a very safe procedure, and no offense to either of the companies, it's very boring. I mean, if you're looking for excitement, this is not exciting. This is like pull up your bar stool and just sit there 7 seconds, 7 seconds, 7 seconds. Next, it's not very exciting. But yeah, it's super safe and fast. And it really doesn't require the kind of sedation and analgesia that we were thinking about. Because again, the longest it's going to last is a treatment that's 60 seconds at a time, but it could just be 7 seconds. So our case we did was with the ReCore system, and literally about the time that the patient's starting to notice something, it's over. And so you don't, because I think there was a real worry that if you have to use anesthesia, analgesia, general, that makes things a lot more complicated. So the fact that you can do it with moderate sedation makes a big difference.
Yeah, the problem is that high blood pressure is a silent disease. You're not having chest pain, you're not having, all this stuff, but it is one of the leading causes of death. AFib is number one cause of AFib is high blood pressure, kidney disease, every single thing. And a lot of you guys, I'll bet you don't even know that you have high blood pressure. You don't even check it, right? So very few people get headache and visual changes. Mm-hmm. So I think this is, number one, it's very, very important. It's the largest cause of morbidity and mortality, but we need to be very, very careful with it. And when we do clinic patients now, instead of saying hypertension controlled or hypertension on current medication, which we always write our notes, we actually should have a section on hypertension and say, is it controlled? Is it resistance? What is it? So we start thinking of high blood pressure as something very different, because we have now modalities, and George showed you, there's about 29-30% of the people are controlled worldwide. And if you get more than 2 medications, the compliance goes crazy. If you take 4 medications, forget it. Most of the people don't take it. Mm-hmm. And then side effects, impotence, different kind of things. But we have a modality now that's actually been proven. It's safe, and we can offer it to those patients. So you got to start thinking of blood pressure as a different kind of thing rather than just be cavalier about it. And that's the key. Insurance companies, all these things, or any new thing you get is expensive. Insurance companies don't believe in it. But as we bring more data, as we start doing these things, I think this is going to change the way we manage patients. It really is a very, very interesting technology. So I've done, a handful of commercial cases, both with ReCore and Spiral Medtronic. But, procedure is simple. Just learn to do it. And George will show a couple cases here of both of the things, that just to make sure, just to show you, how these are done.
So Jazz, do you guys approach this challenge with an integrated hypertension clinic where people interact and act off protocols and have availability to manage this? Because you're everyday interventional cardiologist with a busy clinical practice. My institution set as one of our bonus metrics, 90% of your patients must leave the hospital with a blood pressure, leave your office with a blood pressure of less than 140/90. That is freaking impossible. To convince patients to take their medicines before they come in because they don't want to be peeing all the way to the hospital. And there's a million reasons that's a challenge. And I think as individual clinicians, we're screwed if we keep trying to peck away at the edges on our own. I think this is a multidisciplinary clinic approach, or I frankly will stay out of it.
Yeah, we actually were very patient. We built a team. We have 2 very busy primary care physicians. We have 1 nephrologist, and we have a hypertension specialist, and I'm the interventionalist. So this is our team. So we meet on Zoom regularly. We discuss cases. We have strategy for each patient. We're building database and stuff. So we are doing it the right way. And that's exactly what, if you're building a program, you got to build a program. You can't be just doing the procedure and forget about it. You know what I mean? So I think building a hypertension center of excellence at your institution is key. And Aaron is right. I mean, you gotta follow these patients. You gotta, make sure that they get the treatment. We are too busy, right? And we are too busy to follow these patients. But we have now a team, really, and we have a referral area, and people are referring. We have so many patients right now, they're waiting, and everybody's calling the office, and I'm going crazy because, I'm doing cases in the cath lab. So what the hell am I going to do? So imagine if I went, now we still haven't done it because industry wants us to go market to TV and all those kind of things. So the first 2 patients I've done, we're going to go on TV and share amazing experience, okay? And see how many calls you start getting. Who's going to manage those calls? So you have to build those things. And so once you start building that, I think this is going to work very, very well. So this is in its infancy, but very, very exciting technology.
Yeah, and I think documentation too is going to be important because the intolerance thing is going to be a real deal. There's so many people, there's a handful of people every month that get admitted with metabolic derangements from diuretic usage. If you've got aortic disease, you can't take hydralazine. If you've got ischemic heart disease, there's some medications that you shouldn't be on. So then that limits the number that you can even put people on. But we have to document all that stuff and prove it's intolerance, not just because we think it's intolerance.
I just want to add my 2 cents here. I agree with everybody on the panel here. We've started up a resistant hypertension clinic as well, and it's led by one of my colleagues, fortunately, because as Jazz said, we're so busy in the lab all the time. The one comment I wanted to make, people say, well, I could just take 4 or 5 pills a day. Why do I want to do this very expensive procedure? Insurance may not recover it. But the thing I want to emphasize, if you're on, say, resistant hypertension, you're on 4 once-a-day pills. I've actually did the math. Over a year, that's about 1,500 pills. Over a decade, that's 15,000 pills. So the advantage of this procedure, it's a one-time procedure. It's not like stents that we put in, they come back for restenosis. Excuse me. You get this procedure, you have a long-term durable result. George touched on this briefly, but they have 8-year and 10-year data where the blood pressure is maintained up to a decade. So this is a one-time procedure. They do not grow their nerves back. There was a thought that potentially they could re-innervate the arteries, but they do not. So it's a one-time procedure. So this is literally thousands of pills over the years that you can get these people off of.
Yeah. So as you guys bring up the case, the only other thing I would say that Jazz touched on is if you look at the primary care literature, for each medication you try to add, the compliance is terrible. It's just absolutely terrible. All right. So not that I need to present Jazz's case for him, but well, let's go back. Let's go back to the initial thing. Let me see. Hold on a second. See if I know how to work.
This patient,
She has a little hypertension.
207. If somebody needs denervation, this one does need denervation.
There we go. Yeah, so you see this list of medications, alpha blockers, calcium channel blockers, anything you could imagine. So for this procedure, again, it's not super glamorous. You come into the lab, you make sure that you get a picture of the aorta and the renal artery takeoffs. So a lot of times that's going to be maybe 5 degrees LAO, just depending on people's anatomies. And then you're going to engage the renal arteries in a safe manner, meaning pay attention to your waveforms. Don't inject if you're damped. And then look at the blush, so the injection of the kidneys is a little bit like when you do intracerebral injections. You want to stay for the whole phase so you see everything. And then obviously you want to wire carefully. And then you can do assessments however you want. So if you're using the ReCore system, I think you really need to have a very good idea of what the size of the vessel is. I don't think you should be guessing. Much like you wouldn't guess if you were putting a renal artery stent in. So whether you like to do quantitative vessel analysis or what, I use IVUS. I know Jazz uses IVUS. These are usually very clean vessels. So even if you're not very good at IVUS interpretation, this would be a great place to start because they're very normal looking arteries. And that way you know exactly what size vessel you're dealing with. And so you can pick the appropriate balloon size. And so as you're advancing, to the end of the main renal artery and staying.
So just stop the case a little bit. So the key is first thing if you've had a CT scan or something and you know there are no accessory arteries and you've seen the anatomy, that's okay. But otherwise you should start with an aortogram just to make sure you're not missing accessory arteries. And when you do selective angiogram, you want to make sure the whole kidney fills. So when your whole kidney doesn't fill, you're missing an artery. And about 26% of people have accessory arteries. So it's very important to do that.
And those get treated as well?
Yes, yes. They get the initial Simplicity trial, they were not treated, but they actually have found that there are a huge amount of nerves, number one, and number two, they secrete huge amount of renin. And, you know, medication-wise, spironolactone actually works with people more with accessory arteries too. So we found over time that I think they need to be treated also, as long as they are more than 3 millimeters. Yeah. So this is the RICO system.
Yeah,
Go
so
ahead.
this is the RECORE system. I stopped it here because I want you to see this part. So once you're in the right spot and you go up with the balloon, you're going to verify with a small injection of contrast to make sure no contrast escapes around the balloon so that you know you've occluded the vessel. And the system will also ask that you're adequately opposed, because if you're not adequately opposed, then you're not going to deliver the therapy.
Yeah, the QCA sometimes actually underestimates your because it's a coronary tool, it underestimates the size of the renal arteries. So with RICO system, it's 7 French, and with the balloon sizing is much more important than the spiral one, which George will show you. So I think it's important to make sure whatever tool you use, to make sure you learn to measure, you know, adequately so that you are, you know, occlusive, number one, and number two, you don't cause trauma. And then also you don't really need to go too distal with this system. George, you're going to comment on that.
Yeah. You don't. In all the trials, there was nothing was advanced beyond the bifurcation. So it seems to work just fine, staying in the main renal artery. And then the other reason to IVUS is that you can have size discrepancies. So you may need a 5 or 6 balloon distal, and then more proximally, you may have to go up a size. So really, once you've gone up and you've proven that you've got a good opposed balloon, then you're going to do the sonications, and so it's going to be very quick. And as I mentioned earlier, there's a constant sort of cooling as well, so you're not really in any danger of thermal injury to the vessel.
So you see, we're injecting there, and it is occlusive, and then the machine really tells you what to do. So we just do it. We have 7 seconds of balloon inflation. Patients actually feel pain. Actually, some patients feel a lot of pain. It's like when you're getting access in the leg, right? When initial needle goes, you have pain, right? Patient has pain. But then when you're passing wires inside the artery, you don't have any pain, right? Because there's no nerves inside the artery. All the nerves run on the adventitia, right? Mm-hmm. So when you have pain or you're passing a wire, you know you are in the wrong place. Here, you want to do that. You want to damage the nerves, and patients are going to have a lot of pain. So sedate them well, but this is only 7 seconds. Pain goes away right away. And with Medtronic system, you will see the 60 seconds, and they have decent amount of pain. And sometimes when they have decent amount of pain, they actually move, and the kidneys move with breathing, and then there can be loss of contact with the spiral catheter. Sometimes we've seen that. So I think sedating them very well is very, very important.
Yeah, no, I agree. And again, I don't have a bunch of experience, but the case we did, it was literally like at the 5-second mark pain, but then that 2 seconds later, you're done. So it seems to be pretty well tolerated. All right, so on this kidney, there was 3 separate treatments. Okay, so 3 sets of sonications, and then Jazz moves over to the left. And again, just using standard peripheral techniques. And I think on this side, due to the anatomy of a kind of a shorter main renal, 2 sets of sonications were performed. So same phenomenon in terms of, just position, inflate, make sure you've got good apposition, no contrast leaking around, and then you deliver the therapy.
Yeah, the wire has to be supportive. So you either use Grand Slam, we use high torque power turn, or you use Ironman wire. So you want to make sure it's atraumatic distally, and make sure the distal wire doesn't go to the end arteries, because once the bleeding happens, you're going to have problems. So you just be careful, but you need supportive wire, especially with the 7 French technology with Rico. The profile is a little bit, bigger than the spiral catheter, but tracks very, very well. So use your equipment well. We use IM guides, usually 55 centimeter IM guides, or you can use RTC guide, or you can use, different hockey stick guides also for different things. But IM usually works very, very well. So you see, procedure is done.
So George and Jazz, for people that want to start this program, in terms of preparing for Plan B, if something happens, what should you be prepared for? Like stents, what kind of stents? If it perfs, do you guys because you guys have a program? What are some of the disasters that you prepared for?
Well, so like I said, I mean, you shouldn't. It's not a great place to have someone start who hasn't ever manipulated a renal artery. If you've done any amount of endo work, any amount of renal work, all the stuff you're talking about it shouldn't happen. I mean, now, could you get a dissection? Sure. So, balloons, you want to IVUS, you want to have stents available, but just, garden variety renal stent would be fine. But I mean, you saw in all the trials, I mean, it doesn't happen, because if they've got any amount of appreciable renal artery stenosis, then they're not technically, someone who should have this therapy. So you want to have the usual disaster stuff ready, but if you've sized the vessel, particularly with IVUS, the chances that you're going to rupture or avulse something is very, very, very low.
And then also you worry about dissections. Usually dissections not from balloons, but usually dissections from your guide catheter. And if you're not coaxial, you're injecting without looking at your pressure, you can have dissection in general. Those things you don't need to really stent. Very, very few flow limiting things you see in kidneys. So the complication rate is very, very low. I think the thing that you really want to worry about is make sure your distal wire doesn't go outside near the capsule. Because if that happens, you're going to have a big time hematoma, and patients usually don't do very well. So you don't want that. But otherwise, everything else, I think it's as safe as possible. But, do you need to be, that's a good question. Do you need to be a peripheral interventionalist to do this procedure? I don't think so. I think, there will be requirement, there will be society requirements for general, interventional cardiologists that you have to do certain amount of renal angiograms and these kind of procedures to qualify in doing that. You want to understand sizing of the stents, know what types of stents. We have Heculink Elite stents that we keep all the time, but there are other stents that they have also. So you have Express, small size Express LDs. The Heculink was the one that was studied in renal artery stenosis. So keep those stents on the shelf in case you need it. But otherwise, Josh showed the data, very, very safe. Sometimes when you do angiogram after you do these things, you're going to have these little spasms in the artery. You've done that. So sometimes you give nitroglycerin or nicardipine, they usually go away. You really don't need to do anything with it.
Yeah, and I agree. And it may just be a manpower thing too, because like our vascular surgeons don't want any part of this because they don't really treat hypertension. They don't treat, they don't do a whole lot of renal artery stuff anyway. So if it's a manpower thing, I think there's a way to probably work around it. But if you already have a handful of people that are experienced peripheral people, then there's probably not a need. So this is an example using the spiral catheter. This is a patient that ended up just getting one side treated. So you'll see here a lot of similarities in terms of, doing your angiogram, making sure you understand the anatomy. The biggest difference you may notice right off the bat is that you do take the spiral catheter beyond the bifurcation into the distal, into the accessory arteries. You
Yeah,
want to
and-
do all of the stuff over a wire. Okay.
Yeah,
so-
why do you do that is because the concentration and the way the mechanism of this radio frequency ablation versus ultrasonic is different, and the way they target and the way they kill the nerves. So this is a big concentration. You want to make sure you go as distal vessels, not into distal branching vessels, but make sure all these 3 branches, you want to make sure you go in there, take a wire, same wire, it's a 6-French system. You take the wire, and it's usually straight. So when you then pull the wire out, then it spirals and opposes. So therefore, the proximal one is number 4, the distal one is 1. And you see, it tells you it goes for 60 seconds. And the numbers that you see is, one is impedance, it's around 250 to 300, and you see the temperature drop. So in here, actually the machine will do its job. So if your temperature rises significantly, or your impedance, which is electrical, resistance that you cause, if it drops too much, that means you're causing damage. So it actually will shut down by itself. So sometimes, and if you lose contact, it'll actually stop. So then sometimes you can only, if you come proximally, you can do only 4, or you can only do 1. And if you missed an area, then you can choose which sort of polar electrode that you want to activate. So it's pretty easy. As I said, it's 60 seconds. So pain, and sometimes when pain, patients breathing and motion, you will lose contact with one of the stuff. Then sometimes you just go back and just do one area.
Yeah, and not that you don't, and not that we wouldn't recommend that you know the exact size, but this catheter has a range. So it's not 1-to-1. So it will take care of arteries that are roughly 4 to roughly 7 millimeters.
Yeah, you see there,
Yeah,
that
the
they
lost
lost
number 3.
contact, patient had breathing, started having pain, then you lost contact with 1. So what you do is let this go. If you go beyond 45 seconds, if you lose contact, don't need to do it, another one in that area, because you're already good in general. They want 60 seconds, but data has shown that 45 seconds is probably enough. So now, if it went away 10 seconds, you actually finish these things and then press 3 again, and you do 3 again just to make sure you cover that area.
Yeah.
Pretty easy. Most machines actually tell you what to do. So look at, these guys are standing there, relaxing, listening to music. It's a boring procedure, but you got to do it right. You got to be patient. That's the key. So we just wanted to show you guys these cases. There is no magic to it. Understanding anatomy, make sure you don't miss accessory arteries, make sure you choose the wire, don't go distal. Rest of the thing, the machine will tell you exactly what to do. And groin management is important. You want to make sure you do micropuncture access. You can't do radials now because you don't have longer catheters. It is femoral procedure, but you want to make sure micropuncture access, CAMARAO, OLAO, look at where your needle is entering. If you're high, take it out, re-stick under ultrasound, and then get good, very good in getting femoral access. And most patients go home the same day. Okay, it's very, very important.
Yeah.
When do you see expectation of blood pressure drop? This lady we did first, her blood pressure went to 160 in the holding area. It had never been that low in her life. Okay, that's rare. In general, it's probably a few months, then you start seeing equilibration of hormones and all those kind of things over time, that your blood pressure will drop. And as George said, expectation is key. You got to tell them you may not get off your medications. It's very rare to be on 7 medications and all of a sudden after the procedure you're off all the medications. It actually, in data, it shows that probably it's close to 2 very strong drugs at the dose that you want to control. Okay, it's very, very much. So that's what the data looks like. But we just want to make sure the patients understand those things.
Yeah, and the only last technical point I'd make, and this is because this was an issue with the failure of the Symplicity trial in the US, was oftentimes there was inadequate treatment. So you need to be meticulous. If the patient's having pain, give them pain meds. Don't shortchange the therapy because the pain is bothering you. Because if you do it appropriately, you're going to come up with probably about 16 contacts. And that was kind of the magic number if you looked at the success of the prior Symplicity. trial, but so many people had inadequate treatment, and a lot of it was just bailing out because of pain. And so you want to be meticulous.
Yeah, the only problem here is that you don't even know. That's one thing is there's studies that are going to be done that you will be able to then tell whether you've done effective innovation or no. Because everybody's going to want to do it. And after to Reggie's point, I'm telling you, this is going to become, like for me, I anticipate that one day a week in the cath lab, I'm going to just do the innovations. So it's going to happen. And, you know, you get your cath lab trained in doing it. The key becomes is just to building. And that's the key, building your practice. And that is very, very important. So do it the right way. I think it's going to be good. And it's easy procedure. So you know what? I'm going to give up all my complex PCI. I just do denervation.
That's right.
That's what I do.
The retirement home is renal denervation. That's right. Yeah. So before we change gears, are there any questions from anyone in the audience? Okay, if you come up with something later, then just find one of us. So we're going to change gears altogether and move to ultra low contrast PCI with Reggie.
Thank you. I'm going to be talking about ultra low contrast PCI. In the interest of time, I'm going to kind of skip things along. Those are my disclosures. So for two tools of PCI in 2025, you shouldn't be having a brand new patient on the cath lab table without having done some sort of a testing. And really, truly, to be honest, you should be expecting some sort of coronary artery disease if they are anginal type of patients. Yeah, pre-surgical patients, that's a different story. But if we have anginal patients, there are multiple different tools now that you can anticipate what kind of diseases the patients have. Of course, depending on their renal function, other clinical criteria. But we have so many tools. We have dynamic coronary road mapping. We have sync vision or co-registration. We have OCT IVUS. In the past 2 days, we learned a lot about that too. And there's CT FFR as well that we can predict what kind of diseases the patient could have. I don't want to bore you with the impact of contrast. You know that if you give too much contrast, it raises the risk of contrast-induced nephropathy. There's costs associated. There's allergy reactions associated. And you think it's minimal, but you are adding fluid volume to those patients that could have severe heart failure as well. The contrast-induced nephropathy, the impact is huge. Now, for us, whether it's fellows or for attendings as an interventionalist, we may not see the patient 2 to 3 days later. But if you develop AKI in a significant AKI, there's increased mortality. Now, patients could die in 2 to 3-fold longer hospital stays, increased morbidity with sepsis, lung issues, and of course, higher treatment costs. And some people end up on dialysis. The ultra low contrast PCI, there is a requirement. Now, there's no requirement from the societies or anything like that, but there's a general rule of thumb that you need to be aware of. Now, of course, the whole idea is to limit the contrast use, but you need to have the skill set to be able to do this. You cannot just say, okay, this case, I'm not going to inject any contrast where you have not done that before. That's not going to work. The patient's going to have poor outcome. It's a multidisciplinary teamwork, especially involving your vendors as well, if they're around, or some sort of imaging expert, whether it's you or your partner. And make sure you think about patient safety too. Am I able to do safely for this patient ultra low contrast PCI? For it to occur, you need to limit the angiography, of course, that's ultra low contrast PCI, but you need to integrate intracoronary imaging, coronary physiology, hemodynamics, all the tools that we learned about in the past couple of days. Things have changed. The needles have kind of changed a little bit. Now, ultra low contrast, we used to say, okay, we should ultra low contrast on every single patient when we do diagnostic angiograms or PCIs. But really, truly, to be honest, you need to be able to understand, okay, which patients are at highest risk of developing complications from contrast. Unfortunately, all of us, I'm sure on the senior attending side, we've seen some angiograms done with 200, 300, 400 amounts of contrast, where you see those patients later, they don't have any kidney problems. But there are some patients that you inject 50 cc's of contrast, they have big time AKI. So how can we actually see the difference? You need to build a skill set, like we talked about, but in the beginning, now no ultra contrast for everybody, but you need to have judicious use for every patient. For all cases, think about why you're injecting, what are you looking for when you inject. You want to have appropriate angles. These are very basic things for the fellows. You want to make sure you draw back the contrast once you're done with the injection with your catheter. Integrate imaging and physiology, be confident, so you don't need to puff every single maneuver that you've done in the coronaries, and make sure those are low stakes patients that you're learning from or you're practicing on. Now, practice is a wrong word in interventional cardiology, but it truly is building your skills. Now, on the other hand, ultra low contrast, yes, it's select cases. Otherwise, also the patients are high stakes, okay? But it's a continuum of skill set. To illustrate my point, I'm going through some cases and go through some points. Now, this is an 86-year-old property manager male, referred for RCA PCI. He had crescendo angina, CKD stage 4, GFR is 18, type 2 diabetes, recently underwent coronary angiography and diagnostic coronary angiography and showed RCA disease. High stakes, right? eGFR is 18. So the plan was to do ultra-low PCI to the RCA. Very simple. There is a mid-coronary artery lesion. The purpose of this talk is not to demonstrate that lesion is bad, but you can use IFR, you can do sync vision or co-registration to see where the lesion is. You can plan, you can size with your intravascular imaging, put a stent, post-dilate, and it looks great. For this case, contrast use was less than 5 cc's, right? And you knew upfront that you didn't need to inject that much, but you also need to understand, okay, if the patient's not doing well and you're doing ultra low contrast PCI, you need to know when to inject. If the patient's hypotensive, clearly you need to understand what's going on, so you inject. But other things that you can think about is new intractable chest pain, ECG changes, hemodynamic changes. If you see pericardial effusion on chest X-ray or fluoroscopy, that's really far gone. But if you see that, it'll change your gears. Persistently suboptimal imaging, or you cannot pass the IVUS catheter, then you need to think about injecting as well. The second case, so 68-year-old executive referred to PCI. He's a renal transplant in the past, but the renal transplant is failing. Again, the GFR is low. Worsening angina and shortness of breath. Had underwent diagnostic angiography with LAD disease. And the plan, again, is ultra-low PCI to the LAD. Now, again, there's diffuse LAD disease with calcification. We did an IFR to understand where the lesion is. We have an IVUS catheter. Now, everybody uses a different IVUS catheter. We preferentially use the Philips phased array, but you can do rotation as well with co-registration that allows you to understand the length of the disease. But for this catheter, you understand the length of the lesion as well. You size the lesion, you put the stent in. Now, and post IFR as well. Now, the important thing is, co-registration is a new thing, and it's very, very useful thing if you use it in the right setting. Now, IFR co-registration, I'm really sold off. Very, very useful. Allows you to understand the length of the lesion and where the pressure drop-offs are. IVUS co-registration, in the beginning, I was not using much, but once we start treating diffuse diseases, now you can argue not to stent long lesions, but if you were to put a stent in a long lesion, it's very useful in lesions that are longer than 38 to 48 millimeter, which is the stent length. You could perform the co-registration as well, depending on the vendor, the IVUS vendor you have as well. Case 3 is so 86-year-old male, unstable angina despite 2 antianginals, had a CTO intervention to the LAD, CKD stage 4 again, GFR 22, moderate aortic valve stenosis, the LAD and RCA patent on diagnostic angiography. So for this case, it was ultra-low PCI to the circ bifurcation. So you see there is a LAD stent and there is lesion at the ostium of the circ. There is mid-circ and also OM in the mid-circ that's kind of wrapping around the lesion over there. IVUS stent. Now, again, the purpose is not to show how I did the PCI, but amount of contrast that was used. By using intravascular imaging, I only needed to inject 4 cc's. And I was able to do bifurcation stenting as well. You have to be very careful about the amount of contrast you use, but at the same time, if you are going to use contrast, make sure it's worth it. I see some operators that dilute the contrast, and I'm sure you share that sentiment too. You inject, you cannot see anything, so what's the next move? You inject more to see. So you just have to be careful. Okay, if you're gonna inject, make sure it's worth it for you. And for me, sometimes my techs will try to help you. Really their intent is to try and help you, so they load contrast for you. So for me to prevent for myself and for the techs, I sometimes take the manifold off to prevent that from happening. And I do that in CTOs too sometimes. The technique that I use, as I mentioned, is there is the dilutional contrast, there is limited angle angiography, which is 100% just regular contrast. I preferentially use this contrast layering technique, and there's other providers that do the zero contrast as well. But for me, I don't like doing zero contrast because at the end of the case, I would like to double check there's no distal wire perforations because those patients may not present at the time of the cath. It's usually later at night. They're hypotensive and they have pericardial effusion. So this is how I do the contrast layering. And I just want to show you. So I have my manifold vertically. This is me drawing up saline, and we'll zoom in here. Because of the different density of the contrast and saline, you can see the contrast, that's 1 cc of contrast, and injection after that. And the angiogram that you see is this level of angiogram. And if you have Phillips, or depending on your fluoroscopy, I'm sure you have toggling feature where you can just go forward, forward, forward every frame. And if you do that, you can actually see every single level of the artery. So that's how I do the contrast layering technique. So this case was a 74-year-old patient that was looking very unwell. It's end-STEMI from outside the hospital. They did a diagnostic angiogram, was transferred here. Again, very high stakes. Renal transplant failed, CKD5, EGFR 12. Severe low flow, low gradient aortic valve stenosis, severe peripheral arterial disease, right-sided FEMPOP bypass, heart failure, ejection fraction 15%. Those are the highest risk patients. We talked about we need to be selective about the patient population of who we employ ultra-low contrast. We know by several data that's nowadays coming out that hemodynamic instability, acute heart failure, near cardiogenic shock, needing for mechanical circulatory support, STEMIs. Those are the highest risk of patients that you need to think about ultra-low contrast PCI. But at the same time, those are high-stress situations too. So you have to be very judicious and calm when you think about doing ultra-low contrast PCI. So again, coming back to this image, so there's diffuse LAD disease, terrible RCA disease with calcification. So in summary, this left main, there's RCA, aortic valve stenosis, but before he came, he was working in the yard. All of us have seen these type of patients. How are you still alive? They look fantastic beforehand, but now they're not gonna make it soon. Turned down for CABG, no surgeon will touch this patient. We did a right heart catheterization. The filling pressure is not bad. Index is on the lower side, but he's relatively optimized. But at the same time, we're going to mechanical atherectomy this. So we thought about putting in an Impella, think about orbital atherectomy with shockwave as well, but ultra low contrast, IVUS guided PCI. Now this is a very, very complicated case. And again, I'm not trying to show a trophy type of case, but the important thing here is I had my local Phillips vendor who actually looked at the imaging with me. I had a partner that helps me looking at the imaging, verifying what's happening with the imaging as well. My nurse and second nurse actually paying attention to the hemodynamics. So this is not a case where you can just do it with yourself, your tech, and that's it. It's definitely truly a team effort. So for that type of level of PCI, the ultra low contrast, you can do it in 3 cc's. The second operator and dedicated team member, very, very important. I cannot stress that enough. And these cases should not be done at 10 p.m. at night. It should be done during the day. You need to have trust among your teams. But like I said in the beginning, it's a graduated skill set. You need to build up your skills. You should not take on this skill as a first year of attending, or you don't have a partner that buys into your skill set as well. Make sure you're confident by the time you're able to do these cases. Judicious contrast use is always, okay? You don't keep puffing and puffing and puffing after every balloon inflation. It's not going to help your patient. Plan the procedure upfront and very carefully. Use imaging and physiology as an integrated system rather than separate type of things. Get comfortable with injection techniques. Now, not everybody needs to use the contrast layering. If you prefer the dilution, by all means go for it, but do not keep injecting. Know when to inject. And ultra-low contrast is patient selection. Not every patient is patient selection. And I want to stress it's heart failure, bleeding type, mechanical circulatory support, and STEMIs. Those are very important patient populations that you need to be aware of. Thank you.
So great points. And I think the really key feature there is, and this kind of had to do with some of the discussion yesterday with the use of angio-FFR and how it fits in. As an interventionalist, I've kind of gotten to the point, you just take a couple pictures, there's a problem in the mid LAD or circ or whatever, and then get the rest of your information with IVUS or physiology. And then what things look like, fix the artery, and then look at it again with IVUS. And if you need to, take one final angiogram. And that's how you keep these cases on a routine basis, regardless of their GFR, to minimum. And frankly, it's also the main reason why, as a prior heavy OCT user, I moved to IVUS, because I found that the use of OCT was tripling my contrast usage. What do you think, Aaron?
Totally agree. And Reggie, that was a great presentation, and want to just highlight a couple of things. This is like anything. And the only disagreement I have is, if you're in your first year, you should be doing this every day, because if you wait until you need it, you're going to fail. So as Reggie said, practice. If you're a malignant puffer and you just can't move a wire without a puff, you need to ask yourself after every puff, what did I learn? If it's a game changer, keep puffing in that circumstance. If you really didn't learn anything, you got to get off the puff. Stop puffing. You can explore coronary arteries with wires. These workhorse wires now are atraumatic, terrifically torqueable, controllable wires. And there's nothing wrong with putting 4 wires into somebody, because you're going to mark this branch, mark that branch, and know that your lesion's right in between and work on a 3rd wire. Great way to keep yourself oriented to the image that needs to be imprinted in your brain. And the other thing is just to have the roadmap. I would just suggest that if you're doing any PCI in a patient with a previous angiogram, you put in your sheath, you put in your guide, you put down your wire, you do your first image, if that's a feasible thing, without a single puff of contrast. And just keep working on it, and you will get better at it. The only discouraging thing in all of this is there is a funky relationship between contrast volume and AKI that you alluded to. And there's a lot of other things to consider. There could be atheroembolism, there's episodic hypotensive episodes, there's a lot of other things that might create problems for you, but it's still your obligation. The one thing you can control is the contrast.
Excellent points. I just want to add a couple more things on top of this. I think you might be sitting in the audience go, well, how can you only use 3 cc's of contrast and engage some of these coronaries? So I used to wonder that as myself. You may be puffing just to get your guide in place, right? Well, the technique you'll use is inject saline. You've done a lot of cases. We have interventional fellows here. If you inject 10 cc's of saline, you'll see the hyperemic response. Typically, you'll see T wave changes, ST changes. That tells you that you're in the coronary. And then, just as Aaron said, use a soft, workable wire. Mine is a Xi'an Blue because it's the softest workhorse wire, 0.5 gram tip. I'll put the wires in every branch. I'll put it in LAD. I'll put a circumflex. When you do an angiogram, literally, we'll just do maybe 1 shot for the right, 2 shots, maybe 1 cranial, 1 caudal for the LAD. That's it. If you need more shots to get different angles to see if it's tight or not, we don't do that anymore. Now we just purely based on physiology. Get your 1 shot, so you see the branches. Everything else is wire-based, IFR to tell you if you should fix it or not. And as Reggie pointed out, use your IVUS to mark the proximal distal landings and to help optimize your vessel prep.
All right, so we will move on to the next talk on radiation protection, so that we also leave ourselves just a few minutes, if possible, to discuss things. This should at least provoke some sort of questions in the audience and on the panel.
Chief,
Good day, everybody. This is Kenny Rosenfield. I'm in New Hampshire, and it's very cold here, about 5 degrees, and I decided to wear my Hawaiian shirt in honor of you guys who are lucky enough to be in Hawaii and enjoy the nice warm weather and the beach. But what you're about to hear is probably the most important talk of the whole session, because it's about safety for everybody, and it's also about heat. So talking about Hawaii and heat, this is about radiation and radiation protection in the cath lab. What's new? So thanks to Jazz for inviting me to give this talk. I really appreciate it. I wish I could be there with you, and maybe next year I will be. So, I recently gave the similar talk, and the name of the talk for that other session was, "Is this job literally killing me, or at least injuring me?" I think the answer to that is yes. And these are my financial relationships. The only ones that might be relevant are that I am a consultant for Philips, and I work with Radiaction, which is a company that's developing radiation protection devices. Additional disclosure that several of these slides are borrowed from friends, Manos Baralakis, Jim Goldstein, Dave Reisig, and others. But the passion about this talk is my own. I own that 100%. And why am I so passionate? Well, here is my spine. You can see that there, this was back about a year and a half ago, where the circle is a ruptured disc, and it's compressing the spinal column. So there's actually no space for either spinal fluid or the nerves that pass by there, by the way, that control my legs and so on. And below that, in L3, L4, L5, and S1, there's absolutely no disc space left. So the discs are dehydrated, compressed, and there's a bulge. And by the way, 35 years on, after having been in the cath lab for that many years, this is what it looked like. And I was very disabled at this time. There was no space for the spinal column or the CSF. Not a good thing. And I underwent my second spinal surgical procedure within 2 years at that point, which was at this point a decompression and a discectomy and a partial laminectomy to remove that bulging disc and restore function to my legs. I had physical therapy for a couple of months. I was back in the cath lab doing my usual thing, avoiding lead in cases where I could, using some protection devices we'll talk about. But 6 weeks later, after a very long limb salvage case, while I had to wear lead because the current systems that protect you don't allow you to do a long limb salvage case, a peripheral artery case, the configuration is just not right. I ended up in the emergency room with the worst pain I've ever had in my life. I was admitted for 2 days, had steroid injections, and what had happened was I'd slipped broken off a little piece of disc. And by the way, this is what I looked like after my injection. I was on these medications, and this is what I looked like when I was walking. The dog in front of me walked a lot better than I could. Still in horrible pain for several days. And then suddenly I had no pain, but I had some weakness. And I'll talk about that in a second. I was back in the cath lab after 2 weeks. But it turns out that I had persistent pressure on my L3 nerve root that had from a piece that had broken off and gone into that nerve root and compressed the nerve, and ended up causing denervation and atrophy of my left quadriceps. I don't have the sexiest legs here, but you can obviously see how after 6 or 8 weeks, that left quad is much less robust than the right. And what had happened was I had denervated my vastus lateralis and vastus medialis. And I can tell you now, I ended up with another operation to remove that little piece of disc that was in the wrong place. I had a microdiscectomy. I was home in 23 hours and walking and about to start rehab. 4 weeks later, as I was about to start, I had some pain and chills and fever, and I went to the emergency room again. And guess what? I had an infection in that prior surgical site with an infected seroma that was really up against the spine and also the subacute tissue. It grew out abundant Staph aureus, not a good thing to have next to your spine. So I had a surgical washout, placement of a drain and a vac, and I was on IV antibiotics at home for 10 days, and went back to rehab for my back and my quads now, because now my quad was weak. And I can tell you now I'm about 6 months out from this thing, and I'm still going to physical therapy once or twice a week. Trying to regain my strength, getting my core strength back. I'm back in the lab, doing everything I want to do, but doing it without lead as much as I can. We'll talk about that in a second. So the total time out of the lab in 2024 was 24 weeks. That's a lot of disability for a guy who's fairly productive in the lab. And my 15,000 or 16,000 RVUs went down a lot last year. So unfortunately, I'm not alone. We're experiencing an epidemic of orthopedic injuries in the cath lab. Just about every doc that I talk to who's been in the cath lab for 15 or 20 years has aching back and symptoms, clearly got symptoms. And half of them have had surgery. It's unbelievable. People I never imagined that have had back operations. And, I didn't know it. They were out for a few weeks and they were back and I never knew it. So to date, we've really barely acknowledged this problem. And most importantly, we can fix this problem. Let's talk a little bit about occupational hazards in the interventional lab. Back in 2009, Lloyd Klein convened a group and wrote this manuscript. The headliner was basically interventional lab poses significant workplace hazards to physicians and staff. And that's 2009. Why is it taking us so long to do something about this? We haven't done anything about this. We've done very little. The X-ray equipment manufacturers have reduced the radiation dosing that we're getting, so kudos to them, but very little else has been done. So those hazards consist of the physical hazards of ionizing radiation and what it can do, other things that are less probably relevant, but noise, electricity, etc. And then the ergonomic and orthopedic issues like wearing heavy lead, which has led to my condition that I just described to you, lifting in awkward positions and so on, prolonged wearing lead for 7, 8, 10 hours. And by the way, the interventional era has brought a higher volume of cases per operator, a larger volume of cases in the lab, more fluoro time per case, more complexity, more imaging, higher radiation exposure. And even though, we're looking at where the wires are, we're trying to be careful and deliver safety to our patients, it's what you can't see actually can hurt you, and that's radiation. We know that it's bad for the patient. It can cause skin injuries and ulceration and cancer. We focus on the patient. We take our fluoro exam every year, and we talk about that and, talk about ALARA and so on and so forth. But guess what? There's a huge radiation risk for staff and both cardiologists and everybody who's exposed to radiation in the lab. And the prevalence, for example, of posterior lens opacities is 52% in this study. So there's the eye that's at risk. But frankly, it's the whole body. And the average interventional cardiologist is exposed to 50, well, you can see it here, 50 millisievert to 200 over the course of a career. Basically, a whole body exposure of nearly up to 10,000 chest x-rays. And the brain can get exposed to up to 50,000 the equivalent of 50,000 chest x-rays per year. And by the way, great, everybody's crazy about structural stuff. They have the highest exposure, and complex PCI also has high exposure and accounts for about 40% of all PCIs. I did a complex left main the other day, and it was a lot of radiation. And radial access has grown significantly. And by the way, radial access is exposed with significantly more radiation exposure compared to femoral access. So all you radialists out there, be aware that this is a high radiation exposure procedure. I personally like femoral better still. It's also associated with, I told you about the brain exposure. Well, here's a picture of famous cardiac surgeon, Ted Dietrich, who I knew very well, who died from a brain tumor that was on the side of his brain that was exposed to the most radiation. And he is a quote, that he says is, "I never thought it would hurt me." And I guess I was wrong. And he was wrong. There are findings that suggest a causal relationship to radiation exposure because of the left-sidedness of brain tumors in most of these cases of a small subset of patients, a subset of cardiologists who developed glioblastomas. My own colleague, Chip Gold, who some of you may know, he was very well known, a famous guy. He died of leukemia that was undoubtedly related to his extraordinary exposure to radiation in the cath lab. And there's no doubt in my mind that that was associated. So how do we reduce radiation exposure? Well, during my lifetime, we've developed the fluoro store function, and I use that all the time, so we don't have to do cine angiography. Reduce the frames per second, reduce the radiations per frame, use the highest standards and best equipment that's available, understand where the radiation scatter is coming from, back away using that inverse square law. If you step back one foot, you get an exponential reduction in the radiation that you're exposed to, and less scatter. But how do we really reduce radiation exposure? Well, we've been wearing lots of heavy lead, but beware, there's a trade-off to wearing that heavy lead. First of all, there are lots of areas of your skin that are still or your body that are still exposed to the radiation that are not protected by lead. And there are reports of significant skin cancers in cardiologists and others that are exposed to radiation that are outside of the lead apron. Most of them outside the lead apron. And 90% left-sided. If that isn't a smoking gun, I don't know what else is. But keep in mind that aside from, cancers are real. You can see them on the far right, skin lesions on the left. Cataracts are real, but the biggest occupational exposure for people in the cath lab related to protecting against radiation is orthopedic. It's from wearing that heavy lead. And this is a study that demonstrated that if you'd been in the cath lab for 16 years or more, then you had a really high incidence of orthopedic and spine issues. And even if you'd been in the lab for more than 5 years, or more than 10 years. So in this ACC survey, musculoskeletal issues were affected 48% of patients, of cardiologists and cath lab workers. And it was exacerbated by work. And that in 50% of these folks, they were either retired or cut back. And these are people who have been in the lab for many, many years, who are very valuable to the lab, but they're just being forced to stop or cut back on their work volume because of the aching in their back or the orthopedic issues or the need for surgery, like me. This is a survey that was done, again, Lloyd Klein led this, 314 responses of SCAI members, and at least half of them had at least one orthopedic injury, mostly lumbar and cervical, but some knee and hip and ankle. It correlated with age, and in a significant number, it meant that they had to limit their caseload or take a leave of absence like I did last year. So what's the magnitude of this? As of 20 years ago, and that's before the interventional era, the data showed that 60% of physicians performing invasive procedures for more than 21 years reported spine problems, and I would venture to bet that 50% had surgery. 26% with less than 5 years reported spinal problems. So this is a big deal. But the true current magnitude of occupational effects is probably even greater than that. It's challenging to quantify, but it's certainly underestimated. There's, as I said, more than 50%. In my discussions with my colleagues, I'm finding that 50% of people in my era who've been in the lab for 20 to 25 or 30 years have had actually spine surgery, something or other. What are the keys to mitigating this? Obviously, minimize the staff radiation exposure, allow freedom from the heavy lead aprons. How do we do that? We're going to talk about that. We now have some tools to achieve it. First of all, you should use the RadPad. I mean, RadPad is open for every one of my cases, and I can't believe how many times we forget. Even I forget to put it up there where it's most effective. It has significant reduction in exposure. It doesn't mitigate the need to wear lead aprons. It doesn't protect the brain, but it does help. Zero gravity is one of those systems which has a suspended lead suit, and it enables the operator, the primary operator, to really reduce their radiation exposure without actually wearing lead. But it's cumbersome and restrictive. Single operator, and by the way, this is my colleague. It's a little bit of a Darth Vader. This is my colleague Farouk Jaffrey in his suit with his helmet on as well. There are newer systems now that are available increasingly and getting better and better that do protect you and allow you not to wear radiation. At least some people in the room not to wear radiation, or to wear a lesser, a lighter version of radiation that weighs more like 3 or 4 pounds as opposed to 20 or 25 or 30 pounds. So Rampart is probably the most common of these, and I use Rampart now. I'm lead-free about 90% of the time because of Rampart. It's a good system. It's a little bit challenging to manipulate it. The staff are not so thrilled with it, but honestly, it's been a boon for me. And sometimes the fellow who's next to me who decides, they may decide not to wear lead, but most of the time they're wearing lead. And I'm the only one in the room without the lead. Egg Nest is similarly protective. And I don't have a lot of experience with this, but I understand that system is actually pretty darn good. And Protego, similarly protective, a little bit more blocking between the patient and you, but it's actually very effective in eliminating exposure or limiting exposure, at least for the operator and the primary and secondary operator. The one of the issues with all of these systems is that the staff in the rest of the room, especially at the head of the bed, are still exposed, and therefore they need to wear lead still. I've been working with a company called Radiaction, and so I've disclosed my personal interest in this company, but I think this is the future. So when you talk about what's new, this is coming down the pike, and actually it's already been installed in a few hospitals and will be increasingly over the next 6 months or so. St. Francis has installed it, and they apparently are in love with it. Basically, this is a system where a series of shutters comes up from the tube and comes down from the II. With each angulation, it retracts and then comes back down instantaneously using sensors to go up against the patient without actually compressing the patient. But it does actually, again, you can see that the scatter is encapsulated by this series of shutters. So people in the room can get away with wearing light lead, and eventually, I think as we get better with the shutters and they're actually more encapsulating, it'll be no lead at all. Again, this is full body protection to everybody in the room. So it protects all the patients. I mean, all the hopefully not patients. Hopefully they won't become patients as a result of this kind of protection. But all of the staff in the room blocks the scattered radiation at its source. You can see that lower right-hand picture encapsulates all the radiation. So in conclusion, what's new? Well, what's new is actually old, but what's new about it is that we're finally recognizing it, that it's the most common occupational hazard in the cath lab, and that is orthopedic injuries. Not to say that the radiation exposure injuries themselves aren't injurious and important. More than 50% of cath lab workers report these things. Mostly lumbar and cervical is a higher incidence with the longer time in your cath lab career, and with more complex interventions and structural and CTO interventions and long peripheral cases as well. It often leads to surgery and disability, lowering your caseload, premature end of careers. I can tell you many of my colleagues have stopped because of this. Preventive measures are clearly underutilized, like ergonomic adjustments and lighter lead and physical conditioning, which we need to work on as well. I certainly need to. There are better solutions now available with creative shielding, and these should be mandated. We should force our hospitals and force Big Iron to grapple with this. Big Iron's been, avoiding it. It's their problem. It's their problem with ours. They're the ones making the radiation and making the systems. They need to incorporate these systems into their make it part of their sale, if you will. This is a call to arms for all of us. Are we paying enough attention to these occupational hazards that we face daily? The answer is no. We've been all very complacent and resigned to the status quo. We don't think about it. We race into the burning fire, or we race into the room to do our work that is life-saving. But we need to think about our own longevity, and what is good for us is also good for our patients. What we've accepted as the norm is no longer acceptable. It's wake-up time for our docs, our staff, our hospitals, and industry, Big Iron, everybody. Time to pull our heads out of the sand, and it's time for action. So with that, I'm just going to refer you all to a PBS special called Scattered Denial. If you just go online and look up Scattered Denial under Google, you'll get a link to this. It's a series of 7 or 8 little videos that describe this whole problem and really go into depth. And kudos to David Ryzek and many others who've actually spearheaded this. SCAI is going to be spearheading a statement, a scientific statement about this over this next year. My colleague, Jim Hermiller, who's the president of SCAI, is taking this on as a big issue this year, occupational hazards. And we all need to do a better job, and we have solutions. I'm very confident over the next 3 or 4 years, things are going to really change in our labs. Thank you very much. I hope you guys enjoyed the beach and the sun and the beauty of Hawaii. And I look forward to seeing you. Thanks, Jazz, again.
So I may be the only one who's got experience with EggNest Complete. We've got several of those, and it does offer around the table protection. There are some constraints, you know, according to BMI. So what we did when we installed is we wear real-time dosimetry, and what we found is if you've got a BMI of 35, 36 and above, in spite of everyone's best effort, you're probably still getting some exposure. But I've done several zero exposure or close to zero exposure cases. So I think that's a good system. I think all of these have they're good and they're bad. And you mentioned this last year. This is eventually going to become a work hazard, and we'll be able to declare that we don't feel safe, going to work because of the exposure.
Yeah, there's an old saying that wise people learn from the mistakes of others, and wise people learn from their own mistakes, but wiser people learn from the mistakes of others. You young folks in the audience have got to listen. Don't ruin your retirement by being cavalier, being tough, being indestructible, being a team player, listening to all the things your administration wants you to be. You're probably in an average environment where your hospital administrator does not give a shit about you. You are a RVU producing cog in a wheel that can be replaced anytime, anywhere. I know that sounds cynical, but that's actually the fact in most hospitals and health systems, that they don't view you as an asset to be protected. And so I shared the story last year of how the only way we could get Rampart, we got 5 systems now in all of the coronary labs in our health system, but the only way we could get the last 3 was through a generous benefactor. And I was sitting in a meeting with that donor and the CFO, people from the foundation and the development team, and he had a check in his pocket. He was ready to write a check for 2, as long as the hospital kicked in 1 more to bring us up to the 5 that we needed. We already had 2. And the hospital was trying to convince him that the one they already bought counted. And he's like, no, you need another one. The guy made a killing in the used car business, and he knew how to deal. And as we had finally agreed on the whole thing, the CFO said, hold on, we haven't adjusted yet for depreciation. And I don't know how much you guys know about depreciation, but it's kind of a fake accounting method for hospital systems to write off capital equipment over a 7-year period. And it was going to equate to $12,000 to $13,000 a year over the next 7 years. That came out of a budget, but wasn't cash exchanged. It wasn't real money. It was just being deducted, and it's added as a cost to their operations, which meant the CFO might miss her bonus because she wouldn't get the cost down low enough. So that's how much they care. $13,000. They're getting a donation of hundreds of $1,000s, and a $13,000 glitch is going to give them spasms. So just use my cynicism, please, to advocate for yourselves. And if there's not a place in medicine where we should coalesce, I hate to use the word unionize, it's considered unprofessional, but at some point in time, ACC, AHA, SCI, somebody's got to make a position statement. We got to get all the old equipment out of the lab. We got to get modern equipment in the lab, and people have to invest in this. And I will say, Rampart's not perfect. I cuss it every day. It makes me crazy trying to get the angles I want, bumping and grinding stuff. I'm breaking the II all the time. It's a pain in the butt. And when a code goes off, it's like got to get out of the way. And so it's not perfect. And I think if it doesn't get better, it's going to get swallowed by EggNest and a few other competitors in the market. So.
And I mean, an EggNest is still not good for peripheral cases, but if 70% of the time I can wear no lead or wear the new, 3-pound, 4-pound lead that comes with, if you purchase one of the systems, they get you a set of 4 pieces of this ultralight lead. Yeah, there's still work that needs to be done in the field. Fortunately, we have sold our system on it being almost a competitive advantage for recruitment. So like if you're coming out of training and we need a new IC and the people across town need a new IC, but in our lab you can do your cases with no lead, and there you have to wear lead. It could be a big deal.
George, you just stole my thunder. So I would just comment to folks who are in the process of looking for jobs, negotiating contracts, or switching jobs. Put this in a negotiation. This is your time to do it. This is when you have the most power before you sign. say that you want this, say that you expect this, that this is sort of the new standard, and push the administration to answer why they can't do it. This is where you're the most powerful in negotiation. And Rampart now has a new iteration, which is ceiling mounted. So one of the big issues that I've had with Rampart, I've used it for a couple of years, is that the floor mounted system has a post that will interact with the C-arm, particularly in an LAO projection. LAO is a nightmare to work in with Rampart. There's now a ceiling mounted version, which takes away that whole issue with the post. So that's another option as well.
Unfortunately, that's not an add-on. That's not an upgrade. That's a repurchase.
But it can be negotiated, right?
Everything can be negotiated.
Yeah. So anyways, I'll cut you guys loose. Let's try to just come back on time. That way we can get finished on time and you can enjoy the rest of the day. We'll take
Yeah,
one
what
question.
about the Corindus robotic issues there? You know, we had one in the VA in San Francisco. It seemed to work out, but it's like problematic at sometimes. What are you guys feeling about that?
Well, as the former chief medical officer for Corindus, Corindus sold to Siemens for $1 billion, and Siemens, over 2 years of trying to figure out what to do with it and ignoring the roadmap they were handed, killed the coronary program. So it's dead. They're not making cassettes anymore. And it's one of my biggest professional disappointments and embarrassments, but I had nothing to do with how it transpired. I just totally believed in the technology. I've told this radiation story a million times. It was one potential solution, but the actual applications were even more exciting than that. But it's dead, and I think that's a shame. There's not a better way to kill a new technology than a giant organization taking it. So.
All right. We'll see you guys back at 1:15.
Atuyanara, iteheyo na ona, if I know, I taught Tawatino. Atuyanara, iteheyo po, te hapeura ana uite ipo. Te hapeura ana uite ipo.
mai te tiare, te rā mai te maire, te rā mai te hei Tahiti. Te rā mai te tiare, te rā mai te maire, te rā mai te hei Tahiti. Hatui anara, I te hei ona, te whaino, aino aito tawatino. Hatui anara, I te hei upo'o, te hape ura ana ui te iepo. Te hape ura ana ui te iepo. Te hape ura ana ui te iepo.
No ka pua lo ke lau ke aloha, no ka ikau I ka weki. No ka pua lo ke lau ke aloha, no ka ikau I ka weki. O ala o nau na ia nei, o ola le na ia na la le ia. O ala o nau na ia nei, o ola le na ia na la le ia. Evalea pua me ole, I ka hanano e ao o ipo. Evalea pua me ole, I ka hanano e ao o ipo. Ahe ipo o e na ui aloha, ka ano ia ku'uwai. Ahe ipo o e na ui aloha, ka ano ia ku'uwai. Aina ia mai ka puana, no no Green Rose ke aloha. Aina ia mai ka puana, no no Green Rose ke aloha.
E ai nei o ka lani, a mau o kau la kau nei ae, ai noho a panei ae, ua ka pue ka hai ke li. Ai e, ai la, ai e, ai la. E ai nei o ka lani, I ka owenei e kalomana, lawe a mai e kai o laua e, o kau ka iu iu o lani u. Ai e, ai la, ai e, ai la. o ka laki I ka poi ai le hua o wali ia e kai o I nano mai ka I he pahe e ke munia ai he ai la ai he ai la Kei ai nei o ka laki I ka o whai mahiki hiki I ina ia e pense lauri O kaua kua hini o manoa Ai he, ai la Ai he, ai la E ai nei o ka lani I ka I a he au I ia mai e kai o au kai Au e hu kai o ka moana Ai e ai la Ai e ai la
E kahi au e ke aloha e no ka ili lau o ki koa e au e ke aloha e no ka ili lau o ki koa e au e ke aloha e au e ke aloha a e I ho'u ke kula munu pile E lua, au e ke kani a ka vi ke au moe. Au e ke kani a ka vi ke au moe. Au e ke kani au e ke kani a e I o'u ke ke la munu pide. Pa'ani. Au e, ke kani e. Au e, ke kani a e I o'u ke ke la munu pide. E kolu, au e ka ini nui a ka pu'uwahi e. Au e ka ini nui a ka pu'uwahi e. Au e ka ini e. Au e ka ini a e I o'u ke ke la munu pide. E ha, au e ka pili e, o ka pili pono a kaua e. Au e ka pili e, o ka pili pono a kaua e. Au e ka pili e. Au e ka pili a e I o'u ke ke la munu pide. Hana ho, au e ka pili e, o ka pili pono a kaua e. Au e ka pili e, o ka pili pono a kaua e. Au e ka pili e. Au e Kapiwi a I o e ke la munu piwe.
As far as Hawaiian music and all music, it's not especially understanding what it is, but feeling the music. And in Hawaiian music, I think there's a lot of feeling that cannot be explained, so that's why it's so important.
We the voices behind the face of the Hawaiian nation, the Hawaiian race. Rise for justice, the day has come for all our people to stand as one. Ela we the voices behind the face, the Hawaiian nation, Hawaiian race. Rise for justice, the day has come for all our people to stand as one. Ela Te huli huli I ka pakini halamihi, lana the day the galamihi. Kiko I ka piko o ka mana o ka poe, power of the people is the people. O ka piko ke aloha o ka aina, o ka aina. We the warriors born to live on what the land and sea can give. Defend the birthright to be free. Give our children liberty. Te huli hoi ka pakini halamihi, Father de ka halamihi we. Te kiko I ka piko o ka mana o ka poe. Power of the people is the people. The people ke aloha o ka aina, o ka aina. We the warriors born to live, what the land and sea can give. Defend our birthright to be free. Give our children liberty. Ela ea ea ea, ela ea ea ea. Ela ea ea ea, ela ea ea ea. Ela ea ea
It's not especially understanding what it is, feeling. Hawaiian music, there's a lot of feeling that cannot be explained, so that's why it's
Hone ana ko reo e uerie, I kahi manu noho ai kai. Ki ai makala e o ke kaha, o ia kai wala na mali. Urili e ahana, ili e hene, ili Ulele ho ehene, ele ahana, ele ehene. Ulele holo holo kakaie, hoia kai walan alie. You know what? Hey, I'll get 2 verses.
he ao e kamakani koni Pawali na mera e u Au he ao e kamakani koni Pawali na mera e u Ele hua mamoi popo e mai nei Nei a pua holani Behi kalani E kiss my gently kaua E ke hoa e o ku hoa ro Leo kapo Aloha o mai oe Naka beauty ahi ahi o ina Wana ke aloha o mai oe Naka beauty ahi ahi o ina Naka beauty ahi ahi o ina
Ai kanani o moloka ila ina pali beli beli o ke ko o lau e mai ka leo hone i ke ahi ahi la i kamakani e ke pue o ke awava e hihi wai la lai lai e hoki mai ka uala i ka aina ulu ehi o waila hano hano wale no ka wailele ka hiwala a me ke kua iwi o oroku Ele ka konei a pau I ka mele aina la O ka nani mai ole O ke ola mau O ka makani kuleo O ke kai kupu O ka aina ulu rehi e ho'i mai ka uala I ka aina ulu ehi o wailau. Ano ano wale no, ka wailele ka hibala, a me ke kua iwi o oloku.
Ila ila hoi ala hoi ke ika I o ka pumiulana. Ila ila hoi ala hoi ke ika I o ka pumiulana. Nui ka o mana hoi no ake na ia nai. Kanui ka o mana hoi no ake na ia I Hawaii. Apumake ona ona e ala honi nei tu mohori. Apumake ona ona e ala honi nei tu mohori. Ya vai kapuana tu kuri bolita uata wahine. Ai no mai kapuana kuri bolika uata wahine.
Okay, this one's for Gabby. Ooh, somewhere over the rainbow, way up high, and the dreams that you dream of once in a lullaby. Oh, somewhere over the rainbow, bluebirds fly, and the dreams that you dream of, dreams really do come true. Ooh, someday wish upon a star, wake up where the clouds are far behind. melts like lemon drops high above the chimney top. That's where you find me, oh, somewhere over the rainbow. Bluebirds fly, and the dream that you did to, oh why can't well, I see trees of green and red roses too. I watch them bloom for me and you, and I think to myself, what a wonderful world. Well, I see skies of blue and I see clouds of white and the brightness of day. I like the dark and I think to myself, what a wonderful world. The colors of the rainbow, so pretty in the sky, are also on the faces of people passing by. I see friends shaking hands, singing, how do you do? They really say, I love you. I hear babies cry and I watch them go. They'll learn much more than we'll know, and I think to myself, what a wonderful world. Someday I wish upon a star, wake up where the clouds are far behind me, where trouble melts like a lemon drops high above the chimney top. That's where you find me, oh, somewhere over the rainbow, way up high.
Hi, good morning, good afternoon.
We're going to give it a couple minutes to see if we can get any more of our stragglers in for lunch, then we'll get started. Oh, hi. All right, good afternoon, everybody. Thank you for being the small but few that are making it through this whole conference. I know it's nice outside, but we have some really nice talks and a really nice session coming up. So we're going to start off with Dr. Matsuno. He's going to talk about in-stent restenosis mechanism and treatment. Welcome.
Okay, thank you very much. Good afternoon, ladies and gentlemen. It's a great honor to talk about one of the hot topics in PCI. This is my disclosure. In the bare middle stent area, the incidence of ISR was as high as 20 to 30% in year, and the development of drug-eluting stent dramatically reduced the incidence of ISR, but it still remains at a rate of 2% per year, and 10-year clinical data from randomized trials with drug-eluting stents showed the range of the incidence of TLR is still 20%. Moreover, the proportion of PCI for ISR remains stable at around 10% per year in the United States. In summary, ISR remains a main cause for repeat revascularization even in DS area. The development of ISR is influenced by the complex interplay of patient-related, biological, anatomical, procedural, and stent-related factors. After taking them into consideration, we need to do PCI while modifying and while avoiding the modifiable risk factors. Mechanisms and the morphological appearance of ISR can be classified into mechanical and biological mechanisms. Mechanical mechanisms include stent under-expansion, stent fracture, stent malapposition, geographic miss, and residual stent edge dissection. On the other hand, biological mechanisms include neo-intimal hyperplasia and neo-atherosclerosis. The neo-intimal hyperplasia is a typical pattern of the typical mechanism of bare middle stent ISR. On the other hand, neo-atherosclerosis is characterized by the atherosclerotic changes within the stented segment, which can vary from calcific plaque to the thin cap fibroadenoma. Needless to say, it is very important and crucial to understand the underlying mechanisms of contributing to ISR and adjust them to treat ISR effectively. But unfortunately, we can't understand the mechanisms of ISR only through the angiographic images. So the use of intracoronary imaging, such as IVUS or OCT, is mandatory to treat ISR properly. IVUS and OCT have advantages and disadvantages respectively, but OCT is generally superior in neo-intimal tissue characterization, and thus it can be more informative for ISR management. Various treatment options for ISR have been attempted previously that include plain balloon, scoring and cutting balloon, IVL, ROTA, CSI, ELCA, and brachytherapy and DCB, DES, and CABG. And regarding DCB, nowadays there are many kinds of DCB in the world, but in Japan there are two kinds of drug-coated balloon, sequent please and agent, both paclitaxel 1. And the indication for DCB was originally studied with ISR and de novo small vessels, but the indication is now expanding to the de novo calcified lesions, bifurcation lesions, ACS patients, and high bleeding risk patients. And the use of drug-coated balloon is increasing gradually in Japan, according to the National Registry. There are two network meta-analyses comparing variable strategies for ISR treatment, showing the use of DCB and DES was associated with the highest efficacy without significant trade-offs in terms of safety compared with standalone use of other strategies, for example, ROTA, cutting balloon, or plain balloon. Therefore, DS and DCB are recommended as the first-line treatment option for ISR in European guideline and in the Japanese guidelines as well. But which option should we select? the DCB or drug-eluting stent for ISR. There are some randomized trials, and some trials revealed DES was superior in efficacy compared with DCB, and other trials showed DCB was non-inferior to DES in terms of efficacy, and safety endpoint was consistently reported to be comparable between DES and DCB. So we need more comprehensive data, and DEDALAS is an individual patient data meta-analysis. And in this study, 1,976 patients undergoing DCB or DES in all available randomized trials were compared at 3-year follow-up, and DES was moderately more effective than DCB in reducing the rate of TLR without statistically significant differences in the composite safety endpoint. In the sub-analysis, DCB was associated with a lower incidence of a safety endpoint compared with the first-generation drug-eluting stent, and in the setting of DS-ISR, TLR was significantly higher after DCB compared with DS. The other one is a 10-year clinical follow-up extension of the ISO-DESIRE 3 trial. The clinical follow-up of the patients assigned to plain balloon, paclitaxel-coated balloon, and paclitaxel-eluting stents was extended to 10 years, and this study showed that there was no significant difference between DCB and DS in terms of the primary efficacy endpoint of TLR and the primary safety composite endpoint. Interestingly, notably, the excess of death and cardiac death associated with DS compared with DCB was observed at 5-year landmark analysis, though 10-year differences did not reach the statistical significance. So this alarming result may be attributable to the use of the first-generation drug-eluting stent, but we need further examination. So evidence so far suggested repeat DES implantation could be comparable or superior to drug-coated balloon for ISR lesion, but we need more because ISR lesion itself is quite heterogeneous in terms of the morphology, mechanism, and patient background. So we need more practical guide how to select appropriate treatment for each case. So this is my personal algorithm for the treatment of the ISR. The first thing to do is to assess ISR functionally. So if the clinically and angiographically and functionally significant, so we need treatment. So the first thing to do is to intracoronary imaging using IVUS or OCT. In case of ISR with one metallic layer and the main cause is a stent under expansion or malapposition, next thing to do is lesion preparation. I usually start with the plain NC balloon, and if it can't fully expand the lesion, consider the scoring balloon or cutting balloon. And all of them don't work well, consider rotational or orbital atherectomy. Actually, in Japan, IVL for in-stent lesion is contraindicated, but I rarely use in selected cases. And if the lesion preparation is successful, I always finish with DCB for the stent under expansion or malapposed case. And if the lesion preparation is unsuccessful, I consider CABG. And if the stent fracture or stent gap or edge dissection is a main cause of ISR, additional DS implantation for the lesion is reasonable. Anyway, we need adequate lesion preparation before implanting the stent. If the main cause is not mechanical but the biological one, it includes the neointimal hyperplasia or neoatherosclerosis. Anyway, we need adequate lesion preparation. And after that, we should select DCB or DES. But if the ISR is focal or bare metal stent ISR, the patient is the high bleeding risk patient, or the ISR is located at the significant bifurcation, I prefer DCB. On the other hand, if the ISR is diffuse pattern or instant occlusion case or drug-eluting stent, or there is a concomitant mechanical cause, the DS should be additional DS implantation should be considered. But actually, I prefer the drug-coated balloon for the first TLR case, even in diffuse ISR or ISO or DS-ISR case. On the other hand, in case of ISR with multiple, I mean 2 or more metallic layers, additional DS should be avoided because previous reports clearly demonstrated 3 or more layers can be associated with worse clinical outcomes compared with 1 or 2 metallic layers. So anyway, in this case, we need aggressive lesion preparation. And if the preparation is successful, we can finish with DCB. Otherwise, we need to consider CABG, especially in case of high-risk ISR location, for example, left main or the proximal LAD, or in the setting of mouth vessel disease. So please let me show you 2 cases. This is a very recent case, and the 80s male. He underwent DS implantation for the LAD and CIRC in more than 10 years ago, and he developed unstable angina last month, and circumflex lesion was treated first, and then LAD lesion was tried. This angiography showed a diffuse restenosis from the ostium of LAD to mid-LAD, and we can also see the large septal branch and diagonal branch. So anyway, after wire crossing, I performed OCT to understand the mechanism of restenosis, and OCT image showed the extent expansion was quite nice, but there was a combination of neointimal hyperplasia and lipid-rich neoatherosclerosis, and in some part we can see the calcification within the stented segment. I decided to pre-dilatation with the scoring balloon 275 all the way through the lesion, and after that, slow flow occurred due to the probably due to the distal embolization. Fortunately, flow recovered after nitroprusside and inotrope administration, so I continued to do the additional lesion preparation with 3.5 NC balloon and 275 scoring balloon. And after the OCT examination, I finished this procedure with 2 DCB application, and final angiography showed a good result with patent side branch. This is a recent Japanese style. So in the first TLR, the most Japanese avoid multiple stenting. The next case is more challenging case, 70s male. He had a multiple history of PCI and EVT, and a few years ago, he developed non-STEMI, and you can see the tight stenosis at the proximal circumflex, and at another hospital, the drug-eluting stent was deployed, followed by pre-dilatation, and final angiography showed a good result. But angina relapsed 3 years later and was referred to our hospital, and the angio showed severe restenosis within the circumflex stent. First, I tried to advance IVUS, but IVUS catheter couldn't be advanced, so I tried to dilate the lesion with scoring balloon 2.5, but you can see the clear waist at the middle of the balloon, and I couldn't dilate the lesion. So here I tried IVUS examination again, and on the IVUS you can see obviously the calcific plaque, so-called calcified neoatherosclerosis within the stent. So I tried ROTA with 1.5 millimeter bore, and then sized up 1.75 to debulk and reduce the amount of the calcification, and then moved on to the scoring balloon dilatation and sized up to 3 millimeter, and IVUS revealed suboptimal but acceptable result. So I finished with 3 millimeter drug-coated balloon application, and final angiography showed an acceptable result. but the patient relapsed angina 6 months later, and we can find the same, the tight stenosis at the same part, like this, and IVUS at that time revealed calcified neoatherosclerosis again. So at that time, I started from ROTA 1.5 and then sized up to 2.0, like this, and followed by the predilatation with the 3.0 scoring balloon. And because this event was a second TLR, so I decided to put the additional stent, 3.0 drug-eluting stent, followed by the post-dilatation with a 3.0 balloon. And I was reviewed a little bit expanded, but the acceptable result. Final angiography showed an excellent result. But angina relapse 6 months later, and we can find the restenosis within the stent. And I was reviewed the same findings, calcified neoatherosclerosis. So at this time, the scoring balloon was used for predilatation 3.0. And then because though the IVL for the IS instant lesion was contraindicated, but I secretly used 3.5 IVL and followed by the 3.5 NSC balloon dilatation, and IVUS revealed better result, I mean the larger luminal gain. And I finally finished with a 3.5 DCB. And final angiography showed a good result. And after this treatment, fortunately, the patient is free from angina and, free from angina, and 6-month angiographic follow-up showed a patent circumflex stent. This is my last slide. I talked about the importance of intracoronary imaging for treatment of ISR and appropriate treatment selection for the ISR depending on the morphology and mechanisms and the patient background. And most importantly, once ISR occurs, it can recur multiple times. So the best way to address DS-ISR is to prevent it. Thank you very much for kind attention.
That was a very nice talk. It's a difficult issue. We continue to get plagued by it. And I think the most important point that you made was that if you use IVUS up front, use OCT up front, then you won't get into at least the issues with self-expansion or under-expansion and stent fracture and under-recognizing those things. I'm just curious in the panel if there's the algorithm you showed was really great. And thank you for sharing that really difficult case with us. Anyone else use anything? I tend to use laser for ISR, so.
Regarding your last case, the mechanism for the last case for the ISR is intrastent calcification, and even the repeater target vessel failure is also caused by the calcification inside the stent. So what's the mechanism between the difference of the mechanism between this intrastent calcification and the intrastent hyperplasia?
Yeah. Thank you very much. So I agree. I think the main mechanism is the neoatherosclerosis, the calcified neoatherosclerosis. It is typical in the CKD or the dialysis patient, but I think that there is also the mechanical stent under expansion in this case. So that's why the final treatment with a 3.5 millimeter balloon was effective for this patient.
It's very nice. Taishi, any difference in your treatment of ISR?
So I think there's a truth in like Japanese style of trying to do the DCB, try to not put the second layer, because I think as a chip or CTO operator, we always see this end result with multiple layers of stent with under expansion, and those are the really harder ones to treat, whether you're doing a CTO or high risk intervention. So it's really, I think, important to prevent, and I've changed the practice, kind of listening to Dr. Matsuno's experience and everything. Even if we didn't have a DES, I tell my patients that I'm just going to go with a balloon angioplasty. and then tell them that you might come back in 6 months, but you'll know because you'll have angina, and we can do the angioplasty again. It's like teeth cleaning. And so I don't know if that's the right approach, but that's what I've been doing to avoid, it's really hard not putting in the second stent. So now that we have, DCB, I think, that'll be even more common practice in US. The question I had for Dr. Matsuno was, a lot of times it looks good at the end by IVUS, but then angiographically it looks pretty so-so. What do you do in that situation, and how do you decide?
Yes, retrospectively, I have sized up the balloon to the 3.5 originally because of course, one of the reasons was neoatherosclerosis, but one part of the cause was the under-expansion. So I should have sized up to 3.5 balloon at the first DLI event. Thank you very much.
Thank you very much. Next we have Dr. Grantham, who needs no introduction, St. Luke's Mid-America Heart Institute, talking about DCBs and expanding indications, and very important for us as we now get to use this technology.
All right, thank you, Sudeshna. The subtext of this is it's early in America. I'm not sure I'm the one to give this talk, because we're going to talk a little bit about where DCBs might be important outside of ISR. And I think our friends from Asia and outside the US have the experience that would be terrific to hear more about. But I'll just share some thoughts. One thing I want to make clear is that I'm not an expert on ISR. I don't want to be an expert on ISR. If this talk is unimpressive, that's not totally unintentional, because that would mean I was really bad at stenting. So I think take that for what it's worth. These are my disclosures, and the one that's important is I was on the planning committee for the AGENT trial, and I'm on the advisory board of Boston Scientific for the DCB. Along with a really great group of people. I have played a trivial role in all of that, but I do perform those services for Boston Scientific. As a CTO person who has said 1,000 times at the podium, it can't take you longer to stent the vessel than it took you to cross it, I can share with you one of the other major humbling things about my career is that I was dead wrong. And I've learned a lot of lessons over the years. And I think it's really important to admit your fallacies. And one of those was that we thought imaging was a waste of time because we thought we were so cool getting vessels open that nobody else could open. So we've eaten a lot of crow over this. And in the last 5 years, my IVUS rates have gone from 10 to 15 to 100%, to 99%. And in fact, when I go around the country talking or asking people, how much do you IVUS? I know you're lying if you say 50%, because there is no 50%. It's usually 0 or 100. Once you do it every day, it's kind of like femoral access with ultrasound, just isn't comfortable doing it without it. And as an old man, I'm still struggling to pick stent sizes if I don't have an IVUS image to do that. So the point is that restenosis isn't just a plague on society. It's just not a problem faced by society. It's a new disease, and you're giving that disease to your patient. And it's almost intentional if you haven't done everything you know how to do to avoid it. So just put the catheter in and look at the images. My other favorite thing I learned was from Kevin Croce, who said there's a big difference between imaging endorsed and imaging informed PCI. You know, all these trials now that Greg meta-analyzed for us and showed us a 30% risk reduction in MACE events with image-guided versus angio-guided PCI are done in places that know how to image. And the vast majority of people just don't know how to image. So I think you're getting the information at this conference that's going to help you, but this is a long-term process, and just looking at a few presentations and going back home and trying to look at those pictures, the resources you have available are tremendous. There's weekend workshops, there's courses like this, there's major courses, and there are reps. And despite what your institution thinks about reps being in your lab, I know that at least Boston Scientific, this is not a sales thing for Boston, but and I know Philips and all the other companies, they will support you as you learn how to image. You have to learn how to interpret the images so that you can use them properly to get the results that are reproducible in these trials. So again, this is a big problem. It's 10% of PCIs in the US. This is data from the NCDR. It's old data back to 2017, but you can see In the green line, the incidence, the frequency of bare metal stent ISR cases is declining as the frequency of DES cases for ISR are increasing, but overall the rates of PCI for ISR remain around 10%. And out of 700,000 procedures a year, that's a lot of cases. So it's a big impact. It's also not a benign disease. We think of this as just scar tissue, but it actually presents as non-STEMI and STEMI, and about 25% of people, 1 in 4 of these people with ISR, come back with an acute lesion and come back somewhat hot. The other thing that that was revealed to me in all of this is that now in the era, I used to tell patients all the time, oh, if we make it through the first year with your bare metal stent, you probably will never need that spot treated again as long as you get your risk factors managed. With DES, there's a 2% per year rate of ISR and neoatherosclerosis or repeat revascularization. It's an interesting phenomenon, and that's part of what's generating the interest in non-polymer-based therapy, non-strut-based therapies. Those treatments are usually with stent, often with DES. PTCA atherectomy is used infrequently, and brachytherapy, which basically delays the hyperproliferative response by 3 years, just isn't widely available. But if you wanted to be a real ISR guru, that would be something you'd have to invest in building into your program. This is just the data that Greg meta-analyzed. Again, it reemphasizes the need to image, and the most important parts of the image are selecting the right stent and getting adequate coverage of the lesion. One of the things that is often said is that 70% of the time ISR is a mechanical problem or a technical problem, that most often it's stent undersizing or stent underexpansion, and that 30% of the time it's biological. Well, all that tells you is that 75% of the time you could find something that's been associated with ISR, but that doesn't mean that's the only thing going on in that patient. That patient might be a hyperproliferator like Shinsuke's case just showed. He had great IVUS results. He did everything right. Calcific nodules inside of stents within a year or two. That's crazy. That's not all just technical. There's more to it than that. So it's a misnomer to say, I saw a little bit of underexpansion, that must be the cause of all of this. It's true that it's associated with it, but there may be other causes. Anyway, the ACC/HA guidelines committees have finally upgraded imaging to a 2A recommendation. I think they got it wrong. I think that PCI without imaging should be a class 3 indication, and I don't think it should be reimbursed. And then we have to do our part by understanding how to interpret the image so that that cost is worth it and that we get the full benefit of the IVUS. This is that data Shinsuke referred to that in outside US studies of ISR, when they use a DCB and it's after the 3rd layer, the restenosis rates are 43%. I mean, if you put in a 3rd layer, you're condemning that patient to a life of misery. So just never put in a 3rd layer. Think real hard about putting in a 2nd layer. My general algorithm is if there's something inside the stent and it's a remediable problem, if I can get that stent expanded properly, then I've got the scaffold I need. All I need is the drug. If there's not a remediable problem, but it's outside the vessel and a new part of the vessel, it's an edge restenosis or a geographic miss, I will generally want to cover that up with stent unless I have an absolutely perfect result. So lots of different algorithms and way to do this. In the US, we're still trying to learn how, but this is all stuff that led up to the AGENT trial. You're all familiar with it. Quick slide on the endpoint, which was target lesion failure at 1 year, was 17% in the AGENT group, and it was 28% in the angioplasty group. That's an absolute risk reduction of about 10%, a number needed to treat of 10. Kind of easy things to remember. You got to do 10 DCBs to prevent one event had you done plain old balloon angioplasty. And all of this is predicated upon very short lesions. The longest DCBs we had in the trial, I think, were 25 millimeters. The lesions had to be short. They had to be totally within the stent. They couldn't be within 5 millimeters of the edge of the stent. And we had to have a good result with less than 30% stenosis. Interestingly, in the trial, imaging was only done 75% of the time. So we still don't think that this is optimal. I think we can perform better probably with both technologies had we imaged a little more frequently. But that's basically what led to the US approval for the AGENT drug-coated balloon. And this is where I thought it'd be fun to talk, because we've heard a lot about what can be done and can't be done in Japan, and what should, is, and how those are different. In the US, Boston Scientific decided, and this was strategy decided outside of the group that was advising them, to use the transitional pass-through cost pathway for device approvals and reimbursement in the United States. Again, I'm no reimbursement expert, but the bottom line is, if you have a novel device and it's expensive, and there's a threshold somewhere around $4,000, I don't know if that's a published number or something that they just alluded to, then CMS can issue a temporary code for payment, and they'll often attach strings. In this particular case, you're supposed to participate in a post-market survey, and they would only reimburse for on-label use. The other part of this is, in the US, we have different reimbursements for inpatients and outpatients. This is all Medicare Part B outpatient reimbursements. The inpatient reimbursement codes still aren't worked out, and it is still a bit of a problem for hospitals to be using DCBs on inpatients. But with the outpatient stuff, they finally, on January 1st, issued the final ruling. They are going to pay for every single DCB used in the United States. There won't be a requirement to be on label. I was told, and I don't have confirmation of this, but told that Aetna has followed suit, and they're going to reimburse for DCBs for outpatients who are getting angioplasty. And the company believes that multiple other payers are going to join in. I didn't know much about the TPC pathway, so I just went to ChatGPT for all my information. I think that's a good source for all of us. If you have any medical questions, let me know. I said, what's the process for TPC? And it's basically this manufacturer submits an application to CMS, and CMS evaluates the clinical benefit. They use the agent trial. They didn't use any other information. They used testimony from consultants, and they're supposed to be weighing the cost effectiveness. And that's clearly not being done. If approved, they grant a higher than standard Medicare rate for a specific period of time, often up to 3 years. And they're supposed to be paying for what they believe, or the company tells them, is the true cost of the device. In this particular instance, Boston Scientific told them it would cost $6,000 per device to release the device for clinical use, and that's what they were granted, a $6,000 per balloon reimbursement. CMS reimburses facilities by a separate pass-through code. I don't even know what that means mechanistically, but the hospitals are getting paid for the devices. You don't have to listen to your administrators complain, and none of the administrators are really upset about it who understand this transitional pass-through cost pathway. After that period of reimbursement, then they'll go back to a traditional payment form. And again, the purpose is to encourage innovation while balancing costs. So I also asked ChatGPT, what are the pros and cons of this pathway? And the whole thing was to encourage innovation. Those of us who are gray-haired enough to remember, after Partner One, the year and a half, I think almost 2 years, where we waited for CMS just to issue a payment code so we could give life-saving therapy to patients with severe aortic stenosis who weren't surgical candidates. So we had patients dying, waiting, because our hospitals wouldn't let us do it without getting paid. I think this was part of the response to that. This was first used successfully by Shockwave for IVL approval. And this is what Boston Scientific chose as their strategy for reimbursement. It's supposed to then allow them the time to get good cost effectiveness analysis. The cons of it are there's increased short-term costs. They're going to pay a premium for these balloons for the next 2 or 3 years until a competitor gets to the market and starts competing with those prices, if they will, if there's not a cabal. And there's potential for misuse without data. And that's what I'm going to show you, is how I'm going to misuse this damn device, because I've been waiting 10 years to get it. And I've seen some of my colleagues outside the US use it in very innovative ways. And that could also lead to disparities in access. There's a lot of hospitals that are followers, and there are a lot of hospitals that are leaders. The leaders are going to get access to technology, the followers aren't. And again, if reimbursement's not tied to effectiveness, there's going to be a perverse incentive for manufacturers to promote expensive technology when there's not really a great benefit that ultimately drives cost savings. So this is going to drive up the costs. So these are all things we're wrestling with in the United States. You may not have to. How in the hell they ever convinced CMS that this is a novel device, I have no idea, because these are all the commercially available DCBs. Europe has approvals for most of them in the coronary. Asia does as well. There are also peripheral DCBs, so I don't know how they made that. So what I did then was ask Simon Walsh, a friend of mine who did some work with Boston Scientific, to tell me about how's use in Ireland and Europe. And so he gave me this slide where he said there's basically three phenotypes of users. The skeptics, they're going to use it in ISR probably only after the second layer. They're the pragmatists. They definitely use it in ISR. And then anywhere they don't want to put any more metal. And these are all the scenarios where you might think DCB might be a better option for patients than a drug-eluting stent. And that includes things like small vessels. And if you look at the literature, most of the de novo lesion studies are done in small vessels, less than 2.75 is that definition. Side branches, 10 years ago, Kenneth Chen from Kuala Lumpur would come to our Hawaii meeting and present case after case, serial case after serial case, like Shinsuke's, where he did side branch treatment with sequent pleas and all kinds of other DCBs that he had access to long before we ever did. Bleeders, now that we have short DAPT, may not be as relevant. Future graft landing zones, this is something of particular interest, and it's a case I'll show, is can we reconstruct a coronary artery and make it a graftable artery for diabetics who have poor targets or other patients with diffuse disease. Existing graft anastomosis, if you have a graft anastomosis, a distal anastomotic lesion, the first year it does great with POBA, maybe even better with DCB. But as a CTO operator, I would just encourage you to never stent those. It just makes life harder when they occlude to get the native vessel open. And CTO outflow, that's where I'm going to be using a lot of these. We get a lot of shrunken vessels, a lot of distal disease, a lot of things that impede outflow through our full metal jacket stents in the right coronary artery after CTO PCI, and that's a great place, I think, for DCB. And then some people are advocating it, just like, Greg Stone is now talking about prophylactic stenting to prevent ACS in vulnerable plaques. You have a STEMI and a patient with a non-obstructive lesion, probably an ulcerated plaque that may reactivate. Maybe that would be somewhere you could apply this. And then he says there are enthusiasts and they use it for just about anything. I don't care. The DES are only for bailing out bad dissections. This is the BSIS registry sites, and you can see that the frequency of use among PCIs between centers is everyone 37% of cases, or 37% of patients are receiving a DCB, all the way down to 0% on the right-hand side of the screen. So there's tremendous variability in use. And one of the things that I think is more frustrating than anything is the data that is being developed is okay, but it's just not large, multi-center randomized trials. There's a lot of little trials, and I'll show you some of that. But first, let's look at a case example. This is a 51-year-old who I took care of, I don't know, maybe a month ago. And she was referred for CTO of the proximal LAD. She's 51. She's diabetic, type 1 diabetic. She's got no disease in her right coronary artery, no collaterals to her LAD, a very short stump occlusion of the proximal LAD, and then some left-to-left collateralization distally. This was really fairly simple to cross. I took a Supercross 120 microcatheter to point me up so that I could put just a tiny little CTO bend on my Gladius wire. I wired the Gladius all the way downstream, exchanged the Supercross out for a microcatheter, took the microcatheter down, exchanged for a workhorse wire, and then did a proximal balloon inflation with a 2.5 millimeter balloon. This is when you wait for that aha moment. It's like, oh, when you restore antegrade flow to some of these vessels, you get an immediate, flow-mediated vasodilation. But in this particular case, it's just crap. The vessel looks shrunken all the way down. So I took a 2.0 chocolate balloon very distally, a 2.5 more proximally, and ballooned this whole thing and then did IVUS. And I did the ballooning so I could get the IVUS all the way down. Again, this is after nitro, after chocolate ballooning, and on the right-hand side, you'll see the IVUS run. This is from way downstream where the vessel's maybe 2.5 millimeters. It shrinks down to a 1.5, millimeter vessel. This is negative remodeling, but you can see also areas of Glagovian remodeling, suggesting that there's also plaque within it. That's just totally negatively remodeled. It's cinched down on the IVUS catheter. And then as you come back, you'll see more proximally that there's lots of diffuse disease. Not having a clue what to do with any of this, I said, what the hell? I'm going to put in a 3.028 drug-eluting stent proximally, post-dilate that with a 3.5 NC, and then take all that mid-vessel disease and see if I can just do a plain old balloon angioplasty and take advantage of what some people are describing, which is positive remodeling that occurs after drug-coated ballooning. And so this is her final result. So hopefully with a little bit of massaging and a little bit of time and a little bit of drug without scaffold, we'll get a better vessel. I can't really show you that right now. What I can do is show you a case that I lifted off the internet by Shin's paper just recently that shows an LAD lesion on the left-hand screen. Tight lesion involves two little diagonals. This is after DCB. They don't even meet the criterion of 30%. There's more than 30% stenosis and there's a residual dissection. That's supposed to get a DES, but they didn't. And this patient came back 3 years later and that segment had completely healed. Looks really fantastic now. And there's a new lesion down there in the distal cert. And so that's the remodeling effect, the hope for remodeling that we're hoping for with this lady who we're trying to reconstruct her LAD. So before I finish, I would say a word of caution. I'm not going to go through all the data now. We're running out of time, but this is a patient who was 46 years old. He has been all over the country trying to feel better. He got bypass surgery. This is pre-op film. You can see there's a little first obtuse marginal, and then there's a PL system down below, a first and second PL system. And he came to Mahi because 4 times somebody had tried to open that second PL branch that you see down there distally. They put a stent in the AV groove segment extending into that PL segment. They had dissected it, had reopened, they had tried it again, 2 different centers around the country. He came down for the world famous JAG to help him out. And boy, did I do a great job for him. Look at this. I got that first OM opened up and stented, and we IVUSed it, and we had great IVUS outcomes. I got that PL branch, and I did DCB at the side of that PL branch. I even stuck a coil in the jump graft segment to keep from competing so that we wouldn't have competition that caused my native vessel to close. And he came back a month later just to look at it and do some stage stenting, and shit, everything's gone. So that's my word of caution. All right. So what are the other uses for DCB? There they are listed. I showed you a few examples of those. I really look forward to, I would like to hear from our panelists who have all this experience with DCBs about what are the most fruitful targets and what are the things you think we should be doing. I'm going to fast forward all the way to the end without going through all this data and say one thing, and that is, the agent DCB from Boston Scientific is approved for use in ISR by the TPC pathway. The number needed to treat is 10 versus POBA to prevent 1 TLF, but stent optimization first requires imaging and a host of devices that enable that optimization. One thing I haven't heard mentioned are the OPN balloons. I find those to be incredibly valuable, especially when there's multiple layers of stent. There's no energy that's going to get outside of 2 layers of stent. But if you can get an OPN balloon up to 40 atmospheres, you just might crack it. And then I wanted to say, I hope the genie's not out of the bottle. I hope Boston Scientific is going to make a crap ton of money off of the U.S. Market, charging $6,000 when everybody else gets to pay $500, which seems to me to be inherently unfair. But if they make a bunch of money on it, they better support education and they better support the research we need to find out if there's going to be applications for these devices that make sense outside of ISR. That's my baby granddaughter, and that's all I really care about.
Any comments from our panelists who have been using drug-coated balloons?
Yeah, it's very surprising that price is quite different among countries. In Japan, the price of the DCB is about $1,200 US, so quite different. So if you have a chance to visit Japan, you should buy a lot of DCB and sell in United States.
Would it be duty-free in the airport?
I'm going to need a little advice on how to run that company. I'm sure there's some entrepreneurs in here who can help me.
Next up, we have Dr. Crescent, who's going to speak to us about planning using coronary CTA.
And Chiefs are up 20-12 because I know you're all interested.
Yeah. All right. So last talk before our case competitions. So I'll try to get through this as quickly as I can. It's a vast topic, obviously. Nothing's changed with my disclosures. So, when you talk about cardiac CT, it's kind of an evolution. So I think you at least have to do a preliminary scan of, how we got here today in terms of data, which really took a quantum leap forward once FFRCT had been proven as a useful modality, because it then enabled us to take a 20% subset of patients that we were unclear about and cleared up with physiology. Since that time, several studies have showed utility in very difficult subsets of people, which I'll kind of quickly go through. And as Greg Stone talked about yesterday, there's probably an advantage to CT angiography in the sense that it can give you a full vessel assessment. So it's not just the lumen. You can see the entire vessel and get an idea of the plaque, and there's a scoring system, and there's data tied to the scoring system. And then you can plan PCI definitely with the use of CT ahead of time. So this is kind of the problem. And, when all of these new technologies come in that are potentially disruptive, we always have to keep in mind that when we're talking about patients, we need to figure out a few things. We need to figure out, who truly has no coronary disease, because those people do exceedingly well. Who needs medical therapy? This is the part where maybe you're not quite diseased enough to be ischemic, but you're not normal, so you need to take your medical therapy. And then if you do need an intervention, we've talked, for 2 days about how to do your intervention or potentially go on to surgery. And so here are the, traditional pathways. They all have their problems, but, it's been an evolution getting CT past some of these other modalities. And the way CT got past it basically is by giving better information as the technology got better. So as CT became more reliable and more reproducible, it kind of left some of these other modalities behind, to the point where some insurance companies take a CT first strategy and they simply will not reimburse another modality. So what I mean in terms of, full vessel analysis is this scoring system, which I'll explain in the next slide. But basically, we know now with high volumes of patients, one study I think was 12,000, the other might have been closer to 20. But if you truly have what's called CAD-RAD 0, you truly have a normal coronary vessel. And we know through these observational studies that those people over 10 years basically have no events. When you get a little bit of disease, so CAD-RADS 1, CAD-RADS 2, so that's going to be anywhere from 1 to 24% or 25 to 49%, they have exceedingly low levels of events as well out to 10 years, but not 0. And then as you progress, obviously, the outcomes change. So this is the reporting system. We've been using this on all of our CT reports. It's something you can build into Epic or whatever your EMR is. And it's very useful information for the referring provider, because again, there's a big difference between 0%, we don't see any plaque or any stenosis. That's somebody that can basically do whatever they want. And then as you have a gradual progression in disease, it's mainly the mainstays medical therapy. The big area where the fork in the road to physiology or something like perfusion CT and some of these other modalities is really a CAD-RADS 3 phenomenon. So that about 20% of the time you see moderate disease, and you can spend an inordinate amount of time looking at these vessels and you're never going to figure out what you think. So these are people that really benefit from further analysis. Once you get to CAD-RADS 4, you need to go to the cath lab. And so that's pretty straightforward. So between CAD-RADS 4 and everything up to 3, that represents probably 80% of your total CT population. In terms of guidance and management of patients, we have 2 studies here that show that the use of coronary CT actually has hard endpoint benefit. So Scott Hart was the very first one to show a 41% lower death and MI rate at 5 years. Prior to that and since that, the strength of CT has mainly been avoiding other procedures. All right, so when you look at FFRCT compared to other modalities, the enhancement of CT with FFRCT gives it an area under the curve that frankly in most studies is better than just about everything out there. The one caveat being PET CT, there's been no correlation to PET CT, and there's been a resurgence in different MR techniques, and so we don't really know for sure how it compares, but it's very, very good, and it's become a lot faster. So it's a lot more usable on a day-to-day basis. So that led eventually to the ACC and AHA chest pain guidelines changing and making basically a class 1, level A indication for using coronary CT. And I think that's with the understanding that there are going to be times when you need to add FFRCT. And the study that really pushed that forward was PRECISE, which I was happy and glad to be a part of. And basically, it was promoting a CT first strategy versus the usual pathway, which was just a mix of stress echo, nukes, whatever else people were using. And what it really showed is, the endpoint was significant, but it really was driven by this phenomenon. And this is like one of those things that we talk about at our board meetings, because we, have to talk about the business side of things, because, running the CV service line. And so at first, your hospital administrators will be very confused as to why your PCI volume remains the same or increases at the same time that your total cath lab volume is decreasing. And the reason why it's decreasing is you've just gotten rid of all of the diagnostic coronary angiography. So what our cath lab has become is a very target-rich environment. If you make it to our cath lab, there's a very high chance that you have real disease that needs to be fixed, and the other stuff has been sorted out non-invasively. And you see here, same phenomenon. It's just, if you take a precision strategy with CT compared to the usual strategy, you're going to hit the endpoint, but it's really driven by the elimination of a lot of diagnostic angiography. And these are other bars, bar graphs from the study that show the same thing. And the importance is that whether you look at platform, you look at PRECISE, you look at whatever study you want to look at, as you come down the two pathways, when you get to the bottom, the same amount of people are being revascularized. So the reason why I've always viewed this and viewed it in training as an opportunity was that I never thought of it as the enemy of the interventional cardiologist. I thought of it as a synergistic thing. So the same number of people are going to get revascularized. It's just how you get there is going to be different and frankly better. I don't enjoy doing diagnostic cath. And maybe some people do. I don't. So then we move on to some other studies like the ADVANCE registry, where you look at 1-year impact on clinical outcomes of FFRCT. And again, if you break these patients down by what you see visually, using 50% as a cutoff and an FFRCT value of 0.8 as a cutoff, you see clear benefit out to 1 year with the CT pathway. All right, and so this is just, another breakdown of the different groups. But all of this has been just, an evolving body of data. And for years and years and years, there was a criticism of CT that there was no data. There is a ton of CT data, and particularly CT with FFR data. Now, moving into some other areas where, you had some staunch opposition. So we have the ReAssess trial here, and that's looking at CT with FFR in stable coronary disease with SPECT perfusion. SPECT perfusion still remains probably the most used modality. And so the people were broken up by disease severity. They either got a SPECT or they got FFRCT. And then a lot of them went on to the cath lab where they got actual FFR. So it kind of dates the trial a little bit because IFR was never really included. But overall, you see, there's actually pretty good agreement between SPECT and FFRCT, but it's really when you got the people to the actual cath lab that FFRCT had more agreement with invasive FFR versus SPECT. And so, it was another trial to kind of separate CT and FFRCT from SPECT. And these are just examples of patients, and what they looked like in terms of their CT imaging, SPECT, and then when they moved on to invasive coronary angiography. The strength of FFRCT, again, is negative predictive value. I talked a little bit about that yesterday as it pertained to angio-FFR. So if you're starting somewhere with a test, you have to decide what you really want to avoid the most. And I think as cardiologists, what we really want to avoid the most is missing something. So if we have a few false positives along the way, that's not nearly as bad as getting a phone call like I got like 6 or 7 years ago, where someone left my hospital and went back to one of the places I have outreach clinic, and the son called me to tell me his dad had fallen over dead in the driveway, and I was calling to tell him that the nuke was normal. And that's a horrible situation. And that's a place where CT really helps because it's an anatomic thing. You can't really be fooled by things that can fool you with SPECT. So the strength has always been negative predictive value. Once you've established that, as the technology's gotten better and better, then you can start talking about sensitivity and specificity also improving. And so Jonathan Leipzig, who's been a kind of a luminary in the CT world, put out a paper where he just kind of also started to look at what happens if you use FFR-CT to plan procedural guidance and really compare it in it. And what it does is it helps you reclassify people. And the importance of reclassifying people, again, is not going to really affect the number of bypass surgeries or the number of PCIs as much. It's gonna rearrange who really needs to move on to cath and who doesn't. It really teases out the people that you can medically manage and avoid invasive procedures. So difficult patient subsets, of which there are a lot. Okay, so just like with real FFR, having a gray zone, FFR-CT definitely has a gray zone. It performs pretty well, but in these sort of areas, and there's a pattern that I think I have a case example, I may show it. There's a pattern that you see with FFR-CT that's very similar to the pattern that we've seen over the last few days with IFR, where if you have a very slow, gradual, diminishing flow, and it's only at the very apical segment of a vessel that FFR-CT is positive, that's just long areas of diffuse disease and probably an area where you're just going to go with medical management. It's very different than having a discrete cutoff. So sometimes when you're in this gray area, you just have to make a decision and just be their cardiologists. And this is where I think we can remain employed and not be replaced by, Watson or some other, robot. And then high calcium. So there's reasons why FFR-CT has gotten better and better with high calcium, and a lot of it is technical stuff with the scanner. My last few slides will really demonstrate that. So there used to be a very, well-known abrupt cutoff of 400. If your calcium score is 400, you didn't get a CT. You had to go get some other test. Now, routinely, we'll push that into the 700, 800, 900 range, and it just has to do with improvements in spatial and temporal resolution with some of these newer scanners and your ability to debloom calcium so that you can see better. What about acute chest pain? We've talked a lot about, what happens, with stable people, but this trial and the next one really is the one that shows the ER population, because that's always been a question for people. Now, this is another calcium study, and again, it just broke patients down by calcium score and the FFR-CT, and this was really the study that kind of moved the bar from 400 to 700 or 800. And that was kind of the strength. And this is a busy table, but if you tease it out, the bottom there shows the different breakdown of Agatston scores. So as you moved up to even greater than 1,000, you still had pretty reasonable performance of FFR-CT. And that's why you saw kind of a movement of people to quit having these really harsh cutoffs at lower levels of calcium. And this is just another graph showing negative predictive value and the other things that we talked about previously. All right, so what about in the ER? Because now we're talking about plaque that may not be stable. And so that's always been an interest of a lot of people. And, Greg talked about that yesterday. There's some active plaques that aren't going to show up as positive by invasive modalities. And the reason why is because this is where the ability to look at the whole vessel helps you out. Because here you can appreciate that there's a lot of plaque. There's a lot of plaque in this artery. It's not physiologically significant, but there's something about that plaque that may be the reason why someone came to the emergency room. And so, this is an evolution. I think that while this study was kind of favorable, I think it's still a gray area, but it just shows that, the evolution is moving from stable to more unstable patients and still being helpful. And this was the bottom line of the study. So it more or less helped ER physicians triage people a little bit better. But again, you can see a plaque like that. You can say that it's not physiologically significant, but you see the huge plaque burden. So that's somebody that doesn't leave the ER and you say, good luck. They leave the ER on high dose statin, PCSK9 inhibition, maximal medical therapy from the time that they leave the ER to when they're able to actually get in and see their cardiologist for further follow-up. So it's an amalgamation of anatomic information from the CT as well as the physiology. And you see here that as a strategy, it was pretty safe. So, even if things aren't perfect, as long as you're not having a lot of really horrible outcomes, it means that there's certainly promise for the future. And from an economic standpoint, this is kind of a mixed bag. But overall, the strength of CT economically has been just the ability to be one-stop shopping. So you get one test and then you go home. Now here, it didn't turn out like that because the positive people left the ER and went on to get a cath, so that added cost. So that's the one part about the study that's a little bit confusing in terms of all the other data. But generally speaking, the strength of CT from an economic standpoint is the reimbursement's always been bad. It continues to be bad. So it's great for insurance companies, and it usually saves people money because they don't have to have a lot of additional testing. All right, what about people with severe AS? So, a lot of times when we're doing CTs on people who need a transcatheter valve, we would like to not have to do other procedures, but sometimes it's not possible. But in a lot of instances, it is. So same deal. You take people that, have severe AS, you send them for a scan. The people that have moderate disease, you get an FFR CT on them, and you see that for the most part, that group of people has a high negative predictive value. So at least you feel reasonably comfortable moving forward with your transcatheter valve procedure, that you're not going to have a coronary event that's going to mess everything up. And this is the comparison to invasive FFR on a per vessel and per patient analysis, and you see that it correlates quite well in both categories. And then long-term effects, this was kind of an interesting thing with FFRCT. So 25 patients with severe AS underwent coronary analysis, and what was measured was total coronary volume, LV mass, and their volume to mass ratio before and after SAVR or TAVR. And what happened is that and the reason this is important is that there's been this idea that in settings of LVH and other hemodynamic parameters, FFRCT won't be accurate. But in this study, you see that even after the valve was replaced and the LV mass decreased, the FFRCT remained reliable and constant. So that makes us feel better about the difficult subset of the population that has LVH and other things that were thought to maybe mess things up because of microcirculatory effects. All right, in terms of planning and plaque analysis, just like there's what we saw with Philips with the IFR planner, there's a CT planner, and so you can get your CT angiogram, you can get the FFR CT, and then you can sort of put in where you would revascularize and put a stent in, and then it gives you predicted post PCI FFR. So this is still very much in the works, but it just shows that it's a continuing evolution, and these are further case examples of that where it can help you sort of plan your entire procedure ahead of time, which I think is great. All right, so I'm gonna move ahead because we're running out of time. So what about vulnerable plaques using cardiac CT? All right, so you see here again, this is IVUS and angiography. And you see the breakdown of the different modalities, and what we're starting to find with coronary CTA is this bottom line. So you're starting to now see inflammation and areas of inflammatory areas around the lumen that make you think of vulnerable plaque. And that is beginning to become more of a thing. Now, the issue is the same with IVUS, is you don't know what to do with it when it's not significant. So if you start seeing 30, 40, 50% lesions, it doesn't really make you want to treat it invasively, but it would help you at least ramp up medical therapy. So it's another area where CT is starting to move and characterize plaques a little bit better, which should help us make better decisions in terms of taking care of patients. This is a breakdown of one of the patients. You see the cross-sectional area that correlates with the FFRCT. And what you see here is, again, you've got a narrow lumen. Okay, so that's not a surprise. All the stuff's ischemic. But then this area around here is what is the inflammatory and thought to be vulnerable area. And so, that just gives you a little bit more information about what you're getting into in the cath lab. So in terms of planning, obviously you can get a CT, you can see calcium, you can do your angio, and then you can plan on taking them to the cath lab. But if you know ahead of time that you're running into heavy calcium, it doesn't really surprise you when you need to use rotational atherectomy to do your case. So, all of that information is ahead of you or is in front of you, so shouldn't be a big deal. So in the interest of time, I'm going to skip ahead to the last part because the evolution in some of the technology has really been striking. All right, so we've already talked about all of this in terms of procedural planning. Now, this is evolution in technology. So this is the Siemens system with photon counting, and how it's improved things is the fact that you move from, a step where X-ray has to be converted to light to be converted to current. You take the one step out. And when you take the one step out of X-ray to light to current, it has improved the ability to have better spatial resolution. And so you now have, smaller voxels. I think the average voxel size is down to 0.2. And then temporal resolution is the time by which you acquire the image. So even with the best scanners now, you can't really beat a dual source. Okay, so by using two different sources of radiation, you're able to get a rotations down by at least 50%, which helps with temporal resolution. So if you now have a technology that has better spatial and temporal resolution, you're going to get some really, really impressive pictures. And so the reason why I show this, these next two slides, and that's it, I promise, is that you can start to really get into some difficult sets of people. Stents, high levels of calcium. So here you see the reduce in calcium blooming and metal blooming artifact on that left side. But this case right here is crazy. I can't imagine someone having a calcium score of 5,808 and you say, yeah, let's just do the CT angiogram. I mean, to us, we'd be like, there's no way. But the technology has gotten to the point where they can literally remove almost all of this calcium and you can see what's going on. And then that enables you to take this person who most readers would say is lock, stock, and two smoking barrels, a CAD-RADS 4 or 3. And really, when you look at it, it's actually pretty mild to moderate. So, with that, and I know I covered a lot of territory, but it's still a very exciting field. It's still evolving. But some of this stuff is really, really pushing the field forward and is going to make us much, much better about what we do. So there's an enormous amount of data. It is definitely not your enemy. The payers already like it. The guidelines are endorsing it. It can help you with your plan. And the data is continuing to get better and better with difficult patients. Thanks.
So George, or anybody in the audience, I actually learned at TCT that NHS, the British reimbursement system, has stopped paying for perfusion imaging except CT-FFR. They have implemented the recommended strategy, and they're sending every one of their questionable cases to HeartFlow for a HeartFlow interpretation of CT-FFR, and they're not going to be doing. They didn't do a lot of perfusion imaging. They were still doing treadmill exercise tests, but now it's just right to CT, and if there's a question, CT-FFR, which ought to tell all of us where we're all going to be pretty soon.
Yeah. So what's interesting about that, and obviously, I already had like 1 million slides in there. About a year before the ACCHA guidelines changed, the NICE guidelines had changed in the UK. So it was probably more that the NHS changed how they did it that pushed us more than the just vast amounts of study data. I think at some point they figured, man, if the British are even paying for this, then we have to get on board. I mean, but it's very interesting. Let's take a break and then
Well,
come
that's a
back
wrap
to
for
base
this session.
competitions.
Take 5 minutes and come on back. Chiefs won.
I hau kue I te anu hau oki o Kaleponi. E o kalawahine, e le wā o Kaiona. Alua mai I ngā o e kahapua o mai. O ka hua hani konua, o anu o ke kopalau. Kuoa o ka maluki, malukukui o ka hoki mai. Ia ai ka melina, kare ne e aka o hena maha. Kua kua I ka noe, mo hana I te anu. Noko no me ka anoki, ka mana o ia loko. O loko hana nui, a upole I te ana ia. E o ka wahine, e me ngā o Kaiona. Alua ai ula o ke kahapua o mai. O ka hua ani konua, o anu o ke kopalau. Kuoa o ka maluki, malukukui o ka hoki mai. Ka wailele o nia kama, I te ika vai anue nue, I ka o ai aka ehu, a riki paka I laila, kue ana I ka ehu mai, kukuku I te kope, eia I ho kane hana o ka poni o I lei. E o ka wahine, e me la o Kaiona, Alua ai ula o ke kahapua o mai. O ka hua ani konua, o anu o ke kopalau. Kuoa o ka maluki, malukukui o ka hoki mai. Kuoa o ka maluki, malukukui o ka hoki mai.
Maybe you should skip work, baby. Take a little trip with me today. It's summertime and I wanna know if you wanna go out to the country. Lay out on the beach till it gets late. We'll take our time, there's no place to go. Summertime in the mood, it's right. Out in the ocean in the middle of the night. Out in the eye, no waterfall. We can do it all. In the summertime in the mood, it's right. And if you wanna, we can go for a ride. While we play your favorite song. We can do it all. 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 Never thought I'd find a lady put up with my wild and crazy. But I'm so proud that I found you. Yeah, like the breeze in the sun, it's shining. I believe it's the perfect timing. We could meet and spark love so soon. Summertime in the mood, it's right. Out in the ocean in the middle of the night. Out in the eye, no waterfall. We can do it all. In the summertime, in the mood, it's bright. And if you wanna, we can go for a ride.
Yep.
While I play your favorite song.
All right, let's get everyone to kind of quickly take their seats, get our panel up here. We've got something that we are starting this year that I think it should be a lot of fun, and hopefully we'll keep going, is a case competition. So we've broken it up as best we can to different regions of the world, and hopefully everyone will enjoy this. So to get us started, we'll have Dr. Hirohata come up and present.
Can you start? Okay. Okay. Right. Good afternoon, everybody. And the title of my presentation is Contrast Enhanced ELCA for Underexpanded ISR region, facilitated with guide extension catheter. Although stent underexpansion remains an important risk factor for stent restenosis, management of ISR region with underexpanded stent remains a technical challenge, mainly due to peristent severe calcium. ELCA was introduced around 3 decades ago to treat complex coronary artery disease, including ISR. ELCA may be effective to treat undilatable calcified region because the region also typically have heavily calcium outside the stent strut. Recently, efficacy of ELCA with simultaneous contrast injection for the treatment of stent underexpansion has been reported. However, there is some technical difficulty cross ELCA catheter beyond the region due to a large profile of catheter and originally underexpanded stent. Also, simultaneous ELCA procedure with a lot amount of contrast may result in vapor bubble and slow or no reflow within coronary artery. And this is a strategy of our guide extension catheter facilitated contrast ELCA in a hospital. We use a guiding catheter, mainly 6 French to 8 French, and usually use a guide extension catheter. I recommend 6 French guide due to larger inner lumen, and simultaneous contrast enhanced with 0.9 millimeter ELCA catheter and with a maximum power 80/80 for short duration. I will show a case. And this is a restenosis of right coronary after stenting. The previous procedure was completed without full stent expansion, as shown here. And predilation seemed to be under expansion. And we perform contrast ELCA using a 0.9 catheter, using an 8 French guiding catheter and 6 French guide for 10 times, as shown here. And after make some post-dilation and DCB. And this is the final angiogram of this case. And this is the second case. This is also the ISR case of right coronary. And the tight instant restenosis was found of middle of right coronary artery. And predilation seemed to be very underexpanded of the balloon. So also, we perform contrast ELCA using 0.9 catheter, using a 6 French guiding and 6 French guide with a maximum power about 12 times, as shown here. But this is a kind of the complication of the contrast ELCA. Excessive contrast ELCA without sudden flashing can cause this kind of vapor bubble, as shown here. And post-dilation was performed, as like here, and similar to beta expansion. And this is the final angiogram after DCB. And this is the third case of ISR case of RCA. This was the second attempt. Last ISR PCI was finished with undilatable stent, as shown here. As presented here, 2-layered stent with under expansion was found. And we performed contrast ELCA with 6 French guiding and 6 French guidogira and 0.0 catheter with a maximum power about 10 times, like here. And post-dilation was performed and seemed to be better expansion of undilated stent. As compared to the pre-ELCA, post-ELCA and POVA seem to be a little bit better expansion of undilatable stent. So in conclusion, contrast-enhanced ELCA seems to be increased its effectiveness and allows the successful completion of under-expanded ISR cases. Guide extension catheter makes this procedure simpler and safer. Thank you.
Excellent. So we'll welcome Dr. Matsuno, who is our next presenter.
So good afternoon, ladies and gentlemen. It's a great pleasure to share my case. Actually, my case is not so complex, so a bit interesting case. This is my disclosure. And the patient was a young gentleman, and he had multiple risk factors. He developed angina and CAG revealed triple vessel disease, including RCA, CTO, and LAD PCI had been performed before RCA, CTO, PCI. But actually, this case was performed by myself. But this is a case not in Japan, but outside Japan, actually in Thailand. And the first and the second attempt CT was performed by local doctor. So this is the initial angio. The proximal RCA was occluded, and you can see the PLV is applied via the Kugel's collateral. And left coronary angio shows very diseased distal vessels, and mainly supplied via septal collaterals. Anyway, the local doctor started from the antegrade approach using the XT, Filda XT, and Gynex2, but the antegrade wire escalation failed, so she moved on to the retrograde approach via septal collateral. After a collateral channel crossing with wire and microcatheter, finally, the retrograde wire was crossed to the proximal true lumen, fortunately, and guide wire externalization was established. And pre-dilatation was performed, but I don't know the reason, but she lost the wire position after that. And antegrade shot after losing wire position revealed huge dissection from proximal RCA beyond the crux. The wire seemed to be crossed to the PLV, but IVUS revealed the wire was located in the extraplaque space. So balloon dilatation was performed for extraplaque space, like a subintimal plaque modification technique. And this is the final angiography at the first attempt. There was a residual huge dissection all the way through RCA. 2 months later, the local doctor bravely attempted this CTO again. And this is the first shot of the second attempt. You can see the residual huge dissection, and PDA was almost occluded. Again, the workhorse wire was advanced to the PLV, but IVUS revealed the wire was in the extraplaque space. So again, balloon dilatation was performed, and the procedure, second attempt CTO PCI, was terminated with unsuccessful result. This is the final angiography at the second attempt. After that, I was asked to do the third attempt CTO PCI for this case. And this is the first shot. So I injected contrast from antegrade guide very gently with a guiding catheter, 7 French JR4. And you can see tight stenosis at the proximal RCA. And the lumen was very very smooth. And on the RL view, you can see very smooth lumen of RCA. Of course, the PDA was occluded. Actually, there was no interventional collaterals from left coronary artery. Workhorse wire, Sion blue, was very easily advanced to the suspected true lumen of PLV. So at the first glance, I thought the RCA had been reopened after the absorption of the extraplaque hematoma, but the life was not so easy. IVUS revealed the residual lumen was all the subintimal space, and you can see the true lumen like this. And you can see very small true lumen, blood speckle of the true lumen. So how do you treat? So there was no interventional collaterals, and there remained a huge dissection plane. So because I am a Japanese style and I have a much experience of the IVUS guided wirings, so my treatment option was IVUS guided wiring, and I established ping-pong guide system, and the IVUS was advanced over the first wire placed in the extraplaque space, and Carabel microcatheter and the high penetration wire Conquest Pro 12 ST sharpened tip was advanced through the second guide. And under the real-time IVUS guidance, I successfully punctured the very small true lumen like this. And after advancing the Carabel over the Conquest, and the wire was de-escalated to the Sion, and Sion was advanced to the PLV. And after 2 millimeter balloon dilatation, IVUS revealed now the second wire was in the true lumen, and interestingly, in the first wire in the extraplaque space. After that, the PDA was wired with a Sion Black with the support of the Sasuke dual lumen microcatheter. And IVUS after that revealed a PDA wire was obviously in the true lumen of the PDA. So after dilatation for the PDA, drug-eluting stent was implanted from distal RCA to PLV with a modified gel balloon technique. And additional stent was implanted for mid portion. And angiography after 2 drug-eluting stent implantation showed a patent PLV and PDA. So I removed a PDA wire, and I additionally implanted for all drug-eluting stent for proximal portion. And final angiography showed a good result. Of course, there remained considerable extraplaque hematoma at the distal vessel, but the distal runoff was very good enough, so I decided to leave it. So in summary, repeated contrast injection and extraplaque balloon dilatation after losing wire position enlarged the extraplaque space, making the situation more complicated. Unfortunately, in this case, there was no retrograde option, so IVUS guided re-entry was considered to be the last option. and it was dramatically effective in achieving success in third attempt RCA CTO with large patent extra plaque space. Thank you very much for your kind attention.
Yeah, this is a wonderful and the demonstration of the Edwards and use the ping pong guiding catheter. But why we use the ping pong? If 7 French guiding catheter, you can accommodate the micro catheter, right?
Yeah, exactly. But I had sometimes I use the Boston Ivers, and sometimes I feel friction within the single guide with the Ivers catheter and the Caravell's microcatheter. So to make the wire manipulation more comfortable, I selected the ping pong guide technique.
Okay, thank you. And also the other question is you use the CP to puncture the true lumen, but it looks like this Edwards we can see some still some blood flow the signal there. So it means the true lumen not totally CTO.
Yeah, exactly. So on angiography, I couldn't confirm the true lumen because that size was very small, but you're correct. According to the Ivers findings, there was a residual blood flow on the true lumen. So, but I couldn't find any blood flow both from the antegrade and retrograde angiography.
Yeah, yeah. And but if in that way, where you puncture use the CP?
Very good point. Thank you very much. So I found a very small true lumen at the mid portion of the RCA. So I punctured the proximal true lumen proximal to the PDA to preserve the bifurcation.
But finally, why you? I didn't check to see the full pullback of the Edwards. Actually, usually we pull back Edwards from the distal, from the extra block to the true intra-block, the connecting area, and usually we puncture.
Exactly. Very important comment. So traditional Ivers guided wiring is the rewiring from the transition point from the true lumen to the extra plaque space. But in this case, I performed Ivers guided like an ADR from extra plaque space to the true lumen.
Why?
Yeah, because the proximal, at the proximal portion, the extra plaque space was very large. So it means the puncture from that space to the plaque seemed very difficult.
Thank you so much.
Thank you very much.
Okay, we're ready for round 2.
Yeah, dear Chairman, I'm going to present a case. It's a challenging case, combined rotor and IVL for treating a severe left main calcified lesion. And the patient is a 57-year-old male, and he was admitted to the emergency department because of tetanus and chest pain lasting for 1 hour. And the patient sought the emergency treatment via the ambulance. The initial electrocardiograph shows the ST elevation in lead AVR and ST depression in the other lead. So the patient past medical history is significant for the hypertension. And the patient also performed a CAG 4 months ago in a local hospital, showed a severe stenosis of the left main coronary artery and also calcification in the stenosis in LAD. And the patient had no interventional treatment and for PCI and for intervention and for CABG. In the physical examination, the patient's blood pressure is only 83/65 millimeters of mercury, and the patient was conscious, but was in a very poor general condition. And the patient had hypoxia, so he underwent tracheal intubation and with mechanical ventilation. And this was the EKG at emergency department. We can see that the AVR is elevated and also widened QRS. So this indicates the patient is very severe and massive myocardial ischemia. And here is the coronary angiogram. And before we perform the coronary angiogram, we insert IBP for this patient. And the first picture, we show the left mean was totally occluded. Then we quickly perform a right coronary angiogram. The right coronary angiogram shows normal, but the left mean was occluded. And you can see that the patient from the left mean to the LAD was very calcified. So under the support of the IBP, and we quickly open up the vessel. But after we perform our IVUS, it shows the patient had very severe calcification. And the IVUS catheter couldn't pass through the lesion. So you can see there's a circumferential calcification at the proximal LAD. We use the balloon to open up the lesion because the patient is still cardiogenic shock. So we decided to put an ECMO support. And the patient condition is not very good, but hemodynamically is getting a little bit more stable. So we decided to send the patient back to intensive care unit because the flow has restored to the TMA3. And we perform an echocardiogram, shows the ejection fraction is only 24%, and the diameter for the left ventricle is 66 millimeter. And there's the severe hypokinemic over the anterior wall motion. In the intensive care unit, the cardiac enzyme is very high. It's up to the uncheckable levels. And also for the BNP. But after the treatment, the BNP is getting decreased. Then under the treatment of ECMO and IBP, the patient condition is getting better. So we decided to remove the ECMO 1 week later. Then after that, remove the IBP, and also patient also extubated. And discuss with the patient. Patient refused the coronary bypass grafting. So we decided to perform another intervention. So before the intervention, we still put our IBP, mechanical support. Then we decided to treat this lung and calcified lesion. So initially, we use 1.5 burr to depack the lesion, but unfortunately, the burrs cannot cross the lesion. Even the burrs in this part of the burrs didn't work. So we think maybe this part is quite very calcified. So we decided to use this IVL. So afterwards, we use the IVL to dilate deletion. After this 2.5 millimeters of IVL, and the balloon still cannot cross this part, but the balloon can cross over the proximal IAD. So we decided to one more time use 1.5 burn to debug this part of the lesion. So we repeat another rotational atherectomy, and mainly for this part, the mid LAD. So after the atherectomy, rotational atherectomy, we'll perform one more time of the IVL, 3.0 IVL. Yeah, because this part, the IVL still cannot cross, and the very circumferential calcified. So we decided to use another time of IVL. Then after the IVL, we use the balloon, NC balloon, to dilate the lesion to ensure the adequate lumen expansion. Afterwards, by the support of the Getzeder, we implant 3 stents. So this is the second stent, Trio by 29. The third stent is 35 by 30. And then final post-dilation with a high pressure balloon, which achieved the optimal result. And this is the final Eversource satisfactory flow in the stent apposition. So many pictures. Okay, so the patient was discharged. We follow up the patient every 3 months, and the patient ejection fraction has increased from 25% to 60%, and also the LV dimension decreased from 66 to 54. So this is a case presenter patient with very severe calcification and left main occlusion, treated by the mechanical support device, ECMO and IBP. And after the patient gets stabilized, we treat a very, very severe in the lung calcification by both of the rotational atherectomy and the IVL. And we use 2 rotational atherectomy and 2 IVL sequentially. And the patient achieved a very good long-term outcome. Thank you.
It was a very nice demonstration. You know, anyone have anything to say about the case? I mean, it's interesting how, the staged part of it, you know, I think a lot of us would have a lot of heartburn staging and sending people back to the unit and bringing them back down. So that was great. All right, go ahead.
I just have a quick comment and a question actually for the panel as well. So my strategy is always kind of use atherectomy, CSI rota, and then do IVL. Are people routinely going in with atherectomy post-IVL use as well? To me, the fracture planes make me a little nervous about atherectomizing after.
Yeah, I mean, I agree. I think it was just a situation where there weren't many other things working. But yeah, I agree. I mean, as a routine, I probably would not do that on a routine basis, but that case was extremely difficult.
Fractured planes or even dissection planes, you can still rota. So I think that safety side of things is okay. But I agree, like I usually would do a mechanical atherectomy first, followed by IVL.
Okay. Thanks for the Dr. Sen's invite to attending the ARCH. My case report is tackling Western nations prioritization and strategic approach. This guy is a 37-year-old male with a post-medical history of hypertension and type 2 diabetes. His chest pain is recurrent chest tightness for 3 years, hypertension with worsening chest pain for about 2 months. He is a smoker and never show the HDL-C is a decrease, and the EKG shows the poor RVU progression from V1 to V3, and the echo shows the LVD is 76 millimeter, and the EF is 13.2%. The CT shows the osteoarthritis is CTO, and the mid-disc of the RCX is also CTO, and RC is circumstances. We check the CG. The CG shows the left main is normal. The osteo of the RCX is total occlusion, and the middle of the RCX is also a CTO, a CTO lesion, and his RC, the pro of the middle of the RC about 19% stasis, and the distal of the RC, and the pro of the PLV and the PDE about 17% stasis. The patient refused to heart transplantation and to refuse to cabbage. So in this situation, which one, which vessel is first? So my strategy is the first PCI to RCX. I use the Gancaster 7 French EBU and Macaster, and use the first Y, I use the XTR. But unfortunately, SR going to the subintent mode. So because it's not the coronary reticular to available, so I use the parallel technique and use the double Neumann Macaster Suzuki, and use the second wire to the gas second. But gas second kind of easy to go to the true Neumann, so I change the Y to pen 200. Unfortunately, fortunately, the pen 200 go to the true Neumann to the distal RCX. So the pre-dilation and put two the diagonal stand to the RCX. This put two stand to the RCX as angiogram. And then we PCI to RC and use the 6 French as a Gancaster RCL, and use a run through Y and put one diagonal stand to the pre and the middle of the RCX. The result of putting the pre and the MC to the RCA, and one month later, I PCI to the LD because we do the bilateral angiogram. I'm going to show that distal of the LD, the vessel is very poor, and the antegrade, the success rate of the antegrade is very low. So my choice is directly united to the retrograde force. I use the Makassar, use the Carvel, and Y use the Xiang, and the through the PDA to Suffren. Suffren the septal, because the septal connector is CCO. So I separate from the use that Xiang to suffer septal connector to the LED. Fortunately, we suffer that LED and put the Carvel to the LED. When put the Makassar to the LED and make a tip injection. The tip injection shows that this all of the LED is the vessel is very poor. So I change the retrograde Y to the ITA and the gear to, but the retrograde Y is going to the subintimal of the left main. So I think it's time to begin to the antegrade. My antegrade is the microcatheter use the concept rule, and the first antegrade Y I use the gas third. And in this situation, the gas third is a pump the retrograde Y as a marker also, and use the gas third to puncture to the LED, and adjust the Y to the gasser to are nearby the retrograde Y. Fortunately, the gasser very nearby the retrograde Y, and to puncture in the true lumen of the LED. And then we put the concept rule to the distal of the LED and change the sample. Then we put pre-detonation and check the errors. Check that shows that this of the LED is a diffuse region, and his diameter is small. It's about 2.0 millimeter, and the flux is a calcium. And when we check the LD and we check the RCX, the errors show that also of the RCX is okay, but the pro of the RCX, the MLE is too small. So, a strategy to use the non-DCB combine to DS. And then we put one DS to the nearby the also or LCX. And then use a stand to cross over to the pro of CLD to the left main. This is a final result. After the PCI, the patient don't feel the tenderness or the nice chest pain. And 1 year later, we follow up the UCG. It shows the RD it decreases, and the EF increase from the 32% to the 40%. Key point of this case, I think, when dealing with a chemical cardiomyopathy with poor cardiac function caused by metatarsus lesion, it's not always the culprit lesion take first. It can be from easy to difficult. MCS duals may not use. For very difficult CTE, depend on the condition. It can be night from the recovery to anchory to improve efficiency. Thank you for the attention.
So there's a lot to unpack there. It's interesting. So the post-echocardiogram shows the LV has changed from 7.6 centimeters to 6.3. The EF's gone from 25% to 40%. That's kind of an unusually great situation, particularly with the left ventricle remodeling like that. And then, several people presenting cases have shown the phenomenon of ischemic preconditioning. That guy went through a lot in one sitting and made it through with flying colors. So that's pretty amazing. So before Jay starts, I need to announce the bingo winners. Number one is Eugene. I'm going to say it's Kalanichi. The handwriting is actually worse than mine. Is Eugene here? All right, so there's one winner. And the other winner with very nice handwriting is Gabrielle Montalbano. So once we're done, come see me and you can pick these up and get your prizes. All right, go ahead, Jay.
All right, so I'm going to change things up a little bit too. We've been spending a lot of time with the coronaries, but there's a lot of other types of things that we do as well. And so I'm going to talk today about a case of a removal of a chronically occluded Venetech filter. So these are my disclosures. When do we want to remove filters? When there's no longer indication to have one in place, reasonable life expectancy, and it certainly needs to be safe to be removed or converted. And especially when you see tilt, migration, or thrombosis, there's a lot of different types of filters. Many of these filters you probably don't even see anymore, but some are more conical in nature, but they have a higher rate of tilt. But they are typically easier to remove. The cylindrical ones, they don't cant as much, but they can be a lot harder to take out because there's a lot of points of contact that can be deeply embedded. And if you look down here, this is the Venetech filter. It looks like two different types of filters combined into one. So why do we want to take them out? Certainly in the United States, there's been a lot of litigation associated with this. They can migrate, break apart. This is a case of a filter leg that's in the lung. We've even had a patient cough out a filter leg before. This is one that's like shrapnel. It's just exited out of the IVC, now going off somewhere into the belly. And then you can see here's a strut that's exiting outside of the IVC, now poking into the aorta. And this is what we oftentimes will see as thrombosis and this is a Simon Nightingale filter. And you can see extensive thrombosis of the IVC. These patients present with massive swelling. So the strategy should be multimodality in nature. There's a lot of different techniques. I'm not going to get into all these things, but I'll show you a case. And many times these patients do require a lot of different approaches, both from above and below, in order to be able to get these filters out. And then a lot of times the cava needs to be reconstructed afterwards as well too. So IVUS is really critical. And so this is a very complicated formula. It's called Matteo mathematics. It's a way to actually reconstruct the IVC and iliac veins by using stent grafts, but this also applies to self-expanding stents. And this is something that I use very commonly when we do CRAB procedures, or aortoiliac reconstruction, but it can be applied to the IVC as well. And then you end up with this kind of container stent with a double barrel. And this is essentially where you would apply to figure out how you can achieve a double D inside of the IVC with those two iliac vein stents. So this is a 20-plus-year-old filter. The patient didn't even know when the filter went in. And based on the X-ray and CT, I thought it might be a Venetech LGM, which is possibly the worst filter you can have, especially to try to get out. Presented with chronic lower extremity swelling, severe dyspnea with minimal activity and extreme exertional intolerance. A lot of these patients develop what's called IVC syndrome. So when their cava gets occluded, 2/3 of the blood volume is not going right back to the right heart, and it's going through collateral. So these patients are extremely short of breath. And the lower extremity venous duplex showed a bilateral acute and chronic lower extremity DVT. So this is the first picture. You can see I've obtained access. I typically try to get as low as possible in the bilateral femoral veins. You can see extensive occlusion as well. And so now I've finally been able to get a wire through on both sides. And at this point, what we're just trying to do is to just get wires in place and start separating and delaminating the filter from the wall of the IBC as well, and also creating a channel on both sides. And so you can see that's kind of what we've done here. Now I've got some flow through the filter itself. After this, from above, I've got a laser in place here as well too, as I'm going to attempt to do some laser of the top cone to get it off of the wall. And we snare the top of the cone itself. So this filter has both a cylindrical component and also a conical component as well. And from below, I'm ballooning to try to break the tines apart so that I can actually get it off of the wall as well. So this thing here, these are forceps. And so sometimes forceps are necessary to peel off the legs from the wall, sometimes also used from above to peel the cone off the wall as well. You have to be very careful because you can pop a hole right within the IBC itself. And then the technique that I'm showing on the right-hand side here is the hangman technique. And so I've taken a catheter and then ultimately a wire and snared it together. And I've used it to kind of hook the top of the cone itself. And I'm going to use it to try to bring the sheath down and pull the whole filter through. After this, I've removed the filter. So essentially we pulled it all the way through and then it flipped in and out. And then at this point, I've taken a scraping tool. This is a clot retriever to clean off the clot off the wall. And after doing that, you can see we've got flow on one side pretty nicely here. This area down below is an area of perforation. Typically in that area, it's okay because usually it's fairly well contained, especially up in the belly and below the diaphragm. The omentum will seal off a lot of these perforations. In addition, it's also very low pressure, so typically bleeding is not a huge problem. And after this, I go ahead and I place a large wall stent up in the cava to seal off the area of occlusion, and that's a 24 millimeter wall stent. You can see that we're placing that, and I'm dragging it down to the position. And after this, we place 2 Abre stents inside of this. So that's the container stent. We have the 2 legs coming through here on both sides. After this, we have a very nice result here too with complete restoration of flow. And you can see the renal veins are patent above. And the patient actually did very well. So ultimately, the patient's dyspnea resolved. Swelling was markedly improved. This patient was maintained on chronic DOAC therapy with annual abdominal duplex to maintain iliocaval patency. And our hashtag for this is GTFO, which is get the filter out. Thank you.
What's the oldest filter you've removed?
I think 26 years. That's the average has been 14 to 15 years, but yeah, there have been a couple really old ones. At that point, it doesn't really matter how old it is, right?
Right. All right. Very nice. Now we have the other J. Or maybe Matthews was the other J and you're the real J. I don't know. We haven't decided yet.
Great. Thank you so much for the invite. This is just a follow-up to the first J on another CTO, but in a different circulation altogether. So this is a 75-year-old woman with class 3 angina and a history of atrial fibrillation. She has a known history of coronary disease, had remote RCA PCI, and subsequently had 4-vessel CABG. In 2011, she had presented with an acute coronary syndrome. Her Lima was patent. All the grafts of the lateral wall were occluded, and the vein graft of the RCA was patent. She had another acute coronary syndrome. Subsequent to that, about 6 months later, the graft to the right had gone down, and that was treated. About a year after that, the graft to the right was documented to be included in the RCA of the CTO, and I'll show you these pictures. So on the left panel is what she looked like with her acute coronary syndrome, and on the right panel is what she looked like after the vein graft was treated. This is at an outside hospital. And the big thing to look at is the configuration of the distal RCA, the crux. So this is sort of the PDA, PL, anastomosis bifurcation, and there's a stent in here, and there's a little trickle of flow in here. So this is going to be important as the case moves forward. This is what she looks like in August of 22 and in May of 23. RCA is occluded. There's a couple of stents in here. I can't tell exactly how many stents are in here, but there's severe ISR. And you can see that the distal RCA is filling through collaterals from the Lima to the LAD. You can see that there's a stent right here at the crux of the RCA. But again, this angle is really sort of the main point of the case, and what made this so difficult to do is because we really had a lot of challenges here. So she was sent to us for CTO management because of ongoing angina. The plan for us was integrated preparation using wire escalation. And we pretty quickly got through the first segment of stents, but towards the distal RCA, the wire started to look quite unusual. And we're suspicious that we're probably outside of the stent itself. And so you can see here that the guide wire is really not dancing with the distal stent. So the stent is down here, and we can see that the wire seems to have taken some other trajectory. So this point, the case has to be done retrograde. I think the antegrade wire has done it about all that it can do. So what are the retrograde options? So what we really wanted to do was get into S1. The reason I wanted to get into S1 is because it connects to the PL branch. I wanted to be in the PL branch because that would give me a more direct coaxial attack on the distal cap, which was in an old stent. I really didn't want to be in the PDA because that would require making a 90-degree turn at the distal cap, and I wanted to avoid that if at all possible. But there are obviously other options. The septal connections, S2 is okay, but it does go to the PDA. There's obviously the occluded graft itself, which has been stented. So these are sort of the options. So initially, we were unable to wire the LAD. Had a lot of difficulty even wiring the LAD because of extensive calcification, post-CABG patient. And jacketed wire could only get into S2. That's all we could get into. We could not deliver dual lumen microcatheter because of the extensive calcification in the LAD. So the initial plan was to perform rotational atherectomy, primarily to make some space within the LAD so that we could make the turn into S1. And unfortunately, a 1.5 millimeter burr would not cross. Patient developed profound bradycardia and hypotension, which we treated with an aminophylline infusion, as well as some atropine. And then we went ahead and used a 1.25 burr, which did cross, and then went back with the 1.5 burr to make a little bit more room. So now we thought we were in pretty good shape to get into the septal. But of course, no matter what we tried, we could never get into S1, only into S2, despite a fair bit of effort. So at this point, we had wasted a fair bit of time, so we decided let's at least try S2. Let's see what we can do in S2. So I went ahead and wired S2. I'll show you what happens next. So this is just the wire going down into the septal. And it pretty quickly crossed into the PDA. So this part was pretty encouraging. So we decided, let's just go for it. Did a tip injection through the microcatheter retrograde. So you can see, again, I need to make this 90-degree turn, which unfortunately was very difficult to do. We tried with a couple of different wires. We tried with Gladius Mongo, Gaia 1. We tried with some tapered wires, banded wire. We also tried with a stiffer jacketed wire called a Raider. Unable to cross this distal cap. And the patient subsequently developed a VF arrest. So we had to resuscitate her. It took a fair bit of time to get back to spontaneous circulation, but she did recover. Took a couple of angiograms to confirm that no complications had occurred, and she was fine. So the question here is, can we keep going? So she stabilized. So we decided that at this point, we've invested a lot of time and a lot of material. Let's continue on. We can keep going. She's stabilized. So I next went in with a Supercross 120 microcatheter, an angled microcatheter retrograde, to see if I could make that turn. Impossible to make the turn. No way to make that 90-degree turn. So then I thought, okay, let's wire the PL branch retrogradely and use that as a target. And then we can redirect the antegrade wire to see if we can get it antegrade. Unfortunately, we could never get the antegrade wire to meet with the retrograde wire. There was just too much plaque in the way and the stent that was in the way. So we could never make this work. So now the question is, what do we do? So at this point, we're really kind of desperate. And this is me just basically out of total frustration, just whipping the jacketed wire around. And somehow it found S1. After all this time, it actually found S1. So, you know, it better to be lucky than good, right? So I decided, let's go ahead and go for it. And we did select out S1 with a microcatheter and did a tip injection. And then she developed profound hypotension, requiring multiple aliquots of norepinephrine, and ultimately had to be put on a norepinephrine infusion. Thankfully, again, she stabilized. I took some angiograms to confirm, no complications. So she stabilized. I said, we should continue. We've put all this effort into it. Let's continue. We're finally into S1. So this is just a tip injection through S1. You can see it's quite tortuous, and it was not that easy to wire. It actually took a combination of Fielder XTR as well as Xi'an wire to ultimately wire this thing. It actually took a fair bit of time. It was not that straightforward. But ultimately, I was able to get into the PL branch, which was the branch I really wanted to get into because now I have a much more favorable angle of attack on the distal cap. So this is a jacket wire, Gladius Mongo, at the distal cap, forming a knuckle and making very good progress. Very, very happy at this point. And unfortunately, what ended up happening next is that the wire fractured. So the knuckle was retained within the distal RCA. The shaft of the wire came out of the body. So what next? What we decided to do next is to see if we could push the wire out. So the retained wire that's in the microcatheter occupies space within the lumen of the microcatheter. So I used a banded wire to 0.008 wire, and I advanced that through the same microcatheter to try to push out the material that was retained. And the wire was free. The wire pushed through all the way to the tip very freely. So you can see this is the second wire coming out very free. So at this point, I felt pretty comfortable with proceeding. And so we go ahead and did reverse cart. So this is doing reverse cart. So a 2-0 balloon, second Gladius, and the connection was made very efficiently. And we're very, very happy, except now the wire was frozen. So the Gladius wire would not torque, would not advance, would not retract, stuck, even though the reverse cart had been completed. So now what? So what we did next, since we had so much difficulty with getting into S1, is we parallel wired S1 with the second system. So this is parallel wiring S1 with the second system, and I pulled the first microcatheter out, and this is what came out. So you can look on the fluoro, the retained wire actually came out, and this is what we see. So the Gladius that I used to do the reverse cart is here. This is the broken Gladius right here. They both came out as a unit, fused together in the first microcatheter. But now at least I have a second microcatheter in the septal. With some difficulty, I was able to wire this again with a Xi'an. And since the reverse cart had already occurred, it was very easy to wire and externalize and perform reverse, the stenting. So this is the completion angio of the RCA. And since we had already done all this work and she felt well, we went ahead and finished off the left system. And this is the final result in the right and the left. Total contrast 180 mLs, 1.7 grade radiation, almost 6 hours of total procedural time. So the key the key learning points for the operator and the team are rotational atherectomy. I think is a great way to facilitate side branch access rather than compromising side branch access. I think it actually facilitates side branch access. So I use rotational atherectomy a lot for these types of situations. I think it's safe to go ahead and continue with the procedure despite these pitfalls. If you can stabilize the patient and the patient's doing well, it's okay to continue. Obviously, operator fatigue and frustration can play a role in these cases, and that can be mitigated by working as a team and certainly working with my partners, my advanced fellow. All of that has really ultimately helped this case get completed safely and effectively. Thank you.
Being your fellow about 6 years ago, looking at these cases bring back nightmares. So thank you for sharing all the tips and tricks.
All right, we're almost home.
All right, well, good afternoon. So this is literally the last session of the last day. So appreciate everybody's attention and time here. So I know one of the mantras of ARCH has always been to make complex angioplasty simple. So I'm kind of doing the reverse case here, how to make simple angioplasty more complex. Not intentionally. So case history, just briefly, this patient was admitted to a referring hospital, went there for a non-STEMI. They did a cardiac catheterization demonstrating sequential lesions of the RCA with a little bit of an anterior takeoff. There's only mild to moderate disease of the left coronary system. They attempted to wire this, integrate a couple of times, and were unable to get a good wire position, good guide position, so they aborted the procedure. And they transferred to us for more complex RCA PCI. So these are the initial angiograms on my iPhone. I think a lot of you people who get referring films, get them up from other hospitals. You see it on the iPhone. That's all you get. So this is what you get. You see a couple of views here. You see some eccentric lesions in the proximal and mid RCA. This is not a CTO for the CTO operators here in the room. Just heavy eccentric calcification of an anterior takeoff. They attempted radial. They subsequently converted to a femoral, you can see here, and they still were unable to get good wire positioning there due to kind of the acute angle of the proximal RCA. These are our pictures here. We just shot the left again. Theirs were a little bit subselective from the radial approach here. You can see on these pictures here. I'll kind of let them just cycle through here. Just mild to moderate disease, nothing to write home about. No major collaterals to the RCA of note, which will be pertinent a little bit later. So we thought, okay, relatively straightforward procedure. We'll go from a groin standpoint again. No need to try to reinvent the wheel with another radial access. For these complex cases, I get my usual package. I'll put a long sheath up. We've switched over to these 7 French Roadster with really hydrophilic long sheaths. We took an AL guide just to get a better positioning and anchoring in the anterior takeoff. And I was to start out with my package. I use a guide extension catheter. I prefer the trap liner so I can quickly get equipment in and out and not have to use the trapping balloon system in and out. I use a workhorse wire and then a microcatheter. Just go with all 3. So right off the bat, it saves a lot of time. Wire this very easily with my usual workhorse wire. This is Xi'an blue here, kind of a couple redirects at the second lesion there. You can see the heavy eccentric calcification in that middle picture there with the wire twisting around the calcium. And the second one here, just spinning the wire really easily, made it down there. We're in the true lumen. Okay, great. So we advanced our guide extension. We had a microcatheter at the time. This is the Corsair. Again, trying to get the Corsair through here, spinning, even with all the support that we have there with the guide extension, would not be able to cross this lesion. Tried for a while, got the wire even further down to make sure we had good support on a relatively soft wire, but with that amount of wire positioning, shouldn't be an issue of the wire support. It's more just the subtotal lesion and the concentric calcification. More twisting here. You can see us pushing on the guide, us kicking the guide out, even with the support of guide, still not being able to cross this lesion. So we're now getting to that algorithm of the wire across, gear won't cross algorithm for CTO operators in the room. So we switched out, tried a big profile balloon here to try to break it up to get better seat into the guide extension. We tried the lowest profile. We have the 1.0 sapphire balloon on the table. That would not cross. Tried to rupture that, do this so-called granuloplasty to create some micro fractures through the calcium. That did not work. You can see us pushing pretty heavily with these balloons here, trying to get something to go. Switched out for the different microcatheter. We switched out for a turnpike spiral, thinking maybe we need more body behind there. And again, you can see in the bottom that we're in the true lumen. It's a little distal side branch there. Still couldn't get anything to go. So about this point, we're like, okay, maybe we'll try to just free wire, RotaWire, and we'll just drill this thing and call it a day. But of course, a couple spins too many, tip breaks off. And then you could tell the tip I always recommend to my fellows, I didn't follow my own advice, is to keep the wire every once in a while when you have a few spins that's not moving. Try to move your wire in and out a few times to make sure you really haven't bound on the tip of that wire, especially with the Corsair, which has the softest tip. This was a turnpike, but still, nonetheless, still broke off, and now we're trapped in the subtotal lesion. So of course, now there's no collaterals. It's not a CTO. Now we added a microcatheter tip to the lesion. This patient gets hypotensive, bradycardic, you can see there. We quickly got a balloon pump in there, got a temporary pacemaker in there. You can appreciate more of the calcium here without the X-ray dye now. So what to do? So again, now we have a non-CO2 lesion. We're in the true lumen. Now we added more of a blockage. So now we have TIMI 1, TIMI 2 flow right now, and we're getting ischemic because there's no collaterals to this patient here. Now the patient's hemodynamically unstable. You'd hate to pull out your equipment right now, even thinking that maybe that microcatheter tip would come back with the wire, but then you lose your wire position. So we tried a parallel microcatheter system here. And so we took another microcatheter system. We just left the Xi'an blue down there, took a microcatheter. We said, well, either we get in that true lumen, but ideally we get subintimal. This is where we do this so-called subintimal cap crush here. So it actually wired pretty easily proximal. It's kind of hard to appreciate from the back of the room, I'm sure, but you can see in that middle frame there, the microcatheter is in a different plane. It's not overlapping the wire. So it's probably subintimal around the lesion there. And then just knuckle and probably start out into one of the marginal branches there. Okay, so now you can see here, this is a picture of kind of what Chaishi was showing earlier from the STAR trial here. If STAR, if you're not familiar, subintimal tracking and reentry, where you pop out into subintimal space. You push a little knuckle, this was a Mongo, and it popped into the True Lumen beyond there. Not that we're planning to use this, we already have a wire in the True Lumen. Our plan was just to do subintimal balloon expansion on the outside cap. Inadvertently, someone grabbed the manifold. We were talking about this earlier today. Sometimes we take off the manifolds, especially when we're doing CTOs. You little dissections to that spot. Not the end of the world because we're in the True Lumen already, and it may maybe even create a little bit of a Carlino dissection to help open the space anyway. So we got the external cap crush. We took an NC balloon, took some high pressure balloons. You can see here, really doesn't expand very well. It's kind of spiraling around the calcium here. So at this point, we said, you know what? We haven't tried this before. This first time we tried it, let's take a shockwave. So we took a 2.5 balloon initially, and then we took a shockwave. So we're doing shockwave in the subintimal space. First time we tried this, we figured that the shocks go three-dimensionally, 360 degrees, should have some benefit. We actually, you can't really appreciate in these films, and I'm sparing you all the IVL shocks, but we did see some good expansion, actually some fracturing of the calcium. You see more concentric spacing of the balloon and the wire lumen. So it's very heavy eccentric nodular calcium, give enough shocks and we're fine. So at this point, it was pretty interesting. So we had the microcatheter, tried to push it again with the balloon over the wire, and it actually moves. I put an arrow here that you can see the tip of the microcatheter. Now, it's hard to appreciate before, but you see the little dot there. That's the tip of the Corsair. And then the second picture you see, just with the balloon on the same wire, we were able to push it past the lesion, and now we're able to get the balloon through the True Lumen, through the cap, because of the external cap crush with the IVL. So now we didn't want to give up our True Lumen and the wire. We had the microcatheter tip on there, so we can't really use that wire, right? But we didn't want to just pull that. So now we pulled a Sasuke dual lumen, pushed the whole system past. We did have to, fortunately, the Xi'an blue, we pushed it way out. It's a safe wire, even looks a little funny in the distal PL branch, side branch there. Got another second wire down alongside, and now we're home free, right? Walk out Sasuke. We switched out for a supportive wire. The new microcatheter went down another turnpike catheter, switched out for a supportive wire. I'm a big wiggle wire fan, so now we're with this heavy calcium, we think we're going to be in for battle, so I wanted a supportive wire. So now we're like, great, case is done. I'm going to switch over, let my fellow finish the rest of the procedure. We just need to balloon this. It's already fractured. Maybe we'll put some stents in, right? Wrong. When you see these kind of pictures, it's never a good day, right? So now, because the patient had been hypotensive or ischemic for so long, the IVL takes a little while, and there's really no flow this whole entire time because we're blocking the True Lumen here. So now we're doing this really quickly here, trying to do some ballooning and stenting in between CPR, doing shocks and so on and so forth. You see people's different rings coming in and out here. So it's a long ACLS as the circulators are changing their CPR. The different ring here, you can see there. So we quickly put a couple, change a shift right there, switch out, they're sweaty. So we just put a couple long stents in, knowing, okay, it may not be the perfect result. We put 2 overlapping DES just to secure the True Lumen, get some TIMI3 flow going in there. The heartbeat's a little bit slow on the right-hand side. Of course, all the pressors, you name it, we're going in there. So now we finally get this now. TIMI3 flow, patient stabilizing, heart rate's on his own. We're not pacing, we're off pressors at this point in time, just a balloon pump, doing okay. So at this point, we said, okay, the patient's intubated now. We're bagging initially. Now the patient's intubated. You can see he's got interesting as the elevated hemi-right diaphragm there. Just thought I'd show you that. Still has a significant balloon waste because of all that heavy calcium. We hit it with some high pressure NC balloons. We partially fractured it before. And at this point we said, okay, enough's enough, and this is what we got here. So we're enough for one day here. Decent flow, had all the major distal branches. So at this point now the patient's stable, was a shocky and ischemic for a while. Now we took the time, pre-close, put an Impella in, put a Swan, got the hemodynamics, and this patient was put in the ICU. We were monitoring him for the next few days. But I really just wanted to show this as one of my learning points, that you really have to be prepared for anything. Stuff can happen, right? Even when you don't expect it. I thought this would be a relatively simple case. We maybe roto, maybe shock, maybe a very quick case. Earlier change out, when you feel that microcatheter stopping to spinning and a lot of tension on that, when you spin too many times and you don't move your wire in and out freely, switch it out. You get microcatheter fatigue. I've broken off too many after like one turn too many, and you're done. Potentially could have free wired with a roto wire earlier, right before that tip had broken off there. And as we always tell our team, the case is really not over until it's over. Last thing, when we brought the patient back from the Impella removal, a couple of days later, here's our shots here. Now we did go back and optimize. We know we're undersized, so we went back, did another round of shockwave, high pressure balloons, and we IVUS optimized here and actually got a nice result. So here's our final results here. Here comes the Impella, per-close that for my access and large bore closure. All right, thank you very much. Appreciate it.
All right, last but not least. So I like the newer roto wires, but that would have been difficult. I mean, potentially you could have, but that would have been difficult.
Hello, everybody. I'm Jeff, or Fellow, as the program would suggest. I have the last case for today. Thanks for all hanging in there. I have a case of stent fracture. So this is a patient, 63-year-old male. He's an extensive PCI history after he had a CABG way back in 1995, and we're going to go into that in a little more detail in a second. He was with hypertension, hyperlipidemia, and atrial fibrillation. So this is just a quick and dirty summary of his PCIs, and we're kind of going to start off at the very bottom one, which is in January of 2023. Now, all of these other PCIs were done to his right coronary artery and some of his OM grafts. So, you know, this guy has enough stents, but we did manage to find the only de novo lesion that he has, and to make sure that, oh, whoa, how did I do that? There we go. So just to make sure that what we're doing is actually going to help him, we go ahead and we do an IFR, and it seems to be hemodynamically significant, or something that we don't need to defer, and we do another, we put in a stent of that de novo lesion, and our IFR afterwards 0.97. Great. But as always, you know, we don't do things just by angiogram here. We always take a look at our post-IVUS, and this is just to prove to everybody that the post-IVUS looks pretty good. Now, you know, bad things that happen never happen at your hospital. And so this guy went out, and back in May of 2023, he went to some outside hospital where he had VF arrest, and he got, somehow they only did a PTCA to the mid-RCA, which they thought was ISR. Even despite him having VF arrest, they didn't put in a stent, just PTCA. So he comes back to us 3 months later, and he seems to have more stable angina. So let's all take a look at this angiogram here. Take some time to look at the angiogram before the contrast injection, and you can see in the mid-RCA, there's kind of this discordant motion of two parts of the stent. And so we're already thinking, you know, maybe he's had some stent fracture here, but, you know, let's figure out what's actually happening. So we go and we wire this thing. We actually have to double wire it because it's a little bit challenging to get in and out of it, so we need some extra support. And so we ultimately are able to get a Phillips IVUS catheter down, and you can see here, it's not subtle. He's got a stent fracture there, and it looks like there's probably some calcified nodule under there that's causing that stent fracture. So what do we do? Well, you know, it's a calcified nodule. So what we're going to do is we're going to take an IVL catheter. We're going to perform some shockwave therapy to it. And so we go ahead and do that, and then we go and put 2 stents. One, you know, we noticed that the osteoproximal segment was a little bit calcified and underexpanded as well. So we just, you know, hit both, but focus on the mid RCA for now. So here's our angiographic result, and here is our IVUS result. So it looks okay, right? You can still see back there, he's got a little bit of a protrusion inwards where that stent fracture used to be, but, you know, we say it looks good enough. We know he's got that stent fracture there. Let's go ahead and move on. But we're not done, because he comes back in October, and we look at this. I wonder what that is. So let's try to figure out what this is. You know, let's take an IVUS down there again. Looks like something is just protruding into our stent at this point. And so we're thinking maybe it's some kind of tissue prolapse that's being pushed in through the combination of that calcified nodule along with the stent fracture. So what do we do? Well, you know, if we don't think that the base problem, that calcified nodule, was taken care of, we're going to IVL it again. So we go ahead and we do that. And then we put in a covered stent this time, because we're thinking, you know, okay, so this has been a recurrent problem. There's probably something that's putting a lot of force and kind of squeezing that tissue through. So we put in a covered stent to the mid-RCA to kind of prevent future tissue prolapse of this. So this is a 5.0 by 15 papyrus stent. And let's go ahead and look at our IVUS.
And it looks enormous, huge, excellent, right? He's never going to have chest pain again, but we're wrong. So he comes back again. This time, you know, another elective coronary angiogram for this guy. He's filling out all of our RVUs. We double wire this thing. And you can see here, though, that it looks a little bit different than the last few times. It actually looks a little bit hazy, a little bit concerning for some thrombus. So we take our IVUS down there, and yeah, that's probably some nasty thrombus. And at this point, you know, we're all thinking, how has this happened? Because at this point, he's also, in the interim, he developed that atrial fibrillation that we discussed earlier, and he's on Xarelto too. So he's on Xarelto and he's on dual antiplatelet therapy. So how on earth is he getting this this thrombus? Well, I'm not 100% sure, but we go and just do the usual, which is, you know, we inflate a balloon in there, and then we put in a stent. And it seems like we have pretty good results. We're happy enough with that. You did see there was a little area of underexpansion, so we went in and did a NC Sapphire balloon to that area. And then we have a nice angiographic result, and so we move on. And then in January of 2024, finally he has a non-elective admission. He comes in with really crushing chest pain, unstable angina. And so we come and look here. Wow, that looks really bad. That looks almost like organized thrombus. So we actually stop here and we say, let's just infuse him with an integralin. So we give him 24 hours of integralin drip. We're also thinking at this point that this is pretty complicated. It's been complicated, and we only have a 6 French guide up there. You know, let's let him marinate and then come back after we've had some more time to plan what we're going to do. So we take him back 24 hours after the integralin. And this time, you'll notice that we have a different, more aggressive set of equipment. We take an AL sheathless guide, which gives us an effective 7.5 inner French lumen diameter. And we wire it with a 410 moderate support wire. And knowing that it's probably organized thrombus, we go ahead and we take a laser catheter down. And we perform some runs of laser atherectomy. And then we actually take an angiojet aspiration catheter and we try to get some stuff back. And we don't get too much back. So we go ahead and we're thinking, let's see what we're dealing with at this point. So it looks at this point, you see the thrombus, but there's also underneath it, there's something there. It's like an extrinsic compression. I'm not sure what's pushing something through, but something is definitely there. So what we do, we take a bigger angiojet aspiration catheter. We do manage to get some stuff out on this one. And then we're thinking, you know, this has been a case where there's just continuous protrusion into the stent, and there's some kind of extrinsic compression that may be causing an issue. So how are we going to fight that? How are we going to fight that force coming from the outside, pushing tissue or whatever into our stent? So we actually decide to take a self-expanding stent, which we use in the peripheral. It's a Pulsar 18 T3 self-expanding stent. So with quite a little bit of work, we managed to get it down there with sort of a 7 French guideliner coast, and we kind of unsheath that Pulsar stent, and we go and deploy it. And here we have a very nice angiographic result. To make sure that we've really got it, we go and we take our IVUS of it. And you see the luminal gain is excellent. You see that extrinsic mass kind of pushing in and out of the lateral wall of that stent there. But we think we've done a good enough job. We post-dilated again just to make sure that we're all happy, and then we go home. And this is, you know, one more time to just see the IVUS. You know, again, you see that extrinsic mass kind of pushing itself in. But we think, you know, at this point, the self-expanding stent will be the solution to this. He has some atypical angina back again in March, so we think maybe we're not done. It looks ugly, right? But now you take the stent, you take the IVUS, right? And you come back in here, and yeah, there's that mass kind of pushing in. But the luminal area is actually okay in this case. You know, in all the other cases, you've seen quite significant reduction in the luminal area. And so we decided to just say, let's not do anything to this. He's got enough metal in there. We just watch him. And to our happy surprise, despite being followed very closely in clinic, he hasn't had any more complaints of chest pain after a little bit of escalation of his anti-anginal therapy. So in summary, what did we have here? Well, we had a refractory ISR due to a stent fracture, likely due to some underlying calcified nodule that's pushing, like actively pushing stuff into the luminal area. Despite multiple attempts at IVL and even a covered stent, we didn't get the results we wanted. And finally, using a self-expanding peripheral stent, we were able to hopefully keep this guy out of the cath lab. Thank you.
So you had an 014 wire down. did you guys ever talk about, using like an exact carotid stent, one of the straight ones, not the tapered ones, for the closed cell, because you're trying to create a barrier versus the stent that you picked?
The sizing of peripheral stents, the carotid ones, they don't make it anymore. That's the problem. So the smaller ones, they used to be 3 millimeters, 4 millimeters and stuff. So we don't have that. So what we did is, this is a Biotronic pulsar stent, and it's 4 millimeters by 20. So it goes through 7 French guide the thing. So it actually works out very well. And you can see in IVUS, it actually pulsates and goes back, pulsates, goes back. So it doesn't fracture,
right?
Which is amazing. And that's what this patient needed, really, because it's a hinge point from bypass, and there's a calcified nodule behind it. So one part of the artery goes this way, the other part of the artery goes this way. We see that in some vein grafts, right? The hinge point. So it keeps on doing that all day, and it fractures every single thing you do, and balloon doesn't hold it. So we decided to do this because it's a last-ditch effort. He's obviously not a candidate for redo CABG, and so we went with it, and it actually worked out very well. He hasn't come back now. So Jeff, that was great.
Yeah, it's pretty amazing that you delivered it. You delivered a 018 self-expanding SFA stent, in that RCA. That was unusual. That was a great case. All right, so we are going to tally the votes here real quick. If the bingo winners want to come get their cards now and go see Anna Marie, she's got your prize.
Yeah, they actually gonna email you your gift cards. So just make sure, just touch base with them, and then you guys are good to go. Congratulations.
Because faculty members at Arch have too many conflicts, both Jays were disqualified. So
They are DQ'd.
they're disqualified. They're disqualified. So
That don't meet the standards.
so the third place goes to Jeff Tran. And Anna Marie will have we'll get your information and take care of the prize. Second was Yi Tao from China. And our winner is Dr. Matsuno from Japan. And on behalf of Jazz and all of the faculty, we really, really appreciate you guys hanging in there for the conference. We're going to continue to make this bigger and better. We appreciate our international colleagues coming in. I can't thank you guys enough. Please enjoy the rest of the evening, and we look forward to seeing you again next year.
Nothing like roots reggae music. music. Oh, oh, we're grooving. Nothing like roots reggae music. Now turn it up, I wanna lose it. Nothing like roots reggae music. Higher self meditation, the music brings upon me. Mixed with the healing of the nation. Well, now that's all I need. 'Cause it's the perfect combination. We're moving at our own speed. We're talking higher concentration. So keep it moving with me. Yeah, let me tell you now we're grooving. Nothing like roots reggae music. Now turn it up, I wanna lose it. Nothing like roots reggae music. Oh, oh, we're grooving. Nothing like roots reggae music. Now turn it up, I wanna lose it. Nothing like roots reggae music. Yeah, yeah. We're grooving. Feel the vibes of the music. It's alright. Oh, oh. 'Cause when the music all you stay out all night. Yeah, yeah. You wanna jump, you wanna shout, you wanna skank. You wanna shout it all about. I let the whole world know the music has got you. Oh, oh. We wanna move, we wanna groove, we wanna move, we wanna play it non-stop. We wanna move, we wanna groove, we wanna move, we wanna play it non-stop. Because you can't stop this feeling, you can't stop this groove, can't stop this music, you can't kill this mood. Music in the message in the music. Never leaves out in the right time, it'll give back. Well, let me tell you now we're grooving. Nothing like roots reggae music. Now turn it up, I wanna lose it. Nothing like roots reggae music. We're grooving. Nothing like roots reggae music. Now turn it up, I wanna lose it. Nothing like roots reggae music. Oh, 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 oh. Whoa, whoa. Oh, 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 oh. Whoa, oh, 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 oh. Whoa, oh, oh. All right, we're moving.